remove that suture anchor, then you need to pull the
Hello.
suture to look into stability of the anchor. This is a very important in the for the cuff, because in humeral head sometimes the bones are weak. So in humeral head sometimes the bones are really weak. So once or twice you can feel that your anchor is coming out. Okay. So that is very important. If the anchor comes out, there is no point in repair using that anchor. You have to find another place, or you can use a larger anchor and put it deep inside the subchondral bone so that the anchor remains stable. Stability of the anchor is the utmost important in repairing the cuff. So like this, you have to pull it like this, and then you start the retrieving the suture one by one. This is actually through the hole where from the lateral and the acromion where you have put the anchor, and then you need to retrieve one suture retriever. Okay. So you need to retrieve the suture from the anterolateral or posterolateral port like this. With one suture, ऐसे करके you retrieve it, and then you ask one of your assistant to hold the sutures like this, and we usually use the antigrade sort of sutures like this. What is the suture passer? This is Arthrotech suture passer, है ना? So you load it like this, ठीक है, and close it, and then you pass it from there, and then you usually take a bite, which is this is around 14 millimeter. Okay, so it is usually recommended to take the bite around more than 1 centimeter. So minimum of good tissue, 1 centimeter of good tissue has to be there. Okay, so then after that you need to fire it, and it is a self-retrieving sort of device. Okay, like this. Once you take out, the suture will automatically come out from the same port. Okay, then you need to fire it again outside and take that suture out. Okay, like this, you need to take the second bite. Okay, if you want to put a mattress, I usually put a meson alien type of suture in the cuff. Sometimes the tendon is usually weak. Okay, so if the tendon is really weak, you need to take a meson alien type of suture construct. In meson alien, we usually do a one mattress and one simple. Okay, this is a rib stop stitch, the second one. Okay, I'll show you how the meson alien works. Okay, so the second time the tiger sutures come out through the anterior port like this. And your every time you have to, from your scope, you have to be careful the suture is not getting unloaded from your anchor. Okay, these sutures which are fixed sutures should not move. You need to take out this like this. See, whenever you hold it from the anterior port, you are taking it, okay, so you are taking it out. So this suture should move. This suture should, sometimes this gets tagged. If this gets, you are pulling it like this. If this suture is moving, that means your anchor gets unloading. So like this. So you always have to keep an eye through your scope that this should not happen. Okay, so the suture which should come out is this. There should not be any movement on the anchor side. Okay. So then the second suture, second bite we will take like this. Okay, so like you need to take this bite a little deeper. Okay, than first bite. So we have taken 1 centimeter out there. Here we are taking the entire 14 millimeter out deep. Okay, and second bite we have taken. Then you unload this. Okay, like this. Then we will retrieve the second one will be the mattress like this. The quality of cup determines what type of suture, because if you use both the sutures as a mattress suture, you can cover larger area. Okay, but if you are using a meson alien type, you can cover a smaller area. So if the cuff is good quality, then you can use both the mattress suture. But if the cuff quality tissue is not that good, then you can use the meson alien type of sutures. Okay, like this. So this is the third bite. So then third bite you need to be very careful. You need to look at the underside also. These sutures doesn't get entangled. Very often these sutures get tangled. Then you enter the same port and take a bite which is far away, but at the level of the first sutures. Okay, like this. And then you need to see कि अंदर में कोई suture पकड़ रहा है कि नहीं पकड़ रहा है. ठीक है. And you fire it out and take that as well, like this. Okay. So for the Mason alien, I think your entire suturing is complete for one anchor. Okay, ऐसे करके. This is the mattress one. इसमें दोनों में बैठ के, and this one will be simple one. So what happens is actually in Mason alien we need to put this as a mattress. Glide cut. So this is the post. You need to sort in the post, and then I usually give the Nicky's knot to loop. Sorry. भूल ही गया like this, and then one more. And then you use your knot pusher like this, and then you pull it out and push it the other one. Okay, like this. First you need to shorten the loop as much as possible, like this. Once you see that the cuff is nicely sitting, and then you need to secure the knot like this after doing the pass pointing. ठीक है, अब ये knot loose नहीं होगा. ठीक है. Then you put a 1 and or 2 half hitches like this over that to secure the knot very nicely. Okay, one up and one down. Okay. I usually put 3 half hitches over the ear knot, and then you need to cut it like this. So what exactly I mean by the Mason alien, I will tell you now. Like this. Then you cut the sutures. Oh, front, no? Okay. Okay. And then this is what I meant by this thing. This suture is there in between. And now if you are putting a simple stitch, this even if cuts through the cuff tendon, the suture will stop it from the coming out completely. So there is an extra stability, rib stop stitch we call it. Okay, so this construct is called Mason alien construct. Okay, so whenever one suture is through the anchor, the other suture is through the tissue, like in banker, and the tissue suture is usually the post. So we have to shorten the tissue sutures like this. Shorten the tissue suture, the suture which is passing through the tissue. Then you put two in the sliding knot like this. I am using a Nicky's knot like this, and then you pull it here. The movement is a little slow, so the knot should not be on the lateral side. Knot should be just over the tissue. Like this, then you push it completely to shorten the loop as much as possible. Once you are happy that your cuff is sitting nicely, then you secure the knot by pass pointing. Pass pointing and your knot is secured. Then you put 1 or 2 half hitches over it like this. Half hitches should be always be an alternate half. एक ऊपर से दिए, the other one should be नीचे से, like this. ठीक है. So 3 हो गया half hitches. Then we'll cut the sutures. So this is one of the best suture for the cuff, because many times the cuff sutures are actually, cuff tissue are usually poor quality tissue, because 60-70 साल का उम्र में काफ थोड़ा डिजेनरेटिव हो जाता है. So this gives a very nice purchase. धरो धरो. Okay. Hey. Okay, like this. Then take it up to the knot and then cut it. Okay, this is how it looks. Now you can check it with your probe that your cuff is sitting nicely on your here and your loops are not loose. Okay, you can check करके then you can maybe then you can put on more anchor if you want. Similarly, you want to put better खुद करो एकदम. No. So for the peak anchor you need to do a pilot hole. The thickness varies. So depending on the anchor you need to put how much depth it is. ठीक है कत टप दिया जाएगा पूरा टप दिया था ऐसा देता है 5.5. अच्छा नो टैप करो जहाँ पे. हाँ चलो वही तो हमारा या और थोड़ा जानना पड़ेगा नहीं हार्ड आज. ठीक है ना you put the anchor. push it up to the thread. हाँ पूरा एकदम यहाँ तक जाएगा ब्लैक मार्क तक जाएगा. नहीं जा रहा है ना. you need to use a force. उतना नॉर्मल बोन में फोर्स नहीं यूज लगता है क्योंकि वहाँ थोड़ा वीक. दिस इज अ लिटिल हार्डर. हाँ अंदर जाओ सब कॉर्नल बोन में बरी करना होता है. बस बस बस. नाउ यू अनलोड द एंकर. यहाँ पे इसको somebody has to hold this anchor. ये हिलेगा ना तो एंकर लूज हो जाएगा. तो इसको पकड़ के you ask your assistant to remove the sutures. हाँ चलो नहीं दोनों. हाँ ठीक है. So the surgeon has to hold this anchor. हाँ अनलोडिंग अगर प्रॉब्लम हो रहा है तो सर्जन को हमेशा एंकर पकड़ कर रखने का. somebody else will do. ठीक है. now you this is the through the anchor then you retrieve one suture. ऐसे ऐसे नहीं यहाँ से पकड़ कर टैंगल. हाँ वहाँ से यूज द रिट्रीवर हाथ से यूज द रिट्रीवर. yes retrieve that. yeah. Now use your first anti-grade device suture tack. okay like this. you have to load the sutures. हाँ इसको साइड में रखो पकड़ो. हाँ ना then fire it. इसको बंद करो. इसको बंद. हाँ ना बंद करो. घुसाना होता है. बंद करो. हाँ then otherwise तो पोर्ट में घुसेगा नहीं ना. now you open it. yes. now fire it. hold it complete and then fire it. yes. leave it and then take it out. इसको छोड़ दो. switcher को छोड़ दो. okay then fire it once more. it will unload. fire it once more. fire. हाँ ठीक है. now your first switcher is done. now you retrieve the second switcher. first switcher चला गया. second is the tiger one. हाँ उसी को पकड़ लो. ठीक है. so I'm watching that this anchor is not getting unload. then you load the second switcher. लोड करो. हाँ वो नहीं तो ये बोला हमेशा ऊपर है. the shorter end should be on the downer side. ठीक है. चलो now you need to take this bite a little deeper. open it. yes. अंदर. हाँ चलो. take the bite. yes. चलो take it out. Good. Like this. Now you retrieve this third suture. Third suture is the white one. Yes. Good. No, this one. Yeah. Yes. And load it. Load it. Yeah. तुम छोटा रखना है, जहाँ पे नीडल से निकलता है वहाँ पे थोड़ा सूचर डैमेज होता है, सो वी डू नॉट वांट टू डैमेज द एक्चुअल सूचर. तो एंड में थोड़ा डैमेज हुआ तो प्रॉब्लम नहीं होता है. देन यू होल्ड, क्लोज इट नीचे से. हाँ, देन जस्ट ओपन इट्स. यस, एंड लिटिल डीपर, थोड़ा सा डीप. हाँ बस ठीक. चलो. या रिट्रीव दैट एज वेल. Okay, so all three sutures you have passed. Now you can use your, now yes, since this is a mattress you can use anyone as a post. ठीक है. चलो suture करो. दो नोट दे दो. हाँ, 1 2. यस, थोड़ा स्लाइड कर दो सामने. बस छोड़ दो इसको. हाँ, अनदर लूप और एक नोट. बस. यस, उसको भी स्लाइड कर दो. ज़रा टाइट नहीं करना. ठीक है. नाउ यू लीव दिस. नॉट पुश इधर. नॉट पुश. नाउ यू कीप ऑन पुलिंग इधर, एंड वहाँ पे लूप जमा हो जाएगा. इसको नहीं हटाना होगा तो. ठीक है. एक मिनट एंगल हो रहा है. हाँ ठीक है. चलो. ओके, पुल इट मोर. यस. इसको टान लोगे ना तो नॉट वहाँ पे टाइट हो जाएगा. उसको नहीं हिलाना. हाँ, नहीं, उसको पूरा सीधे पहले ठहरा. लूप को छोटा करना. You pull it completely so that yes. See the coffee sitting nicely now. Yeah, now you're happy that loop is shortened. Now you hold this one from other side, and then you do the pass pointing. Yeah, tightening. Yeah, now the knot is secure. This morning back. Yeah, this is how you should do. Okay, then do the 2 half stitches. Half stitches खोलना भी नहीं है, और 2 half stitches पकड़ी ना. हाँ, ऐसे नहीं. हाफ इंच सिंपल नॉट. यस दैट्स. इसको हाँ, इस शोल्डर में नहीं जाएगा ना. इट लुक्स इजी. हाँ ठीक है. इसको दिस नीड्स अ लिटिल बिट ऑफ प्रैक्टिस. देखने में लग रहा बहुत इजी है. चलो. हाँ, अभी हाफ इंचेस मारो लाइक दिस. हाँ, एंड देन यू होल्ड दिस. ओके, एंड देन यू पुश इट. देखो नहीं जा रहा है. हाफ. हाँ, इसके. चलो. यस. हाँ, गुड. अब पास पॉइंटिंग करो. यस. हाँ, अब दोनों को टर्नो. हाँ, गुड. एक और दे दो. एक और दो. अंडर, ये ओवर था, अंडर दे दो. हाँ, ये था, यही था ना. यू. हाँ,
हो गया होता
ना. चलो. हाँ, इतना ज़्यादा स्पेस है. थोड़ा सा मिलता है स्पेस अंदर में. हाँ, ऐसे एक नहीं बस. हाँ, इसको टाइम कर देता है. नॉट. हाँ ठीक. अच्छा ठीक है. इसको रहने दो. हाँ.
एक इंस्ट्रूमेंट है नॉट पुशर एंड नॉट कटर.
हाँ.
एक ही में.
ओके, सो कौन सा पोस्ट होगा? पोस्ट. हाँ, नहीं, दिस वन इज पोस्ट. सॉफ्ट टिश्यू में ये है ना, ये एंकर के थ्रू है. देन पुल इट. चलो. यस. इसको थोड़ा लूजली टाइट करते हैं. इतना तक आगे आप यू पुल इट. हाँ. पहले इसको छोड़. पहले टाइट कर दो लूप कंप्लीटली. पुल इट. हाँ, ऐसे टाइम कर. हाँ, एकदम कफ ठीक से बैठना चाहिए. यस, नाउ इट इज सिटिंग नाइसली. ओके, नाउ यू डू द पास पॉइंटिंग. पास पॉइंटिंग में नॉट सिक्योर हो जाता है. यस, वेरी नाइस. हाँ, हो गया. देन यस, हाफ इंच. गुड. पास्ट पॉइंटिंग. हाँ, ये मेसनलियन, ये रिप स्टॉप वो है ना, इसको कटेगा नहीं। हाँ हाँ। हाँ हाँ एक्सलेंट है, इसको काट दो। विल यूज सी, अगर दोनों हम लोग मैट्रिक्स देते हैं, मैं डबल रो करते हैं ना, तो ये तो सिंपल है, इसको ये यू कैन नॉट पुट अ डबल रो। लेकिन अगर ये दोनों को डबल रो करते हैं तो वी यूजली सपोज दिस इज ऑल्सो अनदर मैट्रिक्स स्ट्रेच, देन विल वो सेकंड वाला लाए हो क्या। सपोज मैं अगर ये मैट्रिक्स रहता ना यहाँ पे ऐसे लाइक दिस एंड देन दो यहाँ से, सो चारों सूचर अगर ऐसे 1 2 3 4 होता, देन वी कैन यूज अ मॉडिफाइड सूचर ब्रीज टेक्निक। सो एक इसमें से एंकर लेते एंड एक इसमें से एंकर लेते एंड उसको लैटरल, ये जो देख रहे हो ना लैटरल में से उठा हुआ है ना, इसको बैठाने के लिए बोलते हैं कि ये बैठा क्या कहते हैं सूचर ब्रीज टेक्निक, ऐसे बैठा देते हैं ताकि ये भी बैठा उठेगा और ये दोनों भी उधर बैठ जाएगा। ये दिस कीप्स द कफ फुटप्रिंट में पूरा टच किए हुए रहेगा जहाँ पे हीलिंग होगा। ठीक, लैटरल लो एनर्जी उसके लिए ऐसा नहीं होगा, देन यू हैव टू टेक ऑल द मैट्रिक्स। है हम्म
पैराशूट सूचर बोलते हैं, वो क्या है सर? पैराशूट सूचर,
पैरस पता नहीं,
रोटेटर कफ के लिए।
मुझे तो नहीं पता। ये दोनों है ना, नहीं চারটে একসাথে করে দেবো, ভালো লাগবে না দেখতে, দুটো আছে অ্যাঙ্কার। এটা তো বের করে রিইউজ করে নেবে, এটা চিন্তা নেই, এটা রিইউজ করতে পারবে। पायलट होल कर दिए तो देन अच्छा हाँ सॉरी, now you take this soldier, okay, then you put this, ये क्या होगा यहाँ तक घुसा देना होता है, देन उसका इस एंकर को हम लोग यहाँ तक डाउन कर देंगे ताकि ये सूचर को बोन से पकड़ ले ऐसे। ठीक है, लाइक दिस है ह्यूमरल हेड में लेटरल साइड और लेटरल मीडियल रो के एंकर के बाद हाँ ये यहाँ तक जाएगा वो, ये दिस इज मोस्ट इम्पोर्टेंट। यहाँ आगे चला गया, देन ये पूरा आउट द सूचर कि ठीक से बैठा हुआ है, समबडी पकड़ दे, फिर इसको कर दिए, देन ये होल्ड दिस वन, ये इसके साथ घूमेगा ना, सब कुछ घूमेगा, ये इसको पकड़ना होता है। ठीक है, एंड इसको अनलोड करना होता है। ठीक है, लाइक दिस एंड देन यू टाइटन दिस वन। लाइक दिस है, ऐसे होगी ना, देन इसको पूरा एंकर निकालने के, ये खुला हो रहेगा तभी निकलेगा। ठीक है, लाइक दिस है, देखो ये सूचर को कितना अच्छे से पकड़ लिया है, देख रहे हो। ये दिस इज अनदर एडिशनल सूचर दिया हुआ है, अगर इज नॉट रिक्वायर्ड यू कैन जस्ट अनलोड दिस सिंपली लाइक दिस, अनलोड लाइक दिस है। लेकिन अभी हम अनलोड कर लेंगे तो ये एंकर पूरा निकलेगा नहीं, विल रीयूज दिस एंकर, सो वी आर नॉट अनलोडिंग इट। ठीक है, सो यार अच्छी अंचे ना, ठीक। So by the time they are coming, we will put another pilot hole here. ঠিক আছে, আনলোড মানে অ্যাঙ্কারটা ইউজ করবে, বের করবে না, তাহলে এটা খুলে দিচ্ছি সুতরাং। হ্যাঁ, नाउ यू कैनॉट रिट्रीव इट, छोटा वाला जो एंड है वो, ये जो एंड है ये नीचे रह गया। क्या होता है इसमें, क्या होता है, ये छोटा वाला जो प्लास्टिक है ना, ये इसके साथ बंधा होता है। हाँ, आई कैन शो यू, धर बेटा, जस्ट इसको ये सूचा को पकड़ने के लिए है, एंड यू लाइक दिस, यू हैव टू अंडरस्टैंड व्हाट एग्जैक्टली इज द एंकर। हाँ, सी इसको पकड़ा हुआ है। ठीक है, देन विल डू दिस अगेन, ऐसे रहता है, एंड ये सूता है निकल नहीं जाए इसलिए ये गार्डर टाइप का है। ठीक है, लाइक दिस, एंड देन यू रिट्रीव द सूचर्स थ्रू दिस फर्दर। हाँ, ठीक है, लोड के लिए सूचर को, एंड देन यू पुट इट यहाँ पे थोड़ा सा लैक्स रहने से कोई ऐसे लैक्स है कोई ना, घुसा दिए, इट्स नॉट अ प्रॉब्लम। घुसाने के बाद व्हाट यू नीड इज पुल द इंडिविजुअल सूचर्स, ये टाइटन हो जाएगा अपने आप, लाइक दिस। हाँ, अदर वन लाइक दिस। देन यू होल्ड दिस वन, पूरा नहीं गया यहाँ तक, लेजर मार्क तो जाएगा ये यहाँ तक। हाँ, एंड देन यू होल्ड दिस वन। हाँ, এটা কত গো, এটা 10 মনে হচ্ছে তো গো অ্যাঙ্কারটা। एकदम बोन तक, सबकॉन्टल बोन तक चलेगा। एंड यू रिमूव दिस वन एंड this one, and he will come out. You can use this to for another note, अगर कहीं डॉग ईयर हो रहा है, यहाँ उठा हुआ है तो उसको देख एक सिंपल स्टूचर भी जैसे यू कैन यूज दैट एज वेल। लो, एक सिंपल स्टूचर देखे तो अगर नहीं लोग ये रीयूज करें फर्स्ट पर एक सिंपल स्टिच और दे दो। हाँ, छोटा सा। हाँ हाँ, चलो गुड, यस, थैंक यू। हाँ चलो, चलो। तो कौन सा उसका पोस्ट होगा? नहीं, सॉफ्ट टिश्यू वाला ऑलवेज। हाँ, यस, चलो। यस, हाँ, या, चलो, नॉट पुश कर दो। इसको नहीं डालना, खाली इसको डालना, जब तक लूप छोटा कर दो पहले। हाँ, गुड, सिटिंग नाइसली। नाउ उसको डाल लो, नॉट विल बी सिक्योर्ड। हाँ, गुड, यस। एक दो हाफ इंच दे दो। चलो, चलो, बस रहने दो। Now you need to cut it like this. कैसे काटते हैं? हेम पटी जी, ये नीचे। हाँ, ठीक है, पकड़ो, इसको काटो। ये यहाँ पे देखना होता है, साइड में नहीं जाना चाहिए, बीच में। यहाँ पे कटिंग एंड पे, वहाँ साइड में चला जाने से नहीं कटेगा, ये यहाँ पे रहेगा ना। हाँ, पकड़ो। साइड में चला गया, खुला हुआ। हाँ, हाँ, ठीक है, लाइक दिस। यहाँ पे काटना पड़ेगा। स्ट्रॉन्गेस्ट फिक्सेशन है। चलो,
हेलो, कब करें? अभिजीत सारा खरा क्या बोल रहा है? बैठना है। निकल गया पीछे रहा। So, good morning everybody. Myself Dr. Gurudev Kumar from Patna. Today I have given the responsibility to introduce this unique world smart test infinity femoral adjustable loop fixation device. This is a readjustable 11 millimeter diameter 3 mm thin femoral button. So during the ACL reconstruction we can readjust after fixation of the graft in the femur. Suppose we have adjust the graft to fill the entire femoral tunnel or shortness of the graft in the tibial tunnel, then we can again readjust with this device, reversible tap to adjust the graft in the tibia or in the femur. During the surgery, sometimes we land up in the problem. There is a flip of the button inside, or it go beyond the IT band. In that situation, this flip tap will help you to loosen the adjustable device, and again we can adjust accordingly. During it has two thread. One this one is the adjustable loop, and this one is the tiger wire. During passage of the graft through the tunnel, you can hold all the four thread to flip it outside the femoral tunnel. Then hold this this white tiger wire to flip it in outside the femoral tunnel. Then hold this blue thread wire, and then pull this blue wire so that you can passage the graft inside the femoral tunnel. This is the fixed one. Suppose I readjust it, then can pull this. Yes, now I can see here the graft is loosened, and again we can adjust it according to the tunnel size. Thank you. If anybody is interested, then join with us here. So how to adjust this loop button while doing the ACL reconstruction? Yes, sit down here. Now.
तो आपने यहाँ पे ग्राफ्ट फंसा है, आपने यहाँ पे ग्राफ्ट फंसा है, फिर आपने पूरा खींच लिया, ये फेमरल साइड पे आ गया, ठीक है, आपने बैठ गया, ना आपको ग्राफ्ट को छोटा करना है, तो ये आपका ब्लू है, फुल हो गया, यस, छोटा हो गया.
Then how to make it again readjust it?
वापस जो है ना, रिवर्सल टैप, वो वापस हो जाएगा.
No. You can adjust it accordingly. Tibial set से बाहर आ जाएगा. Yeah. This is the only provided by this company. This is not provided by other company. इनिशियली 4 को पकड़ना।
बटन आपका कार्टिक से बाहर है, ठीक है। अभी ग्राफ को छोटा करना है आपको,
ब्लू वायर।
अभी नहीं है बोलती फिक्सेशन नॉट में गैप हो रहा है, अदरवाइज जो फिक्सेशन नॉट के पास है यहाँ पे तो मैंने ठीक है होल्ड नहीं करता है ना आपकी चीज़ को ब्लू वायर इसको छोड़ दीजिए, एक मिनट खींचिए ब्लू वायर, खींचिए इसको छोड़ दीजिए, बस छोड़
वो
दीजिए,
टाइट नहीं है ना इसीलिए
ये फिक्सेशन लॉक,
वो अगेन लेन देन हो गया।
आपको कुछ नोट करने की जरूरत है, जस्ट इसको काटना है। And the diameter is 3 millimeter.
And 11 millimeters the length.
Because we call it infinity at extreme.
Reversible tap.
Actually यार कुछ नहीं है
इसीलिए वो फंस गया।
पिन डाल के हो जाएगा आसानी से। And the one more important thing here, what I have faced during initial 1 or 2 cases. So after finishing the entire procedure of ACL reconstruction, unfortunately I did not cut it. Okay. So once the everything is coming outside the tibial tunnel, what I think now I have to cut all the residual thread, and ultimately I land up in the problem. I pulled this adjustable tab also, so the entire button, everything came inside the joint, and I have to revise the surgery on the table. So
that is the advantage of
so it is keep in mind. Yeah, you can readjust. This facility is not provided from the other company. ठीक है? Anybody? नहीं ना? नहीं ना, हो गया ना? हो गया ना? Close? Rajiv sir? Close? Okay, thank you.
Hello, good morning everybody. Today, day 2 of IAS Saarc Sportsmedcon. It's a shoulder day, and we have some master techniques, surgical technique sessions also in afternoon. So without wasting our time, I would like to invite our chairperson, Dr. Nirav Kayastha from Nepal. Please, Nirav. And Dr. Pratap Kumar from Cochin. Please, sir.
Good morning, everybody. Welcome to the morning session. So we have a shoulder session today, and without wasting any time, we'd like to call Dr. K.N. Subramaniam sir for the first speech of the day. First time dislocators, ideal approach. Please, sir.
Good morning. First of all, let me thank the whole team Kolkata for organizing such a wonderful conference, and thanks for inviting me. And today on the shoulder talk, first thing they want to talk to me about is about the first time dislocator, what will be the ideal approach. I think this is a very common problem that we all come across, what to do with the patients coming with first time dislocation, whether to advise them for surgery or not. But I think there are certain facts that we need to understand. First thing is, when you have a patient with stable shoulder, the head of the humerus is centered well on the glenoid. When they have the first dislocation, what happens is the labral tissue gets damaged and the head of the humerus becomes off-center from the glenoid because of loss of tension between anterior and posterior structures. This is a very basic problem that occurs in all the shoulder dislocation, that someone has to understand it. And very important message is, pathology is certain. What I mean by that is, anyone having a dislocation, almost they will have a labral tear. And it has been reported in almost 97 to 100% of patients will have labral tear. I'm excluding the patients who are coming with the multidirectional instability because they are dislocated because of laxity. All other patients will have some form of labral tear, and there may be a heel sac also. So this is what the very first understanding that we have to understand. So what I mean to say is, at first dislocation result, dye is cast. The pathology has occurred. Whether it heals or not, that is a different issue, but there is a definite pathology. And if you look into the bone defects, if you see the last one over there, no heel sac and no glenoid defect is only in 0.8%. All the others will have some kind of bone injury, and those who are having no heel sac will also have a bone bruise. Every person who has first time dislocation will have a bone bruise over there. They may not have a defect, but there will be a bone bruise. So this is almost certain also. So this is something we have to understand that. So what is the next issue in first time dislocator is whether they are going to recur and are they going to face the complications of recurrence. There are plenty of literature about it. I just thought I will take one meta-analysis which covers in about 1,324 participants, and the study is published some 5-6 years ago itself. First thing is age. If age of the patient is lesser, like around 20-year-old, the chances of recurrence can be even up to about 70 to 80%. Next thing is, males have a very high chance of dislocating again when they have first time dislocation. And those who are having contact sports or collision sports, that kind of individual, there has been very well shown to have a higher chance of recurrence in comparison to the conventional normal population. And those who are having ligamentous laxity has been shown to have about 3 times more likely chance of having dislocation than a conventional population. This is the fact, and just summarize you this one. 20-year-old, male, athlete, ligamentous laxity, and certain specific things like bony Bankart. Where a significant bony Bankart displacement, then there's also something which is indication for early intervention. That is the first thing. Next, to go for complications of recurrence. So if a recurrence of dislocation occurs, then there is going to be changes in capsule, changes in labrum, and there is going to be possibility of degeneration in the glenohumeral joint. And there are multiple evidence about it. First is mechanical study, which has shown that repetitive microtrauma increases the strain of the capsule, which means the capsule will not be of normal length if they keep on dislocating again and again. So if a capsule deforms, that has been shown in the biomechanical study. And then there are also associated lesions start occurring when they have recurrence of dislocation, like slap, alpha lesion, anything, there are so many variants that can occur if they are keep on recurrence of dislocation. And I want to highlight our own study, where already been published about this, what the changes occur in the capsule and labrum over a period of time in patients who are having recurrent dislocation. And our study showed, we evaluated the morphology of capsule, labrum in recurrent shoulder dislocation, and we tried to relate it between the number of dislocations and the appearance of the capsule and labrum. And we had 108 patients over a period of 18 months, this one. And the range of dislocation from 1 dislocation to up to 30 dislocation also we had. When we divided like patients who are having capsular appearance and labral appearance, capsule may be normal or looking deformed. Labrum will be normal looking labrum or a desiccated labrum or a shredded labrum. We divide into 3 categories, and at the end we had like normal capsule, normal labrum, normal capsule, desiccated labrum, normal capsule, shredded labrum, like these 6 varieties are there. And just to show some example how it looks like is, this is a patient who had 1 dislocation only, his capsule and labrum looks almost near normal without any big deformation. That's the thing that you will look in the patients who are having like single dislocation like that. Our numbers in 1 dislocation were very less. We had only 3 patients who came for surgery in first dislocation itself out of 108 patients. But all the 3 were having something like this only, good labrum, good capsule. And somebody having 3 dislocations, they look, capsule was normal, but labrum was damaged or desiccated labrum. So that is a kind of appearance in patients who are having 3 dislocations. This is like 8 dislocation, where a capsule may be looking normal, the labrum is almost disappeared. We can't see the labrum, it's a shredded labrum. So this is another category. And then somebody 10 dislocation having a normal capsule, but the labrum, the damaged capsule, but the labrum doesn't look normal. Labrum looks deformed like that. And 15 dislocations having a capsule deformed, and even the labrum also looks desiccated. And the next one is like more than 20 dislocations we are having deformed capsule and also shredded labrum. So this is what the 6 categories we had. And if you see this one, those who are having 1 or 2 dislocation, the chance of having normal capsule and normal labrum is very high. That's what the inference of the study. So more the number of dislocations, more chance of labral morphology alteration. None of the patients where the surgery was done at the first dislocation had capsular damage. So that makes it clear that capsule damage starts occurring after more dislocations. And more the dislocation, there is loss of morphology of glenoid labrum and also capsule, with our findings showing damaged capsule and damaged labrum variety in those who are dislocating more, like more than 10 dislocations, they have much more severe pathology. So, and next information is arthritis inevitably occurs in those who are in recurrent dislocations. So the message to convey is, does number of dislocation matter? More the number of dislocation will damage, labrum will damage, capsule will cause degenerative changes. There is no doubt about it. It's definite. But in spite of all the fact that we know, still we keep practicing in a different way. This is a survey done in UK about acute first time dislocators, and can see that more than 80% will opt for conservative management after first time dislocation. I think it may be because of lack of understanding of the full concept of what is happening inside the shoulder joint. But at least the whole caveat behind is that there are some group of patients who do not dislocate at all after having first time dislocation. So in order not to over treat them only, we are avoiding surgery. But about 70 to 80% will dislocate. There is 20 to 30% may not dislocate at all. So we don't want to over treat them. That's why we are not advising surgery for all those patients who are coming first time dislocation. But the take home message I would say is, so we know that pathology is certain. We know there is high chance of recurrence in certain group of individuals like young age, athlete, male, lax individual, who are having associated lesions, who are having bony Bankard, hill sac, they have high chance. And capsular deformation, labral alteration is and degeneration are inevitable in all patients. So make an informed decision. So whenever any patient comes with first time dislocation, my approach is advise CT and MRI for all. Because even in the younger age or older age, in the older age you can miss rotator cuff tear, we can miss bony Bankard, which can be 25% lesion. You want to go and address it straight away. So advise CT and MRI for all the patients who are coming with first time dislocation. And then those who are in the risk category like younger age, male, athlete, or ligamentous laxity, displaced bony Bankard, traumatic cuff tear, then you advise them more towards surgery and see whether they get convinced. But in real practice what happens, they don't get convinced for surgery in the first time dislocation. But it's our duty to come and explain to them and tell this is a fact and make the patient understand the facts and decide about surgery. This is what my message for today is. Thank you very much.
Thank you, Subra. It's a never-ending question, isn't it? We always discuss about, and we don't know the answer. Can I ask you about one paper? When we were in training, there was a very infamous paper, arthroscopic washout.
Washout,
you remember that?
Yes, yeah.
Yeah.
This is Dr. Pratap is telling about a paper which has been published saying that increase of capsular volume will cause distraction of the labrum to the glenoid, hence it may not heal at all. So there is a paper has come saying that arthroscopic lavage after having a first time dislocation will reduce that volume, hence there is a chance of healing. But I think it has not proved its consistency. It's not a very good procedure to go ahead. Doing just a lavage for first time dislocation is not a good procedure to do.
I think with the due respect to all knee surgeons, it was done by a knee surgeon and it was published in the Journal of Knee Arthroscopy. You remember that? I'm
not very entertaining that one because sometimes it might look like a sham surgery also.
Anyway, you are going inside.
Yeah. Then, so when you go and see a pathology, you just do a washout and come, doesn't look fair.
One more thing I'd like to add is if you look at the recurrence in a dominant side, it's probably going to be close to 85-90%. On the non-dominant side, it actually might be maybe 60%. So that also should be a decision maker. So if it's a dominant side affection in a 25-year-old, you can be sure that it's a 100% redislocator.
So the messages have to go on a patient-to-patient basis. Yeah. But the understanding is improving now.
ISS score correlates with the, whether first time dislocator with ISS score or more than, 4 or 5, you would like to go in for the operation or something like that? Does all those criteria like contact sports and less than 20 age and very high chance of recurrent dislocation. So can we select some of those?
Yes, ISS score is a Pascal Boiler's concept where he tells about 6 variables: age, ligamentous laxity, contact sports, and hill sac and glenoid. Yeah. And each carries 2 points, I think. Anyone scoring more than 6 points, inevitably they are going to have a high chance of recurrence, and he will advise including a bony procedure for them directly. Yeah. Yes, I think that is one way of determining it. And if you see that whatever risk factors which I have put, they all come into the ISS category only. Yeah. So if all the categories are present, then they are going to have high chance of dislocation. Advise surgery at the outset itself.
Yeah. And also, if you look into the Itoi's study, which says that if you look into the bony Bankart incidence, the Itoi says after the CT scan, you probably see the majority of the patients will have some sort of sleeve or bony avulsion, may not be significant. So, as we know that the bone heals better if you can reduce it and fix it for the first time. So, does that study influence the first time dislocator as well? I mean, may not be significant bony involvement, but since the bone is there with the labrum, probably you can go ahead and repair it early.
A bony Bankart in a first time dislocator, if they are having more than 25%, for example, involvement, and if it is displaced, then I think they need repair straight away. Because it is going to have a malunion at the end, and they might going to have a recurrent dislocation where you will need a lethargy at one point. But if it is undisplaced bony Bankart, you don't have to do anything at all, it will heal by itself. Undisplaced bony Bankart. Because they may not recur at all. Undisplaced bony Bankart is a different scenario.
So I think undisplaced bony Bankart would be a better prognostic sign actually.
Yes.
So they'll heal much better than simple pure ligamentous lesion.
Provided it heals.
I absolutely, that was an excellent presentation, Subra. But the important message that Subra said that probably we need to investigate first time dislocator more aggressively than we are doing at this moment. So many of us, we just ignore first time dislocator, just reduce. Once it is reduced, we think that our job is done until unless he has a second dislocation. So probably if we start investigating them in detail, then we start identifying what are those things or more indication for doing a, fixing a first time dislocator. If you do not investigate a first time dislocator. So when I was in army, I started fixing the first time dislocator, and you'll not believe that these people, those first time dislocator, if you do them surgery in first time, the chances of returning to the military activities are higher compared to not doing on, fixing the Bankart repair in the first time dislocation.
I think what is being a very important point. The mindset of general orthopedic surgeons is when they come with, anyone comes with first time dislocation, they will reduce and send them home. Please give some advice to them about CT and MRI straight away. Most of the patients might accept and get it done also. Once they have a finding, then you can actually sit and talk to the patient about what the pros and cons about. That is the next step forward in these patients.
Sandesh.
Yeah. So the other point I wanted to ask you is about, do you find patients who come with more dislocations, even if they don't have this hyperlaxity on the initial presentation, I mean they don't have inherent hyperlaxity, they develop a significant amount of dyskinesias, especially, I mean, I'm seeing more and more in the practice when we see patients having 10 dislocations, 12 dislocations, and when they actually come to you for treatment, they actually more often complain of periscapular pain as well as these dislocations, and they also have this abnormal rhythm. Do you think that would play a part in the outcome, especially when we are treating them not in the early stages of 1 or 2 dislocations?
Scapular dyskinesia causing recurrence?
No, scapular dislocation which is secondary to the instability that the patient is experiencing over a period of time. Because in our practice, at least, when we actually see the 6th or 7th dislocator, when we actually come into the clinic, when we examine them, they always have some element of this abnormal rhythm, and we actually put them to a rehab before we actually, when we find this associated dyskinesia.
I will put it this way.
Yes.
The problem is, anyone having shoulder problem will immediately develop scapular dyskinesia. It's more common for the cuff problems and also for the adhesive capsulitis, but I can't say it won't occur for dislocation. It can occur for anything, because scapular dyskinesia, first thing we have to look for in any patient coming to any shoulder pathology, and we have to correct it. That will help out for the rehab, pre-op as well as post-op also. That will form a definite important role also, scapular dyskinesia, yes.
Sure.
Thank you, sir. That was very nice presentation and good discussion as always. Going on to the next presentation, sir. Thank you. Next presentation is by Dr. Harpreet Singh, bone loss in recurrent shoulder instability. Please, sir.
Thank you. Thank you, Team CAS. Thank you for having me at this landmark and prestigious conference. Kolkata almost feels like a second home now. Been so many times to Kolkata for different conferences. So I'll be talking about bone loss and shoulder instability, and I'll be mainly focusing on attritional bone loss. So we know that bone loss can be there on the glenoid side or the humeral head, the Hill-Sachs lesion. And the latest concept is about talking about the bipolar lesions or combination of both glenoid and humeral head bone loss. So we have had different papers. So historically, instability has been treated mainly with soft tissue procedures, the arthroscopic Bankards being the gold standard. But we had a very large number of literature telling us that with bone loss, with increasing amount of bone loss, the risk of instability even after a soft tissue procedure is very high. Chances of recurrence are very, very high. So how does a glenoid bone loss alter the biomechanics, or what is the significance of a glenoid bone loss? So the landmark paper by Stephen Burkhardt, the inverted pear-shaped glenoid, this tells us that if there's a glenoid bone loss, there's a much higher chance of recurrence even after a Bankards, and a isolated Bankards repair will almost fail. But this inverted pear-shaped glenoid is just a subjective appearance. We don't have any objective way of telling us how much is the bone loss. Even Christian Gerber in this landmark paper in CORR told us that as the glenoid arc, anteroinferior glenoid arc is lost, there is exponential increase in the resistance to dislocation. So loss of glenoid bone would lead to much higher chance of instability, recurrence of instability. We had many more papers like by Burkhardt, by Malone, and they all came to a concept of that if there is a glenoid bone loss of about 25% glenoid width, that is the point where a soft tissue procedure would not work anymore. And they defined as 25% of glenoid bone loss as a significant or the critical glenoid bone loss. Humeral head defects also, we had lots of literature. Boileau said that with increasing large humeral head defects, the instability increased. Sikaya told us that more than 25% of articular surface area, if Hill-Sachs involves, there is increased chance of instability. And in 2007 came the landmark paper by Toy talking about the concept of glenoid tract. I'll just talk about the concept of glenoid tract later on. So this is all about theory, but when do we suspect a glenoid bone loss? When do we suspect bone loss in a patient with instability, so that we can plan our treatment accordingly? So if there is a history of a large number of dislocations, or there is a history of mid-range, or on examination there is instability in mid-range of abduction and external rotations, or in the history there is instability with activities of daily living, or when the arthroscopic capsulolabral reconstruction has failed, or there are multiple recurrences within a short time frame. All these would lead us to think that yes, maybe we are dealing with a patient with a bone loss and we need to investigate accordingly. Also, in investigation, if we see a glenoid bone loss, we suspect a glenoid bone loss either on the X-ray or MRI, or if a large Hill-Sachs is visible on MRI, we should investigate further. And what is the gold standard for investigations for such patients is your CT scan, NCCT CT scan with 3D reconstruction. We are looking mainly at the end face view, and then we are trying to calculate the glenoid bone loss and look at the humeral head bone loss. On CT also there is lots of methods which are available to calculate the glenoid bone loss, but I think we have come to a consensus that PICO method based on the contralateral intact glenoid, that is one of the best methods. Glenoid index is also a good method to calculate the amount of glenoid bone loss. So just talking about the PICO method, in this, when we do a CT scan, we have both the shoulders available to us. So what we do is make a best fit circle on the inferior portion of the contralateral uninjured glenoid. So we get a We look at the uninjured glenoid, make a best fit circle there on the uninjured glenoid and superimpose it on the injured glenoid, and then calculate the percentage of bone loss using just your software. Glenoid index is calculated from the width, normal width versus the injured width. It's a ratio of the injured width versus the normal width, and if greater than 0.75, we're thinking of it as a significant glenoid bone loss. So what is significant glenoid bone loss? Just reiterating, glenoid width loss more than 25% or glenoid surface area loss more than 20%. I think we don't use this length as a major criteria these days. So width, glenoid width more than 25, loss more than 25% or surface area loss more than 20% is labeled as significant, and we need to address it accordingly. So if there's a subcritical glenoid bone loss, arthroscopic Bankarts usually works. If there's a critical or supracritical glenoid bone loss, we usually go on to a bony procedure, which can be a letarge, which can be done either open using the Walsh or the congruent arc variation, or a arthroletarge, which is becoming popular these days. Or a lot of surgeons also prefer doing a Eden-Hibernate procedure using a iliac crest bone graft and reconstruct the glenoid bone loss. So we need to find out the critical, if the glenoid bone loss is in the critical range or less than critical range. Talking about the humeral head bone loss, so in this landmark article talked about the glenoid tract. What is glenoid tract? In the end range of abduction external rotation, the glenoid, the humeral head, the glenoid articulates with posterolateral part of the humeral head just next to their rotator cuff insertion, and this is labeled as your glenoid tract. This has been shown in live patients as 83% of the glenoid width. And if your Hill-Sachs lies within this glenoid tract, if the Hill-Sachs is within this glenoid tract, this would be labeled as an on-track lesion, or what we used to call as a non-engaging lesion. So this would not require any further procedures for addressing it. So if the glenoid Hill-Sachs lies within the glenoid tract, so that is called the on-track lesion. Just to understand it, we can use a simile. Like Dr. Rajiv is driving his BMW X5 on the road. This is a picture when Rajiv still had a lot of hair while he was in Delhi. So he's driving his X5 on the road. He drives very next to the median of the road. And if there's a pothole on the road, so if it's a small pothole next to the median, there would not be any instability. I know his suspension is well tuned, but just say that if suspension is not well tuned and there's a small pothole on the road, and if his big 325 mm 18 dia tires cover that pothole, there would not be any jerk. So that is a on-track lesion, which would not require any further looking into. But if the pothole is far away from the median, there would be a jerk. So this is an off-track lesion. If it's a large pothole, more than the dia of his big 18 inches tires, again there would be a jerk. So this is an off-track lesion. If it's far away from the rotator cuff insertion, it may be an off-track lesion, or it's a big Hill-Sachs, it would be an off-track lesion. So how do we calculate? Can we calculate if it's a off-track or on-track lesion pre-operatively? Yes, you can do that. You calculate using the CT scan with ends face view. You can calculate the glenoid tract, which is 83% of the glenoid width. If there is any bone loss, you minus that bone loss. So 80%, 83% of glenoid width minus the glenoid width loss, that gives you the width of the glenoid tract. Then you calculate the length of the Hill-Sachs or the width of the Hill-Sachs lesion, calculate the bony bridge of how far it is from the Hill-Sachs is from the rotator cuff insertion. And if you add the second and the third lesion measurements, you get the Hill-Sachs interval. If your Hill-Sachs interval is more than glenoid tract, that is a off-track lesion, and that will require a further addressal. How do you address this? So we have various methods to address this. The most commonly and the most famous one these days is your remplissage procedure. What do you do in remplissage? Remplissage was described by Wolf et al. In 2007. It means to fill in. So what we do is we use the infraspinatus and posterior capsule, and using anchors we fill the Hill-Sachs defect with using a posterior capsulodiscs and infraspinatus tenodiscs, so that this Hill-Sachs becomes an extra capsular lesion and it doesn't cause any engagement or instability anymore. Then came the concept of addressing both the lesions. So Giacomo, I think first time in 2014 talked about this bipolar lesion concept. So how do we address if both Hill-Sachs and glenoid bone loss are there? They gave us this beautiful 2x2 table. If the glenoid bone loss is less than 25% and Hill-Sachs is on track means it's a good lesion, doesn't require further addressal. A simple soft tissue arthroscopic Bankarts would do very well. If the Hill-Sachs is off track with a subcritical glenoid bone loss, you can just add remplissage to your arthroscopic Bankarts. Remplissage is always an adjunctive procedure done in addition to a Bankarts repair. If the glenoid bone loss is more than 25%, with a on-track Hill-Sachs, you do a Latarjet. And even if the Hill-Sachs is off track with a more than a supracritical glenoid bone loss, usually a Latarjet suffices. We don't have to add remplissage to it, because Latarjet increases the glenoid width and makes a off-track lesion a on-track lesion. So just to summarize, in any patient of shoulder instability, if there is suspicion of glenoid bone, any bone loss, you should always analyze CT scan with 3D reconstruction using the end-face view, and doing your calculations is the gold standard method, and we have proper guidelines available to us to formulate our treatment plan. Thank you. I hope I could make you understand this simple topic.
Excellent. That is very nice presentation. Harpreet, it cannot be more simplified than this. Okay, and like your BMW and Rajiv equation there. Just out of curiosity, what is this tetra hand surgeon?
Tetra hand surgeon is using tendon transfers to help with tetraplegia patients.
Okay, fine. I thought you were working in 4 different hospitals or something. I don't know. Sorry, my ignorance. Second thing is this. We are more and more aware of on-track, off-track now, and we have lowered that standards, that volumetric loss of a glenoid, isn't it? Previously, we all agreed for a 25% bone loss. Now we have agreed, the shoulder surgeons, there is an agreement that we have lowered it to 15% in the newer literature. What do you?
So yes, lots of literature are coming in. I think we're still trying to form a consensus on if we want to go lower than 20% or not. So I think maybe it's just orthopedics cannot be just pure mathematics. So you just cannot go only by numbers. You have to take more factors in your mind when you formulate your treatment plan. Age has to be one of the important factors. Activity level of the patient has to be important factor. So if the patient is a athlete, overhead athlete, contact athlete, even less than 20%, 15, 10%, you may think of doing a bony procedure. And if it's a sedentary worker and is not involved in sports, I think 15% would be will be too aggressive doing a bony procedure on such patients.
So that's a patient-centered one, isn't it?
Yes, you have to take into their lifestyle and their age into consideration also.
Thank you. Any questions from? Yeah. Sandil. Yeah. Can you use the other microphone? Yeah.
Now that we are finding, less and less problems with the remplissage. Obviously, initially it was thought that it will limit external rotation. It has been shown that it doesn't limit external rotation, even in athletes. So, and more surgeons are doing remplissage if they find a Hill-Sachs lesion. Obviously, the concept of track. So, what's your opinion on this? Because then, if we are doing Hill-Sachs remplissage for most of the patients, when we see a Hill-Sachs lesion, irrelevant of whether it is track or on track or off track, then only decision would be whether to do a Latarjet or Bankart plus remplissage. Yeah.
So I think addressing every Hill-Sachs would be overkill. It would be like fixing every fracture whether it's displaced or undisplaced. I don't think so. Yes, I think maybe it's still evolving concept. This remplissage and which all Hill-Sachs do we address? But I think this concept is quite useful. The on-track, off-track concept, and even subjectively, when we do our Bankarts, we can always analyze whether it looks engaging in Hill-Sachs after addressing the Bankarts lesion. Because when we I think it's important to address after doing your Bankarts, because before Bankarts, because it's still loose, the capsule is still loose. Most of our Hill-Sachs may or will engage with a glenoid. So I prefer to do only for a big Hill-Sachs which are off track on your pre-operative imaging. So I would not do it for all Hill-Sachs.
Yeah, if I can add one more, yeah, I think that's a very relevant question you asked, and every Hill-Sachs, every Bankarts will have a Hill-Sachs, isn't it? Everyone knows that. But whether that needs to be addressing, that is the million-dollar question, and that will be done only on the operating table during surgery. Whatever index you calculate, whether you are on track, off track on your CT, but the final decision will be made on table with the patient profile, is it, as you discussed.
But the problem is, normally when we actually go in, we address the Hill-Sachs lesions first, because we tend to do the remplissage first if we had decided it. Because most often when we actually see, then you do the Bankart, it becomes more often non-engaging. So it's difficult to do remplissage after you've done the Bankart
exactly.
repair.
Yeah, that's a different issue, isn't it?
Yes.
But if in doubt, what I will feel and what I will do in my practice is, if in doubt, I will put the anchor first and for the remplissage and complete the anterior. What do you do, Harpreet?
Yes, the practice is always to put your anchors first before you put in your Bankarts anchor for the Hill-Sachs. But again, I think it's a combination of both your pre-operative findings and your intraoperative findings. I would not fix each and every Hill-Sachs.
So I would just like to add into this. So nowadays, all of us almost do remplissage in most of our procedures. So what I do is I just check it dynamically by putting my scope inside. I move the arm, and if I see at what point in the movement range the Hill-Sachs is coming against the glenoid, and that gives me an idea to do a remplissage in most of the cases.
Can I ask you one more thing? As you said, you do most of the cases. Is it only for the off-track or?
See, off-track lesions, yes.
Whether, irrespective of off-track or on-track?
Yes. By the time, in our scenario, when the patient presents, usually there is a significant amount of bone loss. First-time dislocators or like very less episodes of dislocation, they are rare scenarios to be present. So what I do is I just put my scope inside, take the arm in the functional position, and see at what angle it is engaging. So that gives me an idea to do a remplissage.
Yeah, that is one thing you need to remember. Definitely there's a division between the shoulder surgeons. One school of thought thinks that every patient has to have a remplissage, which like a bipolar lesion, which for me it is an overkill. I will do it for the on-track, off-track lesion only. But there are other surgeons. There's a lot of surgeons, a group of surgeons who does add remplissage irrespective of on-track or off-track. Thank you.
Thank you.
Yeah. Can we go for the next one?
Thank you, Dr. Harpreet. Next one will be Dr. Ayappan Vinayar. He will be presenting on the failed Bankart, evaluation and management.
Okay.
Okay.
most respected teachers, senior colleagues and friends. I'm Dr. Ayyappan Nair. I'm from Manipal Hospitals, Bangalore. And I'm extremely thankful to Team Kolkata, Rajiv Raman sir and Sunit sir, Soumyadeep. All of you have been very good, I mean, very, very kind. And yes.
Can we see
the screen is not coming up. Yeah. So extremely thankful to all of you. And good morning to the chair as well. So I'll be speaking on the Bankart surgery, management of failure, and further options. So here, the cardinal principles which I feel that we should keep in mind is about patient selection. Patient selection would be like, it's not the same surgery for a first-time dislocator or multiple-time dislocator. It's not the same surgery for if there is a bone loss. It's not the same surgery for a contact athlete. It's not a same surgery for laxity. So the surgery is different. The patient selection should also be very, very different. So it is basically choosing the right surgery for the right patient, and always getting it right the first time is most important, because always the primary surgery gives the best results. The revisions have lesser results. So always I think we should keep in mind about that. And coming to the incidence, when you look at different papers, the incidence is quite huge. On the primary Bankart, that is touching around 18%, that is around 20%, that 1 in 5 patients are going to fail. So coming to failure analysis, there have been different papers talking about different causes and what are the possible failures, reasons for failure. So name it like hyperlaxity, technical problems, bone defects in the glenoid and the humerus, which has been discussed now, return to contact sports, traumatic recurrences, age, and other pathologies. But I think the most comprehensive paper would be from Pascal Boileau, which came in 2006, a failure analysis of 131 cases, which was quite comprehensive. So the takeaways from this paper was that the age, younger age, higher recurrence. So more the higher the age, it reduces. Contact sports, higher recurrence. Competitive sports, higher recurrence. Hyperlaxity, anterior and inferior hyperlaxity, higher recurrence. So if there's a bigger hill sash, the superior hill sash, like if it is seen in extenotation, higher recurrence. So with this, they devised the ICE score, which is a score less than 3. Would be suitable for a Bankart, and the score above 3 would be better for other procedures. So coming to, so this is another paper, 91 cases. So the amount of risk, the percentage of recurrent instability was 15%, and delay to recurrence was interestingly like around 17 months. So we should expect the recurrences like touching around 1.5 to 2 years at time we should start seeing recurrences. Now again, the takeaways from this paper was, so there are certain important factors which we have to keep in mind which are responsible for the failure. One is the glenoid bone loss. So there has been discussion right now about the glenoid bone loss, if it is like a significant bone loss, about 25%. There are some papers talking about like Shin et al. There's a paper talking about 15%. So it is variable. From my side, I would take 15%. I would like to be slightly on the aggressive side. So if it is more than 15% bone loss, it is important and critical to me. A large hill sash has to be addressed. So a stretched out IGHL, we are talking about IGHL which can be stretched out with multiple dislocations. So again, it's an important factor. How many number of anchors we use is very important. Less than 3 number of anchors can fail. And if there is extreme anterior hyperlaxity, like with extreme external rotation, again, these are the main contributing factors which you have to keep in mind when you're thinking about avoiding failure. So again, there is an interesting question asked, and to answer that as well. So when you look at the bone loss could be of 2 types, avulsion type or erosion type. Erosion is like on the right side picture. So here they have higher recurrence. So we are looking at, if there is more than 15%, I would do a Letarge on erosion type. At the same time, if it is an avulsion type, and we can avulsion types, if it is very well fixed, then definitely we can have cases without any recurrence. Excellent paper from Sugaya et al. Sugaya team will come out because he's fixed all with special techniques, trans-osseous techniques. Okay, he's got a particular way of repairing it, and excellent results, no recurrence if an avulsion fracture is nicely fixed. So here, this is the reason why in erosion there is quite a bit of hyperlaxity as well. There is laxity of the capsule as well. So that is why it fails. Now, coming to surgical technique, what all we have to do to be, that we have to be careful and how to manage this would be, in any case, mobilizing tissue is very important. That is the labrum and the capsulable tissue has to be very well mobilized. The capsular plication, especially the plication at around 6 o'clock and 5:30 is very, very important. We can use mattress sutures so that we get a good plication. The IGHL tears, haggles should be addressed. So soft tissue insufficiency, we have to specifically look at ALPSA lesions. So we have to do adequate mobilization in the ALPSA, lift up the capsulolabral complex. Then sulcus signs have to be, if there's a sulcus sign, we have to take care of that. I would do a rotator interval closure in those cases. And what happens is, whenever we are preparing the labrum, we also have to prepare the cartilage. That means we have to take a small rim of cartilage from the side of the glenoid, because that is very important. So that because there's no healing which happens between the soft tissue and the cartilage. The healing happens only between the bone and the soft tissues. So we have to take a small rim of cartilage. That's very important in the healing. Then please look at this picture. So this shows that whenever we're putting anchors, the anchor should be put on the glenoid face, not on the medial side. That also helps in better plication. Then number of anchors should be always more than 3. 3 or less than 3 will fail. So these are the things we should keep in mind when we think about how to avoid failures. So if a case of failure is coming to me, what do I do? Definitely I would do a CT scan, and along with that certain X-rays. But the CT would be most important to me, and I would do a bone loss quantification. So an MR arthrogram would be my choice of radiography. Why? Because I would like to study the haggle. I would like to really know about the capsule, how much of laxity is there, all that, and any rotator cuff tears, all this, and I will do an MR arthrogram. So now we now know that I have a particular case. Now what are my options? My options would be like this. My options are: number one option, a revision arthroscopic Bankart plus remplissage, an arthroscopic or open Latarjet, a dynamic anterior stabilization, or a subscapularis tenodesis. So I'll come to one by one. So what is my indication for a revision Bankart? For me, a revision Bankart would be like if the bone loss is very less and the tissue quality should be good. But personally, I would not do this, because even with the revision Bankart, there's a very, very high failure rate. A revision Bankart failure rate is around 10 to 43%. 43% is very, very high. So I would definitely not do this now. This is my earlier video. So I don't do this anymore. If we are doing it, then these are the things to keep in mind. There should be adequate tissue mobilization, a cartilage removal and a nice bed preparation, inferior anchor placement and mattress sutures. This will definitely help in a nice revision. The results are the problem. When we look at the literature, this is the results. 43% to 43% is a huge recurrence after with a revision Bankart. So the reasons are these: because the soft tissue quality, decreased sites of available sites for the suture anchor placement is much lesser, and the healing capacity overall in a revision scenario is less. So what is my surgery of choice? I would definitely do an arthroscopic Latarjet for a failed Bankart. That is my surgery of choice, irrespective of the soft tissue or the bone quality, but because this would give me a one-stop answer to my questions. So here, this is a particular patient who had 2 times Bankart, failed, and we did an arthroscopic Latarjet. So whenever I do an arthroscopic Latarjet, I always do a remplissage, irrespective of the remplissage, if it's especially revision cases, irrespective of if it is on track, off track, I always do a remplissage along with arthroscopic Latarjet. The advantage of the arthroscopic Latarjet is that it gives you scopy access posteriorly. I also repair the capsulolabral complex back after doing the Latarjet. So all this is possible with an arthroscopic Latarjet, and we have excellent results with this. This is the results of these patients after 6 months and immediate post-op CT. So the patient has gone back to the full range, and so this is my procedure of choice. It's got excellent results. So if you look at recurrence and all, it's excellent results with the arthroscopic or the Latarjet. It is much, if you're doing open Latarjet, is much cheaper and better clinical scores. And the other thing which I would suggest is, if there is bone loss is subcritical, we can always use a DAS technique. This is our technique of DAS, which we recently did. And we use an Arthrex system of tightrope and to do the DAS. So we have evolved this technique, is under publication. So this is my summary. So the patient selection is very important. Rigorous techniques to avoid the failure we have to keep in mind. Revision Bankart has high failure rate, so I would not do it personally. So my surgery of choice would be an arthroscopic Latarjet, which gives excellent results in my hands. DAS is a great option if there is subcritical bone loss because it gives you soft tissue support. Thank you so much. I welcome all of you to Manipal Shoulder Conference. Please come. Thank you so much.
Thank you, Dr. Ayappan. If you have any questions, couple of questions. If no questions,
okay.
Thank you. Okay.
Can you expand on this DAS technique that you mentioned?
Yes.
I haven't heard about it.
So it is dynamic anterior stabilization. So Ladderman had started this technique. I mean, he had reinvented rather this technique, where we take the long head of the biceps, we detach it, we make a split in the subscap, and fix it anterior to the glenoid. So the fixation on the top of the glenoid could be on the glenoid face or on the side. The point of fixation would be at 3 o'clock. Why? Because the IGHL is normally fixed at 3 o'clock position. There are different techniques of fixation, like, we can fix it with like a tenodesis screw. And what we have modified is we have used a tightrope, soft tissue tightrope, like how we do in cordyceps. So we have called fiber tack tightrope. We have used that, and we have that's how we have done it. Why? Because because glenoid is much smaller compared to the knee. We don't want too much of a bone loss there. Chance of fracture and all is there. So this is, and it's very easy to do because so we have. That's why we have done this with, just like how we do some similar to that ACL. So we just pull it in. Only thing is we need an anterior axis. The only thing. It's a great technique. We just did that, and we sent for publication. So we're waiting for that, and then planning to start on long-term series.
Thank you, Dr. Ayappan. We will go on to the next presentation. There's a change in the itinerary. We are going to have next speaker, Professor Gopinath from Calicut. He doesn't need any introduction. He's a mentor and probably is well known to you guys. He got a flight to catch up, so he's going to speak up on partial cuff tear, how to evaluate and how to manage it.
Respected dignitaries on and off the dais, my dear friends and colleagues. First of all, let me thank the organizers for allowing me this opportunity to present this topic in front of this august audience. I must talk on partial tear of the rotator cuff. As you all know, this is a highly controversial topic regarding definition, the management, surgery, and what type of surgery. All are controversies. And partial thickness of rotator cuff has been shown to have more pain sometimes than complete tear. Some patients with partial rotator cuff have more pain than complete tear. It could be on the bursal side, it could be the articular side, or it could be on the intratendinous region. There are several classifications for this. Some sort of a classification is needed for documentation and also communication between the surgeons. One classification is Ellman's classification. Grade 1 is less than 3 mm in depth. Grade 2 is 3 to 6 mm, and grade 3 is greater than 6 mm. 6 mm, more than 6 mm means almost more than 50% of the thickness of the curve. Another classification is by Hobart Meyer, and this is type 1 is a small tear within the transition zone of cartilage to the bone. Type 2, the extension of the tear up to the footprint, and type 3 is extension to the greater tuberosity. But if you look at all these classifications, they don't quantify the tissue laxity, the area of tearing, or the etiology of the tear itself. And there are poor inter-observer reliability. If you show to two surgeons, they classify it as in a different manner. And the other problems are extreme variability in the size and the location of the location and the etiology. Older people, articular surface tear is common, and there is a poor vascularity and reduced tensile strength on the articular side. So in younger patients with overhead throwers, it's a more posterior and the infraspinatus interval. So based on a cadaveric and imaging studies, the prevalence has been around 13 to 32%. And the causes of this particular problem are bursal side tears are primarily caused by subacromial impingement, articular-sided tears are the result from trauma to the degenerated tendon, and intratendinous lesions are due to the shear force within the components or the layers of the supraspinatus. Tears involving more than 50% of the tendon has got a incidence around 55% progression, and tears involving less than 50% of the thickness of the tendon has got only 14% chance of progression. Partial tears has been relatively ignored, and subsequently the treatment of the partial tears remains controversial, and there are only few articles which studies about partial tears, but you get umpteen number of articles which studies about complete tear. So the controversies are regarding definition itself. There are controversies whether to repair or debride is a controversy, and what surgery you do, whether you do a trans-tendon technique or a full takedown and repair are controversies. The controversy number one is the definition. What is partial lesion? It's a partial articular-sided tendon lesion, tendon avulsion, or it is TAS, supraspinous tendon articular-sided lesion, or it's a pained lesion, posterior articular intratendinous rotator cuff lesions. So these are all classified as partial lesions. Now, intratendinous tear may suggest shear within the tendon, as I told, and interstitial tear account almost 70% of all tears. The common presentations include painful arc syndrome, crepitus or weakness, and difficulties in overhead activities and overhead sports, and correlation of the clinical findings to the imaging is very, very crucial. You can do Hawkins test, Jobs test, or near impingement or drop arm sign. These are the tests you can do. Around 13% of the MRI, 13% of partial tears, of which 55% are intratendinous. That's why I told most are intratendinous. 27% will be articular surface tear, and 18% will be on the bursal side. And ultrasound is useful in a very expert hands only. Greater tuberosity articular surface distance remains high in partial tears. That could be one reason for partial tears. And even MR arthrogram shows only around 21% detection chance in a normal view. But if you take an MR arthrogram in abduction external rotation, the chances of picking up the lesion is around 100%. So even in the MRI or MR arthrogram, abduction external rotation film picks up this lesion better than any other view. So the conclusion regarding definition is that location, it could be articular side, it could be on the bursal side, or it could be on the interstitial side. Footprint, mediolateral, it can be more than 6 mm or less than 6 mm. AP, more than 10 mm or less than 10 mm. And delaminated capsular tendinous avulsion or capsular tendinous dissociation with infraspinatus extension. So delaminated tear is another type of partial tear. We can do a non-surgical tear, a traumatic, non-dominant hand, less than 50% tear, low activity level. You can go for a non-surgical treatment, and surgical treatment is for traumatic acute tear, more than 50%, dominant hand, younger patient, failed non-surgical treatment. And you should be always cautious to select the patients with who are athletes, who are overhead throwers, to select for some surgical procedures, because they always come back with symptoms and they are not usually very happy. Now, another controversy is regarding whether debride or just repair. Arthroscopic debridement, scopic repairment, and this is supposed to have some symptomatic relief, and it has been published in 1985 that there is 74% chance of improvement after debridement alone, but other studies shows that the results are not that excellent. So another study, Reynolds, he studied around 67 baseball players, and 76% returned to the same profession, but only 55% had the same or higher level of activity with the debride alone. So concomitant labral debridement, SAD, subacromial decompression, did not have any effect on the clinical outcome. So returning to the same level or higher level after debridement alone is challenging. So healing after debridement. On second look arthroscopy, most of these lesions never healed. This is published by Weber in 1999. In the same article, he told that if you add acromioplasty to debridement, there are chances of some fair results. So the rationale of 50% rule. So the separated fragments or separated layers has got low vascularity, and 50% rule is an acceptable rule, and those with more than 50% you try for repair, and if it is less than 50%, you may go for debridement alone. So the evidence-based conclusion regarding this particular controversy is that consider repairing structurally significant lesions and try to follow the 50% rule. And also, if the mediolateral extent of the lesion at the footprint is more than 6 mm, you go for repair. And if AP dimension of the tear is more than 10 mm, you go for repair. And infraspinatus delamination is an indication for repair. Other cases, you can go for conservative or just debridement alone. Transtendon or complete takedown, another controversy of this particular problem. Transtendon means 100% tendon integrity, more pain until 3 months, less range of motion until 6 months, and these are the problems, and no clinical differences at 12 months. So if you do complete takedown or transtendon, the outcome is the same at 12 months. But in between, those patients with transtendon has got some problem or the other, and the patient may not be happy in the immediate post-op period. The maintenance of intact tendon, better biomechanical properties, and reconstruct the footprint and better length tension relationship is the advantage of transtendon technique. But it's more difficult. Tendon over-tensioning and bunching on the bursal side is a problem. Residual discomfort, pain, stiffness is a problem with transtendon technique. So one technique we do, it's a double pulley technique. You identify the pasa lesion, debride and then only classify. Before debridement, you may not be able to classify what type of lesion. You debridement assess on the table, and then you decide whether you want to do a complete takedown or a partial repair. This is a double pulley technique. You put 2 anchors, one on the anterior extent of pasta, another on the posterior extent of the pasta, and you have threads in the subacromial region. You tie between the threads of the 2 anchors. When you tie those threads, then the lesion will sit on the defect. So now complete takedown is one surgery where it's easy, you get better results because you are used to it. So this is an RCT where finally it was concluded that there is no clinical difference. Strength improvement is better with complete takedown, better in complete takedown group. This has been published in 2013. So evidence-based conclusion regarding this controversy is that transtendon you use for younger patient when supraspinatus is only levels. Complete takedown you do in majority of cases except in very young and where only supraspinatus is involved. Post-op rehabilitation on transtendon should be little more aggressive because post-operative period is going to be little stormy in a transtendon technique, and you can start continuous passive motion early in a transtendon technique. There are some complications for this particular problem as well. Those who underwent complete takedown had a 12% chance of retire, significantly higher risk of treatment failure on the bursal side lesion. And debridement without acromioplasty does not prevent progression of the full thickness tear. Aside progression, other complications are infections or stiffness is always there. It all depends on your post-op rehabilitation. So the conclusion is, if you look at definitions, location could be a footprint extension, or it could be on the bursal side in interstitial or intraarticular, and delamination tear. So classify the tears according to the footprint extension, AP extension, delamination, and bursal side intratendinous or articular. Debride or repair structurally significantly, you try to follow the 50% rule. Transtendon or complete takedown repair, majority of the cases complete takedown and repair except in very young and only supraspinatus is involved. So I take this opportunity to invite all of you to Calicut for the next Arthrocon meeting that is on shoulder arthroscopy. Thank you for patient listening.
Thank you, Gobi. Any questions? What I find is extremely difficult. I am still struggling to define that 50%. It's very difficult to define. But unfortunately, all the literature shows, whether it's more than 50%, you go the high chance of progression, and you go for the repair. Defining that 50% is very difficult, at least in my hand, and I find it extremely difficult. Any shortcut for that, Gobi?
No, classification cannot be decided on preoperative situation always, because MRI, ultrasonography, MRA cannot quantify whether it is 50% or less than 50%. Usually it is an intra-op decision. You debride the lesion, you look for the thickness, and in the intra-op situation, if you feel that you try to put a needle in and you can do some sort of an assessment. That is the only thing in our hand works. Pre-operatively, you may not be able to classify whether it is 50% or not always.
Thank you, Gobi. There is no further questions. No. Safe journey back to Calicut, Gobi.
Thank
you. We'll get back to the shoulder instability presentations. Next presenter is Dr. Sanjay Kumar. Latter J. When and how we are going to do it.
Good morning, everybody. When I was late in the morning when I entered in the hall, Dr. Harpreet was delivering a gem of a lecture. My understanding to his lecture is that now I stand off track, okay, because every bit of my talk has been discussed, but somehow, okay. So coming to the historical perspective, it was first described the Letarjet in 1954. He was a great anatomist, talented surgeon of lion, and a very accomplished musician and a good sportsman. To mind you, he was not an orthopedic surgeon. Along with his name, when we talk about Letarjet, Bristow-Letarjet procedure often comes to our mind because it is oftenly discussed. He was a great teacher, never himself described this procedure. A.J. Helfet, one of his students, who described this procedure 9 years after his death. So it was his tribute to his teacher. The basic difference between Bristow and Letarjet, in Bristow procedure, we can see fixed with the single screw, and it is put in the horizontal mode, and in Letarjet procedure it has been put parallel with the long axis of the glenoid and fixed with 2 screws. Coming to the shoulder dislocation, we everybody know it is very common, more common in male, young age, and there are plenty of causes, traumatic, automatic, and maybe due to laxity. The literature, what it says, that if the age is less, the number of recurrence, the chances of recurrence are much more. It has been already told. So what are the surgical options once we are addressing a patient with a recurrent dislocation of shoulder or instability? Anatomical repair like Bankert, subscapular reefing putty plate, capsular plication. These 2 procedures are not nowadays performed, and Letarjet with its modification. So what is Letarjet? Coracoid along with conjoint tendon is transferred to glenoid defect through the subscapularis space, or a space is created between the subscapularis. It acts like bone block, sling effect, and capsular reinforcement. Now, who are the ideal candidates for this Letarjet? Coming to the age, as I have already told, or it has been discussed, younger the age, more is the chances of getting instability, and they are the candidate for Letarjet. Number of dislocations, as the number of dislocations increases, some patient will come who have the history of 20 to 30 times of dislocation. They are the candidate of the Letarjet. Radiology is very important in these patients. We have to address the bone loss, and if bone loss is there, then your soft tissue repair is going to fail. And Letarjet cannot be a per-op decision. It has to be a pre-op decision and it has to be planned. You cannot plan on the table. And Latarjet along with arthroscopy, again it is very controversial. In my day-to-day practice, I don't do arthroscopy, but some people are there who always go and examine the joint and after they perform the Latarjet. Radiological evaluation already have been discussed by Dr. Harpreet. 3D CT scan is the most important tool where you can address the amount of the bone loss. Again, the bipolar defect and the glenoid tract. This picture has been also shown previously, so I need not have to go into the detail. If the lesion is off track, then in most probable cases, they are the candidates for your Latarjet. See the amount of bipolar defect in the head and the acetabulum. Regarding the critical size, it is very, if you go by the literature, 20% is the critical size. This makes 6 millimeter of bone defect. But as the people, depending on the profession, as the people are taking sports as profession, or they take as their passion, so the subcritical size is going down day by day. So some people used to do that in less than 14% of bone loss also. So this is a small video of probably Dr. Jayaprasad is here. Dr. Jayaprasad, yes. So everybody has overlapped my thing. Probably you are going to take this. So after this exposure, you see now harvesting the coracoid, cutting of the identification and cutting of the CA ligament. Now minimum 2 centimeter from the tip of the coracoid has to be taken. Osteotomy. So, regarding complication, for every procedure we perform, there is share of complications. So, non-union, graft, reabsorption and neurovascular injury are one of the important complications of this Latarjet procedure. In literature, it has been shown that 15 to 30% of complications are there in standard open Latarjet, where non-union of the graft, breakage of the screw, everything is there. If sometimes Latarjet fail, then free iliac crest graft can be done as Eden-Habenet procedure. So the take-home message is, it is easily reproducible. Bone defect is prerequisite to the surgery, and above all, the implant cost is very low. Thank you very much.
Thank you, sir. Are there any questions from the floor?
How often you do the Latarjet procedure?
Yes, sir.
How often you do the Latarjet procedure compared to your bunkers?
No, in less, very less, very
Okay,
less.
I think probably that is the
Very less.
Okay.
Most of the time, banker repair
Bankers repair.
you will do.
Any other questions? Thank you very much. Thank you for your presentation.
Thank you.
We'll go on to the next presentation, which is going to be. Unfortunately, Ram Chidambaram is not here, but we are going to. He's going to be online. So, can we get it ready, please? Ram, good morning, Ram. I hope you are okay now.
The video.
Okay. Yeah, we are going to share it.
Sorry I couldn't join you guys personally. It's a long time. Wait.
Yeah, here Ram is going to speak on a failed lateral J, find the way out. Okay, so he's going to speak about the lateral J procedure and failure. Over to you, Ram. Can we get it on the monitor as well? Thank you.
Okay, can you see my screen?
Yeah, we can.
Yeah, okay. Thank you, Cass, for the kind invitation. Now, I think it's been already covered, the indication for lethargy. So this is my current affiliation, duties from Chennai. So remember, lethargy is a non-anatomical procedure. Still has 5% clearance rate, and complication rate is 15 to 30%. Do not underestimate this. 30 studies, over 1,600 lethargy procedures. This is the list of complications, mainly hardware, graft-related, non-union, migration, osteolysis, or hardware failure like this. So the lethargy failure means recurrence of dislocation. And if you look at it, the recurrence of dislocation is partly or mostly due to some sort of an issue with the graft or the hardware, and mostly technical. So, and it's a challenge to treat. So I split the talk into two portions. Number one, how to prevent ktm complication. Number one, 20-year-old gentleman with a recurrent dislocation. You see an isolated 9/10. This patient had lethargy. 9 months after lethargy procedure performed elsewhere, coming with a graft resorption, erosion, screw, prominence, and axillary nerve involvement as well. So most important lesson, we know if you do a lethargy for the intact glenoid, resolve it cause problems. So too late for the right indication, over indication is a problem. I give you some tips regarding this procedure because this is the most commonly performed lethargy procedure, James Walsh technique using 2 screws. First, get the correct osteotomy plane, right angle, and minimum length 20 to 25. Second, carefully exteriorizing, feel the nerves, prepare the undersurface so that it is bleeding bony surface. Aim for 2 to 5 o'clock position of the graft. Never go down, never go superior, it's not necessary. Aim for a flush position, 2 medial, there is no bone block effect, 2 lateral, there is a risk of arthritis, both lead to complication. This is the ideal graft position as we use on the X-rays. As for the screws are concerned, I use 2 screws, partially threaded, cannulated, usually better to be less than 4 mm, not go for 4.55 mm screws in Indian bones, and maintain a minimum gap. The alternative attractive thing is the fiber tape circle, which is also getting popular. To avoid coracoid fracture, don't do excessive decortication, mind the dimension, space the drill hole minimum 8 to 9 mm, and avoid excessive tightening of the screw. Should a crack happen, you should also have something like a small plate or a device like this to help you achieve a stable fixation. Again, repair a capsule or labrum to the native glenoid or the C-picture is optional, but I try to do that because it achieves some extra stability, and second, it also makes your screw extra articulate. Very important, carefully place your retractor to avoid nerve injury. Remember, the musculocutaneous nerve takes a different route. The penetration angle differs as well as relative lengthening. So remember the anatomy, gentle mobilization, heal the nerve, make the muscle to a free excursion. Again, regarding suprascapular nerve, never put a long screw, especially the top one. Never angle it more than 30 degrees. These are all the technical tips to achieve the best fixation. Now, should a situation happen, a failed lethargy coming to you, how to approach? These are the factors: technical error, post-op trauma, or the underlying other disorder. In my experience, 75% are due to technical error and only 25% due to additional trauma. If you want to have a more robust data, look at this paper published last year, 2021. Systematic review of 11 PET studies over 12-year period, 253 patients with failed laparoscopy procedure with a mean of 21 months. These are the costs listed. Major second trauma is only 60. But you see, all the main problems are in the graft non-union, malpositioning, hardware, fracture, lysis, screw, metalwork problem. So the complications listed for laparoscopy can lead to recurrence, make laparoscopy fail. So you need to stick to all the precautions to avoid complication. When the situation comes with the failed laparoscopy, we have two options. Number one, you reconstruct the glenoid with bone graft. And that's my preference. Use a contour iliacus graft readily available. The other alternative is to use the distal tibial allograft, but because of the availability, we don't use it in India. Second option is arthroscopic capsuloplasty can be performed in very selective cases where there is intact glenoid, like the case I first shown, where the laparoscopy was done causing additional damage, but it's not my preference for anybody with the glenoid bone loss. If you look at the results of these 253 patients, you have to warn the patient. Still, the overall recurrence rate is 8.6. So even with the failure reconstruction, you can have only achieved 92%. Still, complication rate is 17%. Only 50% return to pre-injury level of scopes. And OA progression is noticed in 36%. So this is the patient needs to know. So example cases, a 34-year-old gentleman had open laparoscopy performed 6 months elsewhere. This is the presentation. He dislocated the shoulder and is in pain. If you look at it, you have a glenoid bone loss, moderate, 20% around, and you got a long screw with a washer. And if you please see the direction of the screw, it should be inferior, that is not the right direction. And you also see a small broken guide wire or filament. That means that the surgeon had difficulty in doing this surgery. And also you see the graft lysis resolved. So what to do in this situation? I did the, as I explained, and then I did the iliacus graft. I normally take the iliacus graft first because we know the plan. So patient in supine position, measure the defect, always go a little bit higher by 3 centimeter by 2 centimeter, try cortical iliacus graft. Once you take it, you contour to the glenoid as and how it is necessary for the shoulder. The inner table I use it to face the articular surface, and occasionally I make drill holes to put some sutures to do capsular repairing if necessary. In the shoulder, you do a capsular dissection, take care of the nerves, as I said before, remove all the hardware. The hardware has to be removed, but if there is any broken unit or wire, deeper or anchor from the previous surgery, it is difficult to remove or retrieve it. Second, also, if there is a tip of the coracoid with some soft tissue attachment, I also leave it because we have to address the instability mainly. Again, the fixation is like the technique what I described for the laparoscopy, you put the screws, capsular repair if possible. Post-op, you put in sling, mobilize from day one post-operative, do exactly as you do primary laparoscopy, no difference. That is him, outcome in 6 months later with good incorporation of the iliacus graft. As you see, this is the profile picture showing resorption, moderate resorption of the superior part of the graft, which is expected from iliacus usage, but you have a very good reformation of the glenoid.
Thank you, Ram. I know more and more people are doing lateral J, and they should be aware that it's not without any complications. Very highlighting point there. Thank you very much for that. Any questions? Yeah, go on. Yeah. We got one question.
Hi Ram, I'm Sunit from Calcutta. So yeah, so in your second case where you said it was a failed boy shape, so what exactly you do with the the rerouting of that conjoint tendon actually? So how did you go to that exact plane?
Do no harm.
Yeah, that's what I want to learn. How to do no harm.
Basically, I ignored the anchoring glenoid and ignored the point of screw. Is look at the post-op where I have not disturbed the coracoid itself. What I did in that case is a subscapular is split.
Okay.
Subscapular is split, and then do the reattach. The whatever done with the coracoid with the point of the screw. But should a situation comes in where you have to access it, I would remove the screw, do a coracoid tip osteotomy, and leave it to retract. Don't chase it. If you chase it, you will end up in problem.
Yeah.
So do a subscap split and address the glenoid.
Yeah, I just wanted to, the medial retractor, putting the medial retractor on the interface of the glenoid will not be a problem in spite of having already a conjoint tendon going through the subscap. That's what my question was actually.
Yeah, that's what I said. If it is difficult to retract, remove the screw, do a tip osteotomy, and then you should be able to put the retractor in.
Okay, thank you.
Relax.
Yeah. Whatever happens, you want to protect the musculocutaneous, isn't it?
Yes.
Yeah. Okay. You want to? I don't think there is any more questions. You want to have a back-to-back presentation?
Yes.
Yes. Ram is going to speak on arthroscopic treatment of ACJ dislocation as well. It's in the next session, but we are preponing it. Over to Ram.
Is it okay? Thank you for that accommodating this. So we talk about these three things. Number one, highlighting anatomy. Two, classification. Three, what is my experience of arthroscopic treatment in AC joint dislocation. We know coracoid ligament is the main structure for stability, but these two, AC ligament and deltoid fascia, are becoming, assuming increasing significance as stabilizing factors. As evidenced by this study, who looked at 65 cases with a mini open repair, where they categorized 4 types. The common size is clavicular size 10. These 10 should be addressed as per the injury pattern to get the best result in AC joint horizontal stability. And second, remember, deltoid fascia is an avulsion in continuity failure that should be repaired as well. Now, we know Rocky classification, type 1 and 2, take it or leave it, 3 controversial, 4, 5, 6 open. But remember, Rocky classification addresses only vertical instability, not AP, horizontal instability. Example, in this case, 22-year-old physiotherapist after a traffic accident, competency. What is your treatment of choice? How to manage? Operative or conservative? We did here conservative treatment. This is done after 3 months of conservative. Shows the range of movement, full range movement of the shoulder, no problem. And you do an X-ray. That is the X-ray showing mild changes of AC joint but well aligned. How is this possible? By doing an Alexander view or called Basmania view. You take a cross-section view of the cross-section of the arm, the 45-degree oblique, to see the AC joint. If it is overriding, that means it is a significant displacement. It is classified into 2 subtypes, 3A, 3B by isocost. 3A, where stable, rapid improvement, no scapular dyskinesis, and the Basmania view is normal. Whereas 3B, where there is more horizontal overriding, these patients tend to be unstable with no improvement, may develop scapular dyskinesis. So this could be sub-classification which help you to pick up the indication for surgery. Now, a treatment of high-grade AC joint dislocation, there are multiple surgical options. There are multiple options for a condition that means nothing is perfect. So we can vary through AC joint fixation, closed screw, tension wiring was mostly out of fashion. Hook plate was still being used by some surgeons, but any issue with the hook plate is that it has to be removed, otherwise it can lead to a problem. CC fixation has been originally prepared with tapes and sutures. I know I'm aware of the results by relating the combination of synthesis and results and also tendon graft and procedures. I learned that tightrope technique from Bennett from UK with 4 mm drill hole with fiber wire buttons, very cosmetic, no infrared hole, very appealing. But there was a significant secondary displacement with this technique where it was only addressing the coracoclavicular fixation. And there were two buttons, subsidence because the 4 mm flip it and the hooklet to the clavicle. So Marcus Schreiber described the two double tightrope which I learned and we did around 29 cases in the Epsom, 31 patients, but it still have 19% failure rate. 4 patients. Why? Because we were not addressing the AC ligament at the time. It was done all orthoscopic those days. Now, there are ways to address the horizontal instability. Number one, do a mini open technique. Don't do all orthoscopic, do assisted. Direct repair of the AC ligament, circular sutures or internal breaks, and finally, repair. This will complete the room stabilizing factors to the normal tension. AC circular, as you see here, can be done orthoscopic addition, or you do a minimal open AC internal breaks technique, but it involves additional anchors. Fracture clavicle is an issue, but with the new dog hole type of anchor device which we use only 2.4 or 3 mm drill hole, and we do a retrograde passing the Coracoid button, so we don't need to make a larger drill hole. It comes with a couple of tapes. So that is the surgical demonstration. So you make appropriate portals and a small incision on the AC joint, directly visualize, reduce the joint, use the dedicated guide system, take the inner sleeve out, outer drill is there, and you pass the shuttle suture. So the anterior portal retrieve and get the coracoid button deployed under the coracoid. Once this step is done, I will close my orthoscopy because orthoscopic direction we have done the button placement, rest of it is minimal. So we just see the case example. So if this operation should be done in sitting position, there is a diagnostic scope. See the subscapularis down, along with the biceps top, the humeral head on your left, glenoid on your right. You open the rotator interval to reach to the base of the coracoid. This is not difficult because we do this step in frozen shoulder or secondary stiffness shoulder release. We prepare the area. We make an additional portal there under vision. So you prepare the area. You have to reach to the base of the coracoid. Fundamental aspect. Important in doing AC joint surgery as well as orthoscopic coracoid grafting procedure. So once you do that, skip a little bit. You use the appropriate guide. This system comes with a right and left specific guide. So you have to exit. This is the advantage of using orthoscopic for this step because the drill hole in exactly the center of the base of the undersurface of the coracoid to get the right region of the coracoid angle. If you do it only from open to the top, sometimes you might get lost in the width of the coracoid. This is the system, comes with a kit. So you shuttle the suture so that the coracoid button is deployed. The guide wire is removed. Nitinol wire from the top. And you withdraw the cannulated drill bit. Now you have a track. You shuttle the suture from below upwards. In the past, we used to drill a 4 mm drill hole and push the tightrope from the top. But here, you can make a smaller drill hole and take the sutures up. Load this comes with a preloaded coracoid button. So the coracoid button goes in. Very important to make sure the button lies flush with the coracoid. If you have a loose glue, that the tape will not be tight enough as you finish your operation. Make sure that manipulate the button. Make sure that it is seated, flush with the bone, and second, flip it, run the two tapes so that it is flush. Once this is done, I'm done with the orthoscope, close it, I will go up to the, so now I'm just readjusting it as you see. Still there is a gap. should not tight like that. So, okay. Now it's fine. Okay. So both tapes are sliding down flush. So once this is done, we go to the top. A mini open incision which is made a small 3 centimeter longitudinal incision. I repair the tapes, and second, do a direct closure of the AC joint, as well as take the tape across to acromion to also fix it if necessary, and sometimes use internal brace if necessary. So that is the range of movement of the patient after surgical fixation, which is a combination of arthroscopic assisted reconstruction of both CC and AC ligament tear. So some low profile implants are also coming up in the future. To summarize, I'm just raising the awareness for the role of AC ligament and AC ligament repair, especially this horizontal instability, and also about this classification of type 3 into 3A, 3B by doing a simple radiological projection in your unit to understand which subtype need to benefit from surgery. And thirdly, address the CC as well as AC ligament reconstruction, whatever technique you do. Thank you very much.
Thank you, Ram. Any questions? He's still online, so you can ask questions if there is any. Which system did you use, Ram, on that one? Is it Xeronics or Arthrex? Okay, okay. Yeah, Ayyappan, yeah. We got a question from Ayyappan.
Good morning, sir. Yeah, sir, the timelines of the surgery, like less than 3 weeks, 3 to 6, more than 6 weeks. So what would you do?
I would say around until only 3 weeks I would go with the primary reconstruction.
Yes.
Because the primary reconstruction, what we are doing is aiming to get the corpoclavicular joint reduced and acromioclavicular repair direct, so that the native ligament, torn ligament would heal. And addition of tapes with some ingrowth can happen along with the torn ligament. This doesn't happen after the period of 3 weeks.
Yes.
So if the patient is beyond 3 weeks, I would add a graft. But this graft, I would add it as a figure of
Absolutely, sir.
additional term.
Yes, sir. So one more small question was, do you do, when you said it's very important that, it is very true that we do a AC joint closure, also the delta pectoral closure, as well as the capsular closure is very important. Do we excise the disc, or do we excise the lateral nerve clavicle also? What would you do, sir?
I think most of the acute scenario, if the disc is torn, I would tend to excise it.
Yes.
But I do not excise the clavicle. In acute scenario.
Sure, sir.
But in a chronic, when we do, we might need to excise.
Okay. Thank you, sir.
Thank you.
Yeah, sir. You got one more question from Singh.
Again. So, how do you think that the type 3A and type 3B differ pathologically? What exactly do you think leads to what extra structure is installed in 3B that it gives an overlapping in the vascular?
I think this both are the grade of injury. The deltopectoral sleeve, which basically in type 3, we were thinking that it is only superior, but it is only an AP view. But the horizontal grazing of tear is not visualized. So basically, there are some type 3 which we think type 3, but they are actually more extensive tear in the anteroposterior plane with regard to AC ligament as well as the deltopectoral sleeve. So basically, it is just basically between 3 and 5. Grazing.
Thank you, Ram.
Thank you.
I think we will move on now. Thank you very much for joining us. Now, we will continue with the session. Can I invite Dr. Gaurav Gupta? He was here. Yeah, Gaurav. He is going to talk on posterior instability of the shoulder, how to diagnose and manage it. Over to Gaurav.
I'm not getting the mouse up here. Hang on. Sorry, it's probably not very happy with this. नेटवर्क क्यों खोज रहा? I'll take this off and then put it, yeah, now it comes back. And good morning everyone, respected seniors and colleagues. It's a great moment to be here, and I was absolutely enticed by Dr. Ram Chidambaram's presentation. So over to something slightly different. So we will talk about posterior shoulder instability, diagnosis and management. So what is instability? It's a biomechanical dysfunction, failure of stabilizers, both static and dynamic, and ranges from a mild subluxation to a full Monty, full-blown traumatic dislocation. Now let's have a look at what posterior restraints do we have in a normal shoulder. One is the glenoid version. We're looking at the bony restraints. What is the glenoid version? So the greater the retroversion, the more prone it is for a posterior instability or a posterior dislocation. In the soft tissues, it is the IGHL which restrains the shoulder from going posterior. The posterior capsule is a relatively thin structure, not so much like the anterior capsule, with less defined ligamentous components. And this one is quite interesting. Just an incision of the rotator interval capsule increases posterior translation by 50%. So all of these form your soft tissue restraints. Subscap, of course, it is the muscle which provides the greatest resistance to a posterior dislocation, and the capsulolabral structures. And you could have something like a posterior Bankart's lesion, and more with arthroscopy, posterior labral lesions have been found and treated, like a Popsla or a Kim's lesion. Let's have a look at the clinical picture. What is the clinical picture like? Can we have the audio coming out of this one? If I can fit this one. This will give rise to, give the audio out, isn't it? From the computer. Audio eta dile hobe na? Lagi diyeche to. Audio do ache ta. So I'll just try and play the audio as well for this patient, because he is talking about something quite specific. It's in Bengali, so I'll translate it for the wider audience. No, it's not coming up. Aha. Yeah, it's just come. Thank you. So see what he's saying. সমস্যাটা কি হচ্ছে বলুন?
হাত সোজা করতে পারছি না, সোজা করতে গেলে শোল্ডার জয়েন্ট থেকে ঘুরে যাচ্ছে। নার্ভিক্যাল পেইন হচ্ছে, নার্ভিক্যাল।
So what he's saying is, if he brings the arm straight up, then something in the shoulder just twists around. And what he also describes is a nervical pain. I don't know what he means, but some kind of a sharp pain I think he's talking about when he's saying that. So sharp pain and a bit of feeling of instability in forward flexion, internal rotation position, and that is what is classical. Sorry, I'll just... So there's subjective instability in forward flexion and internal rotation, and you get a bit of apprehension sign in forward flexion and internal rotation as well. Right? Sometimes. So there's a definite posterior labral click. Okay? And the head is subluxing posterior. See? I can feel a click, and it is subluxing posterior. He just came to us with shoulder pain, nothing else. Okay? No, thank you. So yeah, you can do a EUA, and this is something that I like to do, always do a bit of a load and shift in EUA, both in anterior and in posterior instability whenever I'm addressing them. And you can literally feel with your fingers there is a distinct labral click as the head pops up and down. So yeah, sometimes they complain only of pain and clicking in flexion internal rotation, forward flexion internal rotation, rather than a frank instability. More so when you have loaded the joint. And it's very easy to confuse with subacromial impingement. Hence, a proper clinical examination is absolutely vital when you're addressing some of these. Now, this gentleman actually owns a snooker parlor, and he himself is a very good snooker player, that's what I'm told. And see how if you load the joint in flexion and forward flexion and internal rotation, see what happens. right? That sudden sharp shooting sort of pain coming from the posterior labrum. That's what is instability. They will not come to you with a frank dislocation. Dislocators are different. But this subtle instability comes to you with pain and certain difficulties. You have to literally fish out the history out of them and then examine them and then make sure of what you are looking at. Associated lesions, what are typically present with this? A posterior Bankart, a reverse Hal-Sachs, you could have a lesser tuberosity fracture or a Hegel, or as they call the Polpsa, which is the counterpart of Alpsa in the back. The light bulb sign, I'm sure all of us have read about it. You sometimes get to see it. And this slide is on proper dislocations, not on subtle instability. So we are trying to differentiate those instability ones from the dislocators. So in a dislocated shoulder, obviously the abduction and external rotation will be painful. It cannot be brought from an internally rotated to an externally rotated position. And it may resemble like a frozen shoulder. And as a result, unreduced dislocations may be missed. So X-rays are a must. CT scans are good for bony lesions. My investigation of choice is an MR arthrogram. I know there's a lot of controversy. People say that since the advent of 3 Tesla MRIs, why are you doing arthrograms? I've been asked that question by radiology colleagues as well as orthopedic colleagues, but I really love the arthrogram. You can do it in a 1.5 Tesla or a 3 Tesla machine, whichever is available. And it brings out those subtle things, those subtle labral lesions in such a nice contrast. You can actually measure from, say you've got a labral lesion from 2 o'clock to 6 o'clock or a 6 o'clock to a 9 o'clock or whatever. You can literally measure them, calculate your number of anchors that you're going to put, and be prepared for everything that you're going to do inside. So I love the arthrograms. Continue doing them. Surgery, you need to identify the pathology and treat it accordingly. Soft tissue injuries are more common in subtle instabilities. You can do an arthroscopic repair, and it's a posterior capsular labral repair with a capsular shift. When I've done these, I've realized that the posterior capsule is not that thick and juicy like the anterior capsule. It's actually quite thin and flimsy. Inferiorly, it's all right, but then as you go up, it's really very dodgy. But the labrum is typically good if you've caught them in their instability phase rather than having been dislocated multiple times. The other thing is obviously the bony injuries, and they need to be considered despite the fact that they are not very common. And if you've got a big reverse Hal-Sachs, you can do a subscap transfer into it. If the retroversion is huge, dislocating again, you can do a glenoid osteotomy or a posterior bone block in some rare cases. But these are rare cases and you need to resort to these surgeries a bit rarely. I'll take you through some of the slides with arthroscopic pictures. You see, this is what you're viewing. This is in lateral position. You're viewing from the posterior portal. This is anterior, this is posterior. So it's like, the postero-inferior labrum is torn, it's avulsed. The video is not fantastic, but I think it does the job. You can put your probe inside. It just goes and disappears inside the labrum and shows you exactly where it's avulsed from the glenoid. No, this one. Yeah, this one is also video. So then you prepare it pretty much like you do your anterior instability. So here we have done use the same liberator, done a release, and then this is a switching stick just to figure out the extent of the tear and whether the release has been done nicely. You curate the bony bed onto the neck of the glenoid. Always do that with a shaver and a bit of a curate. Prepare it nicely, and then you put in your anchors, shuttle your sutures. I like to use the double loaded ones down below just so that I get two big juicy stitches, and you can make a mattress out of them or a simple out of them, whatever you fancy. Another tip has been, which has worked for me, is I've always put in 2 portals in the back when doing these, because I would typically view them from the anterior superior portal and then use these 2 portals to get the correct kind of angle for anchor insertion and shuttling of my sutures. And this is a completed repair. So you've got, I think, 1 stitch over there and a couple of stitches down below. So to summarize, posterior instability has a much lesser incidence than anterior instability, we all know that. But you need to suspect it in high-risk groups to be able to diagnose. The ones that have come to me typically have been into some kind of a throwing sport, some kind of an overhead activity, something to do with their shoulders. In terms of, I would say, repetitive micro trauma is probably happening, and that is how it is. The ones who dislocate are a different kettle of fish. There you have got one episode of some big injury happening, and thereafter you've got those posterior dislocations. But the subtle instability ones are typically the ones which are repetitive micro trauma. And they would come to you with a shoulder pain and a bit of clicking in forward flexion, internal rotation. You load the joint and you can diagnose it, get a feel of the click as well as the pain elicited. MR arthrogram is the investigation of choice, like to do it all the time, and then treatment involves surgery in symptomatic ones for an optimal outcome, depending on what exactly it is. Thank you so much.
Thank you, Gaurav. Yeah, the posterior instability can be quite disabling, isn't it? They cannot lift up anything. That's the main problem, isn't it? They will reproduce that click.
The moment they come into this position, they are in trouble.
One question is, it's already thinned out, isn't it? The labrum posteriorly is already thinned out. And with the repeated instability, there won't be sometimes, there won't be any meaningful labrum to repair. How do you address that?
So I do a bit of an extensive release and literally pull it up from down below and start bringing it upwards. So start more inferior. Inferior is where you will get slightly better chunk. If you come at, how do I put it? If you come at a position of say 9 o'clock at the back, right in line with the equator, that's where the capsule is going to be very flimsy, sir. You won't get it. Postero superior upwards, you will get good quality labrum. But, 9 o'clock position, you won't get much. So start at the lowest level and gradually go up. That's how you can make up for the deficit.
So will you take a capsule as well along with that?
A bit of capsule, yes, always.
Yeah, because otherwise it's going to be very difficult, isn't it?
Yeah, always take a bit of capsule. I mean, you are pretty much doing the same surgery that you do anteriorly. It's just that it's the other way around.
Thank you very much.
Is there a role of doing a CT in these posterior dislocation and finding the amount of bone defect or something like that in posterior instability as well?
Sunita, I always get the MR arthrogram. And if I'm happy with everything, seeing the MR arthrogram, it's good. If I've got some doubts, I can ask for a screening CT, take a few cuts and measure bone loss, if there is. So far, I haven't encountered that.
Sunit, probably with the recurrent dislocation, recurrent instability, I will definitely go for, and especially with the guys with the epilepsy, they are having recurrent episodes of instability when they have the episode of epilepsy as well. So I will go for a CT scan, a 3D CT scan.
Sometimes
and if
we do see that bone grafting procedures are also
exactly
done in posterior
I
instability.
got a low threshold for a bone graft, earlier class bone graft.
Yeah.
In case of epilepsy.
Not the instability. Okay.
Yeah. Those, yes.
Yeah.
Dislocators, not the instability.
Yeah,
That's absolutely right.
two different things. Yeah.
Two different
again,
things.
Just reiterating the same point. So frank dislocators are very different from these micro
Instability, yes.
So these instability patients, you really have to think or remember that this posterior instability exists. Only then you can diagnose it.
Harpreet, I take your point. See, this is a youngsters, and nobody will believe them. They got some problem, and
Yes.
The orthopedic surgeon, when they go, they take an X-ray and examine them. They say everything is normal, but they still have got that problem. So you need to meticulously examine as you
So
demonstrated.
two things I found useful for diagnosing these patients is one, yes, we have to remember. One is a Porcellini test, which we described by my mentor, Dr. Porcellini. Very useful test for this posterior instability, and always use a MR arthrogram. Without MR arthrogram, you cannot objectively diagnose these lesions.
Okay, Ayyappan.
It's a nice talk, and the clinical examination you showed was very, very nice and very, very classical. I said, what I was asking, in most of the cases, okay, which I see or all of us see would be very subtle, because it would be more of a posterior-based MDI kind of picture, And I think the Kim and the jerk test, what is your call on it? A combination of the Kim and the jerk test. If we do it, I think we can pick it up better along with the arthrogram.
Yeah, you could do that. To me, the first thing is, whenever I see a young person, young, I'm talking about late teens to early 30s group, come to me with a shoulder pain, having seen 2-3 people around, to me, the antenna goes up, he's got something on his labrum somewhere. That's the first, thing that comes to my mind. And then obviously the clinical examinations. And I have personally relied on a load and shift for eliciting posterior, anterior, as well as superior clicks. And that has worked quite well in my hands.
Right.
You lie them down on the couch and,
yes.
do those.
Yes. And what about conservative management? Okay, do we, do they respond well to conservative management? Because normally in my practice, I would do rehab for at least 6 months and see. So what would you do?
See, initially when they come to you, you can put them on a conservative rehab because most of these people I've observed have been overuse injuries. So they would have difficulties with their scapular rhythm. They would have some kind of a tight capsule. They would have certain things in terms of their posture, in terms of their technique, right? Tennis players, badminton players, snooker, volleyball, these kind of things, they usually have something in their technique, and I call them shoulders of abuse. They've abused their shoulders to achieve what they want to achieve in their careers. And yes, a bit of rehab is very much in order. You put them through first. My threshold is about 6 weeks. They have to come back and tell me that they are getting better. If they are not getting better in 6 weeks and we are not heading anywhere, then it's time for surgery.
Ayappan, I will say that those who come to you, your clinic, for help is the tip of the iceberg. There are a lot of people who have suffered that, and they learn to live with that, and they might have got the advice that nothing can be done. So they are happy with that, and they are content with that. But what you are seeing is the tip of the iceberg, and those are the ones who are really frustrated. They cannot do anything, they cannot perform. They will definitely come and pester you repeatedly.
Very true, sir. Okay, so they have been, all these are, as you said, very chronic cases. They've been actually going around seeing multiple surgeons and then coming. Very true.
Thank you very much.
Completely agree with
Thank you.
that, sir.
Very nice, sir. Very nice.
Thank you, sir.
Oh, yeah, okay. One more. That's the last question, yeah.
Yes.
Thanks. I am Dr. Purna from Hyderabad. That's a nice presentation. And what you said, sir, most of us learn to live with it. This is a classic example. Most of us arthroscopic surgeons, especially who do in B-chair position, tend to have posterior shoulder pain. There was a study in Canada when I was doing my fellowship, which among the arthroscopy surgeons, and there's a little bit of labral tear. So coming back to conservative, this thing, I myself have a posterior labral tear with a small cyst, which we tend to manage, of course, and we are not very good at doing physiotherapy ourselves. So what do you, for these patients, when you do an MR arthrogram or a 3T MR and you find a posterior labral tear and a cyst, who doesn't want to go in for surgery, or what is your, when do you advise surgery? What is do you go on the size, do you go on the cyst, or do you just go on symptoms? Symptoms, yes, as sir said, we tend to manage, but you have to, where do you draw a line? Okay, this has to go in for surgery, otherwise there is a chance for global posterior instability.
See, if you have got a big lesion, then I don't think there's much point in wasting your time faffing around. But if it's a small lesion, small cyst, conserve, see how they go, give them rehab, doesn't improve, bring them on table. That's what I've been doing.
Those are the patients who earn surgery. They won't leave you without getting a relief. They are fed up with that, especially the youngsters, as you said.
Yeah.
They cannot do anything. It's a really frustrating.
Really painful, yeah. When they keep coming to you back and forth, that is the time I think we should operate on them.
Exactly. It's I will equate that to isolated subscap tears. It's the same problem. They cannot hold anything in that position.
Yes.
Okay.
In those really who are not willing to go ahead, is there any role for intra-articular injections or anything in this, according to you?
I haven't done.
I haven't done myself, I just...
Okay, thank you very much.
Thank you,
And
sir.
that brings the end of the session.
Thank you.
Just to say, the no harm in trying conservative for 6 weeks to 8 weeks.
Right, sir.
And then if they are not responding, then you go for surgery.
Okay, they need to earn the surgery, isn't it? Yeah.
Yeah.
Thank you. That's the end of this session. That was a very lively session. Thank you very much.
Thank you.
next is failed bankard, and for case it is a case-based discussion, and the case will be discussed by Dr. Sridhar, and the panelists are okay.
So good morning everyone. First of all, I would like to thank the organizers and Dr. Rajiv sir for giving me this opportunity. So just bear with me, I had an old case, single case I am presenting now. That was a old one because I couldn't retrieve my latest hard disk data. So before starting of the case, I would like to call upon the panelists today, Dr. Jaiprasad sir, Subramanian sir, Pratap Kumar sir, Dr. Vikash Kapoor, Sir, please sir. So, I am Dr. Sridhar Gangvarpu from Vishakhapatnam. This is a small case, like a 20-year-old male had an earlier recurrent shoulder dislocations. So, he underwent an arthroscopic primary Bankart's repair elsewhere, and before present to us, he had a history of, again, dislocation of history of fall from bike. So clinically he doesn't have much swelling. He had a mild anterior joint tenderness. We have seen him almost after I think 6 to 8 weeks. So he had a good range of motion, and he had a apprehension test positive and a negative sulcus sign. So this MRI, I had a very few pictures now, had a shows labral tear, and CT, which is more important for us in this clinical scenario is there is not much bone loss either on the glenoid side or a major Hill-Sachs lesion on the humeral side. This is the 3D one which we could see. So there is only just a flattening of the glenoid anterior-inferior region, not much bone loss. So we'll just start off what are the management options of this case and how we'll proceed.
Patient came to you, he had a fall.
Yeah. He has pain, sir.
Other than pain, no other complaints?
No. After that RTA, he doesn't have any dislocation again. Yeah.
Only pain?
Only pain.
Well, and the second thing is, can you show me the MRI picture again? This is 1 year old thing, whether it is a rupture, lesion of the Bankart's lesion, or whether it is an unhealed previous thing. That is also a question to be answered looking at this MRI thing. So if he has got only pain, no instability symptoms, but he on examination you feel that there are anti-instability symptoms, this is a dodgy thing.
Yes, sir.
Because the patient doesn't have any instability symptoms as yet.
Yeah.
And you have got a MRI where the Bankart's lesion is exactly in place, but it has not healed or maybe re-injured. I'm not sure.
Can be either.
And if this is the scenario, it depends on the patient's occupation and his requirements, whether you want to go ahead straight away or you want to wait for some more time to see if the symptoms develop. That would be my approach.
Right. Jaiprasad, sir.
Same thing. Pain, we have to deal with the pain, and instability part, I think on clinical examination only you have the apprehension sign is positive. So he is not telling any instability. So wait for some time, physio, and check again.
Subramanian sir.
I guess has he got full range of movement now?
Yes, sir. Terminal, he had
because
that pain.
there are a group of patients who will develop anterior tightness after stabilization procedure. They will develop like frozen shoulder, and if that is a reason for pain, we also have to address that. But if he is not dislocating right now, it's not an indication for surgical intervention right now. So rehab and see how he gets on. It's you ruled out infection, all of the reasons for pain.
Those things are ruled out, sir. Because sir.
I'll rest him and then rehab him and then just wait and watch.
If we are planning for, if he comes up with the recurrent dislocations, like what could be our next surgical plan?
So if he comes with several episodes of recurrent dislocation, which you said recurrent dislocation. And then of course I don't expect an MRI picture like this. That is number one. So if I don't expect an MRI picture, it would obviously depend on what injuries I am getting on MRI.
Correct.
And if there is a bone loss which has come up, which is not as what you showed in CT scan, of course I'll be veering towards bony procedure straight away, rather than going doing niceties like trying to wait and explore and look at other options. And of course, bony procedure being for me a gold standard and a basic skilled latarja, of course not a play. I don't have any place of combining latarja with remplissage because I am an open latarja surgeon. So I don't do arthroscopic latarja.
If he comes with dislocation, you need to have a fresh workup to see what the CT scan and MRI looks like. And if CT scan looks with the bony defect, then I will go for latarja. Or sometimes there may be a problem with the original procedure, where the tissues have not been addressed properly. Then we should go ahead and address those tissues properly. That itself will sort out the issues.
Correct.
Here only 2 axial cuts are there. It is a coracoid level. It is around 1 or 2 o'clock position. The labral anomalies also will see a normal one here in this position, in this cuts, and we need lower cuts actually to know the exact labrum, exact bony lesion. Then only we can comment. Of course, there is no Hill-Sachs lesion. In recurrent dislocation, you will have a 70 to 80% of Hill-Sachs in recurrent, and even first dislocation you will have 40-41% of Hill-Sachs lesion. But it's nothing is there. But to comment on the glenoid and the labral tear, you need further down cuts.
I will slightly stay away from my previous speakers.
Supposing
with these findings, if the patient had a second history of dislocation or a third history of dislocation with this is the MRI and that is the minimal bone loss which is less than 10% or so, then I would think about that my initial Bankart's fixation was not possibly proper. I will go ahead, the labrum still looks good, I will re-explore. I mean, a failed Bankart does not automatically qualify for a letter J. It could be because of a failed initial technique. So I'll have a look at that. If I see that the labrum is good and the capsule is good, and then I will re-fix it, and provided it is not a person with a high demand shoulder, like a body contact athlete, like a that sort of an army personnel, then I will definitely redo the Bankart's lesion, provided the things are still good.
Yes, sir. Pratap, sir.
I missed the initial things, but what I see from here is a failed Bankart's surprise.
Yes, sir.
So,
yes, sir.
I need to know what is happening with the humeral side, so I need a higher cut.
We didn't have much. He's a 20-year-old guy, had a Bankart's done 1 year back. So after the surgery, 1 year he had an RT aero traffic accident and dislocated. So it doesn't show any major bone loss. Glenoid, no bone loss on the glenoid side and not much bigger Hill-Sachs lesion.
So hopefully there is no big Hill-Sachs lesion. So I will do I will do a revision Bankart's looking at the, but before that I will have a CT to make sure that everything else is fine. And probably I have a very low threshold to add a remplissage here.
Yes, sir.
Good.
So what are the management options? What we discussed now is to do a revision arthroscopic Bankart's repair, or do an open Bankart's repair, or a revision bankards along with the remplissage, or do a lateral procedure, open or an arthroscopic, or do an autograft for glenoid bone loss. But as we don't have any bone loss here, yes.
Can I just make a comment?
Yes, sir.
I don't know what extra benefit you are going to get from an open Bangar support compared to
yeah, I just mentioned the yeah. So what just options?
No, I just want to
convey to the audience, right, sir?
Which is much more yeah, exactly. It's going to be difficult.
The failed bankards, no, you need to remove the anchors also if it is there.
No, not always. No, it's going to be more damaging probably. Yeah, for that has to be thought in mind.
Sir.
You know, the anchors, the removal of anchors is not like removing your screws, from the plate and screw fixation. It can be sometimes more damaging. So we'll just accept that, leave it there, and then take it out. If it comes out, yes, fine.
Correct.
So if it doesn't come, you can punch it inside. And
you can. Definitely you can.
Punch it inside and put your bankards really good.
I'll come to that, sir. I'll just show the surgery procedure.
He got some surprises. Yeah.
No. We'll discuss that. So this, so we thought of as Devashish sir and Pratap sir decided it was in the same thing. We went ahead and did the same revision bankards, sir. So sorry, it was an old this thing. So it's more of us look like a failed procedure. Initial technique was a faulty technique. So the labral and the capsular tissue was very good actually. So we could see some of these fiber wires sticking out. And luckily we didn't have much anchors coming in our way. So we don't know how many anchors were put in initially. So we didn't struggle much. And technique was a straightforward bankards. It was like a primary bankards. What we had to do is only just mobilize little bit all the scarred capsulolabral tissue. So we removed all the fiber wires, took a knot and used knotless anchors and got the labral tissue back onto the face of glenoid. So it was not as expected, it's not a struggled one, it was a sort of primary banker repeated again. Lucky. So just for a discussion, what are the surgical factors which can cause failure? So it can be an inadequate mobilization of the labral tissue by the initial procedure, poor anchor position, it can be an inadequate tissue tensioning, or it can be a failure of the implant or the knot, or it is maybe difficult to address the bone loss or associated injuries. Most commonly we are carried about to look for any other associated injuries, cuff tear or any posterior labral tear or any slap tears, anything. So soon after we see Bankart's lesion or from the patient's history, we jump on to Bankart's repair. So we should definitely evaluate the patient both clinical and radiologically and see whether any associated injuries. So now we'll just want to ask the panel about the anchors, sir. What Jaiprakash sir was asking, like if at all metal anchors comes in our way, or if I think peak anchor comes, it's not much difficult. If any old metal anchor comes, what could be our bailout position? If it comes in our way.
Only if it's main thing is the prominence of the metal anchor, which can be a real menace. We need to have to do something. Either we'll have to take it out, and if it's extremely difficult, as Jaiprakash said,
sir,
we need to duck it in. Which we need to punch it in so that it won't cause any mechanical problems taking off the hyaline cartilage out of the.
Sure.
And then. Nowadays it's easy because we got a new anchors which is smaller anchors.
Absolutely.
So we can do multiple anchors and what I will prefer is I will in revision cases I will tend to use double loaded anchors.
Yes, sir.
Yeah.
Well, in my practice, that if we find that the bony anchor is well anchored with good soft tissue or cartilage cover, I don't touch it. Only if it is proud, I try to remove it. If you cannot, then you punch it inside so that it doesn't cause any abrasion of the thing. And I use now most of the time all suture anchors, which are much smaller, 1.4 millimeter in diameter. So you can just place it 1 millimeter this side or that side of the proposed position, doesn't cause much of a harm, and you can jolly well get away with that.
Right.
Try to see the osteolysis around the metal, any infection, that also you need to take care, and try to remove. You can struggle for some time and you do all your instrumentation and try to remove. Then punching is the last option. Damage your own
But here,
yes, sir.
proud metal anchor is a big problem because it's going to cause future for degenerative arthritis. Yeah. Taking it out is also not very easy.
In the process of taking, we may damage the cartilage
yes,
more
of
than
course,
that.
Yeah. So, and it all depends on how far deep they have gone in.
Yeah.
Sometimes they would have gone right down to the half of the articular surface.
Correct.
Then inevitably it will be a degeneration. Inevitably there will be damage
especially
to the articular
anchors
surface.
placed in the inclination position.
So if you are, nowadays I think we are avoiding metal anchors. If you are bury it very well.
Right.
If you see the proud metal anchor, then one of the ways I have taken over drilling around and take it out.
Right.
And then use another anchor like all switcher anchor or a peak anchor can be used. But it's a nightmare, I have to say.
Correct.
Because I've had few occasions where to taking out a metal anchor, I use a over drilling with the 4 mm cannulated drill that we use for the ACL, bead pin drill. That can be useful for over drilling around. Or you just have to put multiple K-wires around a metal anchor and try to pull it out. Occasionally, I have also tried to fit in that original metal anchor's holder into that thread and try to unload it.
That is if
that
you
has
know
happened
about
only
the anchor.
once.
If you are the primary surgeon.
Yeah. No. Even if I have done with others also, one case. Yeah.
Okay.
But you have to exactly fit in the right place and try to unload it.
Right.
It has happened only once.
You need to be
Should be really lucky enough.
It was lucky that day. That's all. Yeah.
Lucky enough.
Listen, there are several aspects to what we are discussing. One is this is what absolutely is the right way to go. But if you look at 3 strong metal anchors placed in a small glenoid, and you are trying to use a frail tissue which apparently is really not working, and you want to put anchors around that metal anchor, so you have a very small window. Basically you have only 2 portals, same portals through which you are working, so your angulation is going to be similar. It's not going to be very different from what those metal anchor placements have been. So for me, if I am going to do a metal anchor done failed bankards, why I discussed latter J initially was the experience is that most of the times it is a difficult skill and to get a tissue of that quality to get it back there. Number 2, these metal anchors and your direction of putting the anchor is almost similar. So what he was saying, taking it out, fighting it out, it is a time consuming process. And we are working in a limited time constraint and you want to give patient a definite result. The problem comes, that's where I come into latter jaw early. So that is why I have a predilection of revising most of these failed bankards with a latter jet surgery, not just because of your bone loss issues.
These are the cases where I won't put any time constraints beforehand. And how much time will I take? Whatever time it needs.
I fully agree, Kapoor Singh, and you don't know how much is the capsule healthiness. So take the consent for both converting into lateral J also.
So in that scenario, can we do a diagnostic scopy? And if you are doing an open lateral J, do a diagnostic scopy. If tissue is bad, then
definitely. See, here you have shown that the tissue is pristine.
Very good.
Very
yes,
nice, very nice, and you've got a meaningful labrum there, which is there to be fixed.
Yeah.
No, even if
Removal,
metallic anchors, yes. Yeah.
Sridhar, may I add something?
Yes, sir.
As Debashish and other people were saying, that is true. But if you yank it in, you press it in, or you remove, there is a hole left. So still that area you still cannot use.
Yeah.
So working around, if it is sprout, then we are stuck, and we have to use things. But if it is there, we do find with the smaller anchors all inside, some of the space either a little bit more onto the face, maybe above and below. And concept of latarge is there, but if there is a bone loss, if there is no bone loss, then we are really stuck, because even if we do latarge, it's going to reabsorb, we know that. So then we have to find a way there only with some anchor somehow or the else.
That's where dilemma comes. If there is no bone loss.
If there is no bone loss, then Letargia is a procedure, but it's likely to fail. Bone is going to reabsorb, and we may not get the desired result.
Yes, sir.
So then the best is to find a smaller anchor somewhere a little further, on the face, which will work.
Yeah. So regarding anchors, like implants, like any specific in a failed scenario, like in a knotless anchor, knotted anchor, or all suture anchor.
No, I will prefer to
any
use
specific advantage.
Yeah, the specific advantage is if we can use small anchors, we can use multiple anchors. So already the space is constrained. So I will use all suture anchors, which will give us, so nowadays we got 1.3 anchors, millimeter anchors, and if I can use 1.8 double loaded, if I can do that, I will go for that, double loaded 1.8. Otherwise, I can use a multiple 1.3 anchors. We got space, and as you said, the concern was the bone loss even after removing it. So we are aware of that, but we are happy with the small anchors.
Absolutely right. Ditto. Same.
So, especially for a soft tissue procedure, if you are doing a revision Bankert, so we should be aware of the contraindications. So if there is any critical glenoid bone loss, if the patient is a contact athletic or a high demanding individual, or if it is a engaging Hill-Sachs lesion or any hyperlaxity, definitely I think we should think about a bony procedure rather than a revision soft tissue procedure. So take home message, always in a revision scenario, obtain a 3D images, 3D CT as the earlier speakers have told, NFACE CT images. So you have to spend enough time like in a primary Bankerts for mobilizing the capsular labral tissue, because the initial mobilization may cause a lot of scarring. So we need to spend double the time of the initial primary procedure to remove all this scarred tissue. So as we discussed, removal of the previous hardware is a nightmare, and it's a very difficult task rather than doing a revision scenario. May need some of the anchors, may need a larger one if there is a very poor or an osteoporotic individuals, and may need some of the accessory portals like anteroinferior or posterior if you are not getting your angle right. So sometimes you may need to add remplissage if it is necessary. Thank you.
Thank you for
sir.
that.
So from arthroscopic to bit a different scenario. So I will present a case of neglected shoulder dislocation. So this is my patient, a 23-year-old male, single episode of traumatic dislocation. He presented to us 6 months post-injury. He had a probably healed GT fracture also. So I'll go to the panelists to go for the further opinion and plan of management. I'll go from the Vikas Kapoor sir. What is your opinion? How do you evaluate, and what are the further plan of management in this patient? First time dislocated, traumatic dislocation with a healed GT, anterior dislocation, no distal neurovascular deficit, obvious deformity, functional limitation, all component there.
And it is stuck. It is stuck in this dislocation.
It's stuck. So what is your plan? What is the offering to the patient? What are the investigations and planning?
First investigation would obviously be a CT scan.
Okay, sir.
So you have it?
Yes, I have it. So any panelist, any other investigation you will suggest? Subramaniam, Dr. Pedda.
I usually do CT, MRI both.
CT and MR both?
MRI both, and this will need open reduction.
Okay.
And it will be a difficult procedure, but you can do open reduction and fixation of GT also. He is a 23-year-old.
Yes.
So we need to go and do procedure. Yeah.
Okay. Anything else, Dr. Pedda? Yes, CT, MR,
Same,
CT, MR both, or
CT, MR both.
Okay.
Both. Because these people will have a rotator cuff days.
Okay.
So you need to know the GT rotator cuff status, and other labral injuries also you will have. So those things you can tackle with the open, definitely open.
Devashish sir, both same. Sir, Pratap sir, same.
We'll go with the same, yeah.
Yeah, okay. So we don't have did an MRI. We have a CT. So CT cut shows that there is a GT fracture also. Somehow it has healed some portion with a obvious depression there. And this is our 3D cut.
So we don't have done MR. Sorry. Any other investigation we will offer to this patient?
Nerve conduction.
Before nerve conduction. Anything else?
Occasionally people can have vessels going nearby.
Yeah.
If they are having any doubt about the angio.
Okay. CT angio.
I had one
yes.
occasion where we had patient come with vascular injury also same time.
Okay. So NCV?
No. When you are exploring it, it can suddenly you can go into
NCV and the CT angio. Okay. So CT angio we don't have the cut. So, but we did a CT angio pre-operatively to see the where the it has gone. So the next plan of management, I think everybody in the panel should, it's an operative procedure, no question of keeping this non-operative. So in a neglected shoulder dislocation, when we don't touch, Sir Pratap sir, what is your opinion?
Well, it's in neglected one, first 6 weeks, especially this age,
yeah,
I will still give a chance to
6 months. 6 months down the line.
I was telling, this is a 6 months, but he is an youngster. But up to 6 weeks, I can do a manipulation and see, because his bone is stronger compared to a 60-year-old.
Okay.
After that, I won't touch. I will go for directly go for an operative procedure.
For every patient, it's an old patient, limited functions, or everyone you will go for open, or any scope of not doing surgery in a neglected shoulder dislocation?
Well, only if it's a completely dilapidated patient, medically unfit, older patient. Otherwise, no, definitely I will go for it.
I'll tell a small story. When I was a registrar in UK, middle of night, a patient came, 89-year-old, came from a nursing home, that means their old age home. She had a fall from the cot and injured her shoulder. The attending nurse has sent the patient. On X-ray, there was a shoulder dislocation. So we said, chalo, we will reduce it. I tried and struggled for half an hour. My senior registrar was there. He struggled for another half an hour, and none of us could do it. So we said we should then go for open reduction. Fortunately, by this time, this big file came out from the medical archive, and we found this lady was living with this dislocated shoulder for last 4 years. So that's the point I was going to say. For elderly patients, sometimes they are often associated with rotator cuff tears, very difficult to reposition and redo, and they are mostly asymptomatic with minimal pain, and I don't know about the function. So they can quite often be managed conservative, matlab leaving it alone. But other than that, a person like 23-year-old, that does not arise that question.
Okay, so I go to the straight to the surgical technique. So my approach was deltopectoral, and I did a coracoid osteotomy, and I had released the bicipital rotator interval. So I had a difficulty to going there, but I released the rotator interval. I go along the rotator interval, go to the glenoid, release all the soft scar tissue, and able to reduce it. I do not find any significant bone loss. I find it to be stable. So this is my post-op X-ray. I fixed the coracoid back with a CC screw. So anything you want to add to the panelists?
Yeah, this is one of those situations where you won't get any brownie point for a smaller incision. I will make a bigger incision, and I will protect all the tissues, whatever tissues. He's already is a young patient, so do no harm. So I will probably make a bigger incision to see what exactly it is, and then reduce it. And I will use, how did you reduce it? Did you use any instruments?
Bone lever and these kinds of
instruments. Because I don't want to put any stress or any rotational force on the neck of the
that may fracture the
That's the last
humerus.
one. Yeah, that's the last. So we don't want to put add another fracture there. Well, it's going to be a nightmare, and it's going to be a very difficult situation then to present to the bystanders as well. So do a release step by step, and the moment it gets reduced, we will stop that release. And then whatever you release, we need to reattach.
Sir, Devashish sir, anything you, Dr. Pedda, anything you want to do?
Why you have done coracoid osteotomy?
To do for better release, better visualization, I have initially done a coracoid osteotomy after getting the skin incision.
In a young patient, in 6 months, there is no need for coracoid actually osteotomy.
Okay.
And you can release whatever the structures which are obstructing, mainly the biceps tendon, that will hamper
Yes,
your
yes.
accessing into the joint, and it will obstruct your relocation. So that you can do biceps tenodesis and leave it. As the most of the time you will get little struggle you have to do, but you will get.
That's the anticipation that I will
okay,
struggle.
Okay. Yeah, there's no harm actually.
Subramanian,
Yes.
anything you want to add? Any procedure? You are talking about GT, so we have done nothing to the GT. So would you do add anything else?
I think the first objective is getting into the joint, which you have done it.
Yes.
So that's okay. About graded tuberosity, it's already malunited.
Yes.
And we just have to make sure the rotator cuff is still intact or not. If that is fine, just leave it as such. Start with the rehab.
Okay. Kaput sir, anything you want to add? Okay, this is a 4 weeks post-op. I'll just go quickly.
Here.
Yeah.
Can I just ask
Yeah.
a few questions to the panel as well? So now, all of you are discussing, we are discussing that it's like 6 months or maybe like 8 months, 9 months, 1 year. So now, if it's a persistent dislocation like this, don't we have a lot of subscap contractures? So getting the joint would be a little difficult, I guess.
Exactly.
So
That's why
subscap tenotomy.
That is where the serialized release comes in.
That also, and you have to release the subscapularis from the origin also, and make no mistake, you have to see it well, release all the contracted tissues to get it back. And yes, carry on.
So subscap, maybe a L-shaped penotomy would be better because to get the contractures in place.
Yes,
and again, I think one of the important things you would have found difficult is the connective tissue inside. To visualizing the glenoid also would have been quite difficult, I guess. So so like if it is in this scenario, for example, if it is unstable still, it's better to do a Latarjet of there.
Yes, that's the other thing I was going to tell. I was thinking in my mind whether to say not. If it was good and stable like this, it is a first time dislocated, this is perfectly logical. But had it been, if you had any doubts, because you have already done an osteotomy of the coracoid, why not use it like a Bristow at least in front of the glenoid?
So that was we planned. We think if we find that it's unstable, we will add this osteotomy to the glenoid.
Yes.
So.
So just to add on that in the interest of time, continuing with the same question, you said there was no bone loss, but if we go
no
back
significant bone loss. If you
but
go to
if
the
we-
CT.
most of these, what I have seen is the GT fractures and the posterior Hill-Sachs defect kind of coalesce with each other. They might not have more of anterior glenoid defect, but what are
Posterior
you
superior
concerned
defect,
about
yeah.
when the patients abducts and external rotate?
But still, this is the first time dislocation, so give him a chance. I mean, the joint was dislocated
yeah,
for
that
6
was my
months.
concern. I would have added a Latarjet for this, but yeah, I agree that there are other opinions as well.
So this is the 4 months down the line. I think he has a reasonable range of motion. So I'm
Good.
going to that video. So left side is the surgical site. I think he has a reasonable range of motion and no history of dislocation.
And you must match your procedure with the patient and his expectations. This is a patient from a different category who is living with that for 6 months. So for him, how far and how much you do, how much post-op physio he will listen to, and his compliance, everything should be taken into account before prescribing your procedure.
So I think that's the take-home message. Young patient, always try to reduce how old it is. So thank you to the panelists.
Thank you, very, very well presented. Thank you.
Our scenario is good morning again. So we are going to tell about something about ligamentous lax individual and dislocation. I thought I didn't know that it was only 10 minutes for us. I kept 4 cases. So I'll try to show in a very quick mode, okay, rather than just to highlight some important points so that we have some take-home message. So we have this gentleman who is 26-year-old male laborer, fell at home 3 years ago, had dislocations many times, and has got signs of anterior instability with ligament laxity also. Anti-operation is positive and relocation is positive. Let's skip that slide. And glenoid bone loss is around 9%. Roughly around 9 to 10% what he has got. Okay. What will be the management plan? Pratap, Bankart, arthroscopic Bankart repair?
Well,
Bankart and remplissage, Latarje?
I hope every other thing.
This patient has got ligament laxity also.
Okay,
so all of my patients whom I'm going to show have got ligament laxity.
Fine. Okay. My first thing is not to touch the patient surgically. Have a good rehabilitation, strengthening, and scapulothoracic movement synchronization. And if that fails and the patient is still having problem, as he said, it's a anti-apprehension test is positive. Many a times what happens is you will have, even though it's a multidirectional instability, one direction will be predominant, and then I don't have a problem of going in and doing, if it demands doing arthroscopic Bankarts. I will take the capsule as well. I will do a capsular shift, and I will do.
Bankart, you need to also do some capsular procedure also, where you have to tighten the capsule because they are already having a ligament laxity. So what I have done is did capsular tightening plus Bankart repair plus remplissage also, because you want to play safe. In a person who has got ligament laxity, there is a very, very low chance of getting post-op stiffness. They don't get at all. So try to reduce the capsular volume as much as you can, and the literature supports that also. These are 4 months post-op. And there are occasions where you do anterior capsular labroplasty and posterior inferior plication, plus measures to try to reduce the capsular redundancy, like remplissage. So you try to add all the procedures together in such a scenario. That's what the message I want to convey. So next is I have this patient, which is a 20-year-old chap.
Suprasad,
yeah.
One question. So like when we look at the failures, the paper by Boileau, so the recommendation is also for trilat procedure. Trilat procedures, they are for hyperlax. So any take on by the panel?
Trilat procedure, the Bristow procedure, this Letarge procedure, they are all different methods of bone blocks, these things. But I don't have any personal experience of this trilat thing, but we have done Letarge and of course Bristow. So
no, Letarge has got its own benefit, and there are papers which have shown that Letarge for a hyperligament laxity has shown low recurrence rate also. We'll come to that in a minute. Okay.
Yeah,
this patient who has got a fall while playing kabaddi and apprehension test positive, relocation positive, and that's his situation. And he has got a bone loss of about 12.5% bone loss is there. Management plan. No, he is a 20-year-old chap, young chap. Active sportsman. Kabaddi, he was playing kabaddi.
Can I? Okay.
Yeah.
I think with that patient profile, I will intend to do a lateral procedure. There's nothing else I will go for.
It's a very small bony lesion, 12%. I think it's overrated, maybe even 10% lesion.
Look, Subha, the option here is between either if you want to go soft tissue, then you have to do an arthroscopic Bankart with remplissage and capsular plication, number 3 or number 4. It depends on the patient's profile and degree of laxity and your judgment. The first one is a manual laborer. I would imagine it would be difficult for him to go for a second, third surgery. I will go later jet for him. If he is a student, an occasional recreation player, then I can as well try Bankart, capsular plication, remplissage first. And if it doesn't help, then of course later jet. That is the basically judgment that you take.
Same thing.
Would you agree with the same, or
same.
What is your?
This is a bony Bankarts.
Yes, it's 12.5% lesion.
Yeah.
As per the measurement, okay.
And therefore, the threshold of doing a lateral J is very low. I would prefer to go for a lateral J straight away rather than going for any capsular procedure.
I think coming to what Ayyappan was telling, actually in such cases where I went for lateral J for this patient, And there's something called subcritical bone loss. I think already this paper has been mentioned, where the threshold for critical glenoid bone loss is supposed to be 20%. Now it is slowly coming down to about 13.5% is the current cutoff in young athletes who are involved in collision sports, that kind of individuals. And this is 12.5% is our patient with the laxity. Hence I went for Latarje, and he's doing okay. I think the threshold for
physiological surgical procedure is completely unphysiological. So I don't agree with the for primary Bangard's lesion doing a lateral J. I don't know. That's an overkill.
Subra sir,
quick
one question. I think you had not done a pre-op CT for this one, for the patient that you showed.
Yeah.
Now, had you done a pre-op CT
and
had that shown a nice chunky bony Bankard's lesion that you would think that you could put back in place.
No, that is a
would
chronic
that
case.
change?
It's not an acute case. It's a chronic case.
You may
It's
still,
a
in a
pre-op.
chronic case,
X-ray
you may
was
still
still.
have one chunk of bone, and maybe that could have changed your decision, and you would have thought, okay, I can bring the entire capsulolabral complex with this chunk of bone back onto the face. Let me try and do it. Maybe.
Fine. Yeah. So just a quick opinion about this patient. What do you wish to do? Dislocating many times. He is a habitual dislocator also. What will be your plan of management? Bilateral. Yeah, everybody agree? As for failures, adding capsular tightening to reduce the capsular volume should be the part of the procedure. Low threshold for a bony procedure. For MDA, rehab is a mainstay of treatment. Thank you. So, just to remind you, please all of you register for IAS Con. Yes, I think we missed that slide, yeah. So, this is on September 15 to 17. All of you register sooner. April 15 is early bedtime. Thank you.
So there is a slight change in the program. Before the cup session, we will conduct the debate session because Dr. Naveen Khan is supposed to leave early, and the debate is on open versus arthroscopic cuff repair, and the moderators are Dr. Amit Joshi, please, and Dr. Mukesh Ladda.
So, Dr. Naveen, you will be speaking on? Mini open. Okay.
পিছনে জ্যাকটা লাগিয়ে দেবে এটা ল্যাপটপে
Thank you.
Good morning. Greetings from Biratnagar, Nepal. I am Dr. Naveen. First of all, I would like to congratulate Indian Arthroscopy Society and Kolkata Arthroscopy Society of Sports Medicine for this conducting first IAS Sportscon. The debate of today is mini open versus arthroscopic rotator cuff repair, and wrongly it's written on the brochure open. It's not open nowadays. Nobody does open. It's mini open. I'll be talking. there is nothing to disclose pertaining to this talk. Now, whenever there is a debate is between two individuals of equal caliber or maybe near equal caliber. But when you see this debate today, the debate is between Dr. Devashish Chatterjee and me. If you see the profile of Dr. Devashish Chatterjee, he is doyen of arthroscopy and he is just like a Bengal tiger. He is so much experienced, and I have seen in last 2 days. If you see my profile, I am like just a week there like this. Now you can understand how many minutes I am going to stand in front of him. I will immediately kick me out. But again, Dr. Rajiv has given me the talk, so that has to be done. So the rotator cuff surgery becoming nowadays more common as the diagnosis of cuff tear is becoming more common. And it is very important, as we know, this is important for the shoulder function. It provides fulcrum to the deltoid to elevate the limb. The factors affecting the outcome of the rotator cuff tear mainly repairability, whether it's repairable or not, geometry, how large is the tear, healing potentials, what is the duration of the tear, and what's the age of the patient, whether that is going to heal or not, and the communication, how you have talked with the patient, that is very important. Methods, open, mini open, that I will be favoring, arthroscopy assisted mini open, and the all arthroscopy that Dr. Devashish will be talking. Now, ability to perform a technique is not the indication to perform it on patient, whether it's arthroscopy or any other procedure. How you choose any technique? One with a better result should always be chosen, but if similar results are there, then simple and cost-effective methods should always be chosen. If you talk of arthroscopic rotator cuff tear, it's technically demanding, as we know, it's time-consuming. There is a long learning curve, it's instrument-dependent, and so the cost increases, and sometimes you have to also use a special type of implant that again increases the cost. The proposed advantages of arthroscopy is basically gives better outcome, less post-operative pain, less stiffness, and cost-effective. These are the advantages. Now let us see through the certain randomized control trial and the meta-analysis whether this is true or not. So I have collected some of these cases. The study, that's the meta-analysis comparing the both all arthroscopy versus mini open, found there is a similar outcome in both the groups and can be intensively used. Another study in 2014, again they compared both mini and arthroscopic rotator cuff repair, no difference. A study in the American Journal of Sports Medicine, again they found there is no difference in both the cases. See, so many cases, so many reports is there. Randomized control trial in 100 patients that's published in Arthroscopy Journal do not significantly differ. Another study in the European Journal of Orthopedic Surgery Traumatology, they went one step further. What they said that both the procedures have the good outcome after surgery, but among both the procedures they are equal. One step further, what they say that the displayed substantially equal outcome except for higher re-tearing rate. In the arthroscopic repair group, they said there is a more re-tearing rate. Another study comparing the quality of life impairment study, again they found there is no difference in terms of subjective and objective outcomes. So many number of studies are there. So till now what we have seen, the outcome wise both the procedure is equal. Now what about the early post-operative pain? Again there is a study, they found there is no significant difference in early equivalent clinical outcome in early posterior period. Stiffness, again they found, American Journal of Orthopedics, they said there were no cases of intractable stiffness and there were no cases of deltoid damage. So what we have seen is the outcome wise, immediate post-operative pain and stiffness is comparable. When all things are comparable, let us come to the cost. Now what they say is that the mini open cuff repair technique requires significantly less operative time, so of course less cost. Another study, they found arthroscopy yields similar clinical results but at higher cost compared to the mini open rotator cuff tear. So everything same, cost less, so definitely the technique is preferred. Cosmesis, you can talk of the keyhole surgery and this. So nowadays with the modified technique, the incision is not very big. It's 3 to 3.5 centimeter long incisions, and none of our patients wear this type of dress where this is of more concern. Now let us talk about technique. Usually my preferred technique is the anterior longitudinal incision over the anterior border of acromion. It's just in order to have an advantage over the transverse that I can go proximally and distally. Another advantage is axillary nerve runs from posterior to anterior, proximal to distal. So you have a 6 centimeter space. So no way you are going to damage the axillary nerve. Skin subcutaneous tissue cut. The deltoid is split at the border of anterior 1/3 and posterior 2/3. And only in the very massive cases you have to add a horizontal limb, which is most of the time not required. Then we take out the anterior hooked acromion from there, or calcified acromion, that's the acromioplasty. And we have to protect the acromion. The margin of the acromion anterior to the clavicle can safely be removed. After that, we take out the bursa. Then the exposure of the rotator cuff is done. This is the classical pattern. What will you observe? That's the crescent U-shaped type of tear. And another advantage again of the mini open repair is here you can now figure out how your rotator cuff can be brought back to the your arthroscopy to the greater tuberosity. That I found relatively difficult in the arthroscopy cases. So you figure out and then can bring back to the greater tuberosity. Then you have to mobilize the rotator cuff proximal distally. You do the debrided, remove the sclerotic bone part from there, use rasp. Sometimes we also add microfractures and make a rounding of the greater tuberosity. That we call it as a reverse acromioplasty. There is a various repair technique, transosseous, single row, double row. In order to reduce the cost, the technique what I usually prefer, I put a single double loaded proximal row suture, and the distally I make a transosseous tunnel, and that act as a double row equivalent. This is the case example, 50-year lady. She was a housewife, pain on the right shoulder, overhead activity for last 1 week. On clinical examination, it's not running. I am asking her to elevate. The moment I left it, there's a drop arm test positive. So there is a massive cuff tear. On MRI wise, the TOR has gone up to the musculotendinous junction. There's the massive cuff tear. And post-operatively, you can see after mobilization, we have to use a traction suture, and anyhow we are able to bring back to the greater, after releasing it with the traction suture, the cuff is able to bring to the greater tuberosity level. And as I said, I use 1 or 2 anchor suture, double to triple loaded, and pass it from anterior to posterior, posterior to anterior, and from transosseous part. This is the way I do it. So this is the anterior, posterior suture were passed from posterior to anterior, and a knot is made, and it is give us something like this crisscross attachment and the knot being made. This is a final picture. Superior, you can see medial loss, single row is there, and transosseous suture being made. Again, you can see the incision wise is very small. Post-operatively, 3 weeks abduction pillow, passive range of motion for 6 weeks, sling is given for 6 weeks, active assisted range of motion 6 weeks, and straining exercises after 3 weeks. This is post-operative, 6 months. She was able to elevate the limb and can do her all activity. Sometimes you might not be able to bring to the greater tuberosity, where you can just up to what level you bring in the articular surface, you make a trough and you do a single level. So why you to prefer mini open is basically simple, allows anatomical repair, cost effective, deltoid splitting is not morbid, and you have an arthroscopy instrument that can be used to suture such a device. And finally, I would like to just summarize with this simple ad, what we all grow seeing this picture. The sound is not there. Can you please? We all have grown seeing this ad.
जब वही महंगे दामों वाली क्वालिटी, वही सफेदी, वही झाग, कम दामों में मिले, तो कोई ये क्यों ले? वो न ले?
Thank you very much, and I also would like to invite you all for our this next Saarc conference will be in Pokhara in 2013, and I would like to invite you all. Thank you very much.
Excellent, Dr. Naveen. Now, Debashish sir.
Yes. Firstly, I thank my opponent for putting a beautiful picture of mine. I don't know where he got the picture from, but I like it. Rotator cuff repair, open versus arthroscopic, honestly, it is not a debate at all. Because we all know in today's world that it is an arthroscopic or endoscopic procedure which rule the day. Because if you have access to both procedures, if there is no cost restraint, there is no difference in learning curve, there is no difference in your training, then of course you will prefer that, and you will prefer that for your shoulder and for your relation's shoulder also. And that is further proven by the fact that if you look at last 5 years, there is hardly any paper in the literature, except this one I found, that arthroscopic mini open, open, and the open, three types of repairs amongst the American Board of Orthopedic Surgeons examinees. And you can see how the open, mini open things are coming down and how proportionally that is going up. And why? Because in conclusion they said, more specifically, our study showed that lower rates of medical complication, surgical complication, reoperation and readmission in the arthroscopic group. That's it. I could have said just that and stopped there. But because it is a debate and I'm given 10 minutes of time, so I'll speak few more things. So what is the open disadvantage? The main disadvantage of open surgery is in rotator cuff exposure. Anybody who tried his hand, he knows that there is a limited exposure, and which is more important for big or massive or retracted tears. And if you have to do an interval release, it is almost impossible. You have to do it blind. And open approach always provides a limited exposure and tends to force the surgeon into a medial lateral mindset. You can hardly bring it down to the greater tuberosity. And that's why arthroscopic surgery is performed with one assistant. Here you need 2 or 3. And this is not me. This is the last documented paper of actual comparative study between 2 groups, and that was done in 2005. Please believe me. And the same paper by Edward Bush, he said that the main disadvantage in the open group is pain, and the overall patient dissatisfaction was 80%. Satisfaction was 80% for open, whereas it was 92, 93 for arthroscopic, the main reason being persistent pain. The open cuff repair has got the reputation being immensely painful in the first post-op week, and the pain reduction was impressive when these people changed from open to arthroscopic, and their anesthesiologists have also stated a proportional decrease in the need of analgesics and region blocks. So pain is a big thing. Stiffness, they counted in this comparative study that it was frozen shoulder occurred much more in the open group compared to the arthroscopy. Even the infection is not uncommon in the open group, which is virtually unknown in arthroscopic. Undue acromioplasty and deltoid detachment in some cases in open repair, and that also adds to the pain and further weakness and stiffness. This was their proposition. These mini-open patients, they seem to have more post-op pain and less range of movement. That was another meta-analysis that was done in 2008 by Kenneth Morse. And they said increased incidence of stiffness in both mini-open and rather than the arthroscopic things. And same thing about infection. Both groups have, both papers have said increased incidence of infection in these open groups. Only one so-called advantage of open they have pointed was initially it was proposed that if there was an ability to make a Mason-Allen stitch, but we do that now arthroscopically as well, so there is no difference. And the restoration of these footprint, that makes sense, but there is no published data to see any advantage of that. On the other hand, again, I'm coming back to the Edward Bush paper in 2008, which said the advantage of arthroscopic is that the patients had a significantly better decrease in pain and better functional results concerning mobility. And that's why the satisfaction rate was overall much better. And it is as likely to be successful for small and for large tears. And you can see the tear pattern comprehensively and make the right decision. You don't have to make always medial to lateral repair in arthroscopic things. So in conclusion, why it is better? If you have access to that, number one, better view, better access and assessment of tear pattern. It is minimally painful, which is a big ask, big question from the patients today. It is better and quicker recovery of the range of movement. And you can also, another important thing, you can manage associated glenohumeral pathology, which is difficult in open. And as they said, that lower medical complication, surgical complication, reoperation, and readmission. Thank you.
Thank you, Dr. Debashish. Dr. Naveen, you want to say something again?
Rebuttal. Yes, yes.
I absolutely agree with sir, no problem. But sir has talked everything about open. I am not talking open. I am talking mini open. It was not classical, very long, large incision. So the many of us maybe resistant conditions where many of the places arthroscopy might not be available, or if it is available, then also time consuming. So today my indications for mini open is especially in the supra or infra tier or the superior subscapulary stair, where the time constraint, number one. Another is the cost. Cost is again very important issue that suddenly reduces the cost. So these are the indications where still I think many of us also might be in Kolkata also, many of us might be doing the mini open, and this is the way go forward. But definitely the sir, whatever advantage this was, I agree with him. That was classical open, big, larger incision used to be given earlier. But nowadays we have reduced the arthroscopy portal hole, 3 portal hole will be equal to the mini open procedure.
Well, in my book, hardly there is any difference between mini open and open. Open is open, whether mini open or maxi open doesn't really make much of a difference. I'm not a big fan of that. What would be the difference is your extension proximally, because you have to mandatorily do actomioplasty to increase your vision. That adds to the pain and further factors. You may have to extend it further. Those are the things. Whether it is 5 centimeter or 4 centimeter does not make much of a difference. That is number one. Number two, as you have said, that if you don't have that facilities or that enough training or that much of this money with the patient, this is of course an option, but of course this is a second option, not the first option. That's what I made.
Now what I want to add is what Dr. Naveen is saying. Mini open means arthroscopy assisted mini open.
No,
that is different. Where
well,
you try to do it.
Yes and no. There are two types of mini open.
Yeah.
He is
so
not arthroscopic assisted.
if you do arthroscopic assisted mini open, that has got almost equal advantages like arthroscopic rotator cuff repair. That has been very well shown in many studies. So that is something which everybody has to appreciate.
Please stop. We are talking about open or mini open group.
Mini open is actually very difficult.
Yeah.
Exposure will not be there. Very difficult.
That's one. If you tell me if there is one difference or rather two differences, number one is view, exposure, and number two is the post-op pain, especially in the first 1 or 2 weeks.
Let us wait. I think the debate is going too long, and we couldn't solve it for so many years. So how we are going to solve it in 10 minutes? So probably whoever is doing what is they are trained to. Deb sir also said that it is dependent upon how they are trained, what are the availability, and I'd like to thank both the debaters on making this very interesting and very audible and acoustic to all of us. Mukesh, you want to say something?
I agree. Dr. Naveen, we all started with open, shifted to mini open, and then came to arthroscopy, and we all know what are the disadvantages and advantages. I agree with you regarding cost, but now the cost which was there 20 years back has come down. The implants which are now, we are using the same implants for open and for arthroscopy. It's only about training, and all this equipment is one-time investment. So cost, I think in today's era will definitely not carry much, because only equipment cost you are talking about, not implant cost.
Thank you, sir. Thank you, Naveen. Thank you very much.
हाँ भेजिए भेजिए
After a wonderful instability session, now let's move to cup session. In this session, we have all stalwarts. I hope we'll learn plenty of new things. To begin with, our first speaker is our own Dr. Vikas Kapoor. He will talk on decision making in rotator cuff tear.
নিয়েছে দেখো ওইটা করো আরজিবি করো মানে এসডিএমআই দিচ্ছি এসডিএমআই দিচ্ছি দাও এসডিএমআই করছি করো এসডিএমআই করে দিচ্ছি কোনটা নিয়েছে দাঁড়াও এসডিএমআইটা দিই শুরু করুন স্যার
Can we just start? Thank you. So today we talk about decision making in rotator cuff tears, and basically what I find, I would be limiting myself to the rotator cable, or the footprint tear and between supraspinatus and the infraspinatus. So the decisions to be taken is to primarily, what I understand with this topic is whether to conserve or to repair. If conserve, why, how, and for how long, and if operate, then why, when, and how. So the large traumatic, degenerative, painful tear with torn degenerative biceps, as we can see here, is basically what I did was a double row rotator cuff repair with biceps tendon resection, biceps tenotomy. So this is what was there, as you can see the MRI, and with these large massive cuff tears where degenerative tendon is there and you have no way to retrieve it. Most of the times it is torn, almost torn. It works very well, and definitely if the patient is on older side, you go ahead and do a biceps tenotomy and do a double row cuff repair. Another one with large traumatic degenerative rotator cuff tear with intact degenerative biceps, double row rotator cuff repair plus biceps tenodesis. Now here, most of the times in rotator cuff tear, I am a fan of metallic anchors, which is vis-a-vis bankards, where I would probably be doing non-metallic anchors. And the primary reason is, as you can see, it is easier for me to see post-op in the X-rays, and it has absolutely similar kind of follow-up results with non-metallic anchors. The second one obviously is a swivel lock for doing the second row. Moderate size rotator cuff repair, pasta lesions, etc. needs just one anchor and can be done with a single row rotator cuff repair. The outcomes of single row versus double row arthroscopic repairs have proven, and this is a standard thing, that you have to have a carefully selected patient where you choose to do a single row cuff repair or a double row cuff repair. But actually it is better to start an earlier rehab in large massive cuff tears. It is better to go ahead, and it gives you a more sense of safety to do a double row cuff repair rather than the single one, and that's what my practice is. But as in this case, which you see here, it is a friend of mine with a very small cuff, reasonably small cuff tear, which was very painful, which I chose, of course, to go ahead and do a double row cuff repair in order to give him a faster, quicker mobilization and get back to movement and feel safe in my mind. So I tend to veer towards a double row cuff repair rather than a single row cuff repair. That's only reserved for most of the cases like pasta lesion, etc. Another slide recently done where you have a cuff which is fairly large, and in this particular case you would see that although this tear is large, it is starting right next to the biceps tendon. Why I am taking this biceps tendon as a landmark all the time? Because a lot of studies where we take decisions regarding the natural progression of the tears and what we need to do with these tears is based on their location from where the tear is starting. So any tear which is starting very close to the biceps tendon has a different progression rate when you compare to the tears which are starting away from the biceps tendon. And that itself takes you to a path where you tend to conserve tears or to operate the tears. Now this is a large tear, a fairly large tear, where you go ahead and kind of, I did a standard double row cuff repair. It was a double anchor, double row cuff repair, and of course a biceps tenodesis. And it takes about an hour's time, does a fairly good job, and all are arthroscopic. Of course, that issue has been addressed in the previous discussion just now. So between the traumatic versus degenerative rotator cuff tears, it is recommended to perform an early repair for acute traumatic rotator cuff tears, particularly in the young individuals, in order to optimize the tissue quality and also the healing environment, as well as to preserve the tear retraction and fatty degeneration. The timing for optimal cuff repair is 3 weeks to 4 months, and it depends on when you get the patient. So traumatic versus degenerative cuff repairs, you need to see the patient's age, tear size, tendon retraction, muscle degeneration, overall healing capacity in order to take a decision of when, how, and how much to do. Tear location, this paper by Kim et al. Is very important. This is an ultrasound measurement. If you have 13 to 15 millimeter posterior to biceps tendon, the healing rates are better. The chances of the tear retraction is less. The closer the tear starts to the biceps tendon, the healing rates and the degeneration rates are much, much higher, which has been shown by this junctional area and this diagram of rotator crescent. And it is important that the tear which is starting from the middle of the rotator crescent is much more stable tear and can be treated with conservative management vis-a-vis a tear which is starting very close to the biceps tendon and actually has a far more chance of retraction and fatty degeneration. As you can see, when the supraspinatus fatty degeneration happens, if the tear is closer to the biceps tendon, so the closer to the biceps tendon the tear is starting, the chances of this degenerating and being more painful is much higher than, and it is just opposite in case of infraspinatus component of the tear. So the tear characteristics and the muscle retraction are important things. Patient with cuff tears close to their anterior margin of supraspinatus should be told that they possess a higher risk for tendon retraction, muscle atrophy, and should be the primary candidates for surgery. The other papers which have shown tear kinetics and glenohumeral kinetics and tear size equations. So if the tear is larger, 12 to 15 millimeter retraction, critical area of the tear, all these things are shown by Keener et al. To have important bearing on decision making of when and how to operate. Full thickness tears, our chances are much higher that they will enlarge and progress compared to the partial thickness tears. Physical therapy is effective in 75% patients up to 2 years. The most important thing is that the patient counseling and the patient should also understand, and they should be veering towards the conservative therapy. Now the patients who are averse to surgery are better conserved, and sometimes they actually end up giving you better results because of the tenacity for doing the rehab. So the important clinical variables and radiological variables are age, chronicity of tear, activity expectations, genetic predisposition, hand predominance, smoking, medical comorbidities, and social factors, etc. Now smoking is a very important factor regarding the healing. Chronicity of the tear tells us about the fatty degenerations, and the age is what we need to understand how early and how quick to repair. Now these are important variables which we need to hallmark and landmark so that we take our decisions on when, how, and how much to repair. 3 more slides, Chairman sir. So group 1 is early operative repair. When to do? Rotator cuff tear due to distinct acute event plus imaging evidence, not suggestive of muscle atrophy. Acute subscap tear or more chronic subscap tear with biceps instability. Small, medium, full thickness rotator cuff tear less than 60 years age with minimal retraction. All should be early operative repair. Trial of conservative treatment can be given in painful partial thickness tears, potentially repairable, non-acute full thickness tear. Reliable results are given in short term with some signs of chronicity. Surgery can be considered if conservative treatment fails. Maximize conservative treatment. This is the third group. Successful tendon healing is unlikely. Make your decision carefully. Age, after 70 years or 65 years, already shoulder degeneration is there. You might end up doing a joint surgery. Retracted tears of any size with advanced muscle degeneration, there's no point repairing. And tears with fixed proximal humeral migration where you need to go for an RCR, a reverse shoulder arthroplasty, and therefore you end up doing a wrong surgery if you do a cuff repair. Thank you very much.
Any question?
Yeah, sir, in the first group, which you mentioned that less than 60 years with a very small tear, you would like to operate. So I just in Indian scenario, we are very commonly observe middle-aged patients, 45 age group, which come with a small pasta type of lesions. In this age group, if you decide to conserve, patients don't want operation. Most of the patients do want a conservative treatment. So what is your cutoff that if you started a conservative management, when you will definitely switch over to surgical management?
See, there are two things. The tear is small is what you are seeing. The pain is what patient is experiencing. So if the patient is coming to you and repeatedly talking about pain, there will come a point when they will agree to the surgery, because the small tear is just an adjunct. You can't really, if it is a full thickness tear which is painful and has reasonably good range of motion, a patient should be counseled to get it operated. And if they are not wanting surgery, then you don't have a choice. Then it is a discussion between a surgeon who wants to operate and a patient who doesn't want surgery. Then you tell them about conservative treatment and its limitation and let them go through the rehab.
Why do you prefer metal ankle? Why do you prefer metal anchor steel now? Is there any particular reason?
For rotator cuff, I said I prefer metal anchors. I get to see my post-operative locations, and I am very happy. Till the time I am not getting an MRI done or ultrasound done, most of the cases, I do understand that my metal anchors give me a good location, and it is a very, very purely personal experience and choice. It has nothing to do with literature or somebody else's experiences. For Bankarts, yes, for intra-articular surgery, I have shifted to non-metallic anchors. But with last 17 years of rotator cuff surgery, I think my metal anchors have stood the test of time. And they do give me a very good locational sort of imaging post-operative in a very cheap way.
Thank you, sir.
Thank you, sir.
Yeah. Next is subscribe tier decision making and technique. Dr. Pratap Kumar, sir.
Good morning. I have been relocated. Okay. Greetings from Sasi. Greetings from Cochin. Okay. What I'm going to do is next 8 minutes I'm going to talk about subscapularis. Decision making. So before that, you need to understand what is subscapularis and what is its role in shoulder. Okay, why the debate? Subscap is not just a tendon. It is, if you look at the rotator cuff, that is the group of muscle. It's not for elevation or forward flexion or abduction or rotation. It's the group of muscle which decide on the biomechanics of your shoulder. That is the one which is going to keep your center of rotation of your head of humerus constant in relation with the center of rotation of the glenoid. That, if you ask me, probably that is the only job which is supposed to be the only job which the rotator cuff has to do, because that is the one where if you pick up 100 kilo, 10 kilo in internal external rotation or abduction, the center of rotation, that relation should be the same. Otherwise, you can get point contact, you can get a point loading, and end up with the rotator cuff arthropathy, which you can get later. Okay, so that is the picture. I'm not going to the details. That is the relation between the center of rotation, and that is the joint reaction force. Okay, which is in equilibrium. So if you lose one of those tendon, like the anterior tendon, then you will lose the equilibrium between the subscap and the anterior cuff and the posterior cuff. When you talk about anterior cuff and posterior cuff, that is the one which you need to keep in mind. Anterior cuff is your subscapularis, long head of biceps, and the leading edge of supraspinatus. That is a functional unit of anterior cuff, and the rest of the supraspinatus, infraspinatus, and teres minor is your posterior cuff. So you got anterior cuff and posterior cuff, and that is the principle behind the tendon transfer and all these things. Now, subscapularis, if you look at it, is nearly 50% of your rotator cuff strength. That is the anterior cuff, I will say, and that is probably the only dynamic stabilizer of your anterior dynamic stabilizer. Now, why these are untreated? These, if you look at traditionally, these are untreated injuries. It for various reasons, okay. But if an untreated subscapularis tear, it can lead on to failed cuff repair. If you repair the supraspinatus, as I said, as a supraspinatus is a part of your anterior cuff, especially the leading edge. So if you got the anterior a cable lost on the supraspinatus, and if you don't repair the subscap, it's going to put more pressure on the supraspinatus. So that can lead on to patient dissatisfaction. You can get an isolated cuff tear, or you can get a along with the supraspinatus tear or a massive cuff tear. Recently had done a study with 24 patients, isolated subscapularis tears, which happens in the younger population, below 50 population, and that can be quite disabling. And we did a rotator cuff, we got an arthroscopic repair for all of them, and with the excellent result. That's going to be published. Now, why this subscap is underdiagnosed? That's because of a multiple reason. You got a multiple clinical test for subscapularis, because none is perfect. So, if you look at the old test of the lift-off test, you cannot these patients will have pain, and lift-off test, you cannot have an internal rotation which is going to be more painful, and that is a pain inhibition. So I don't do that for subscap. I do a belly press test, and the sensitivity and specificity for these tests are very low. Now, this is what I was talking about, the anterior cuff and posterior cuff, and the clinical diagnosis. We need a history, recurrent instability after 40 years, and previous open surgery. The alarm bell should ring. So there can be some telltale stories in MRI scan. You can get subluxation of your long head of biceps, and you can still see some tears. But the important thing is that you can pick it up on the arthroscopy. That is probably the most definite one. Arthroscopic assessment, probably that's the most important one. I'm not going into the details of the classification. You all know that. I do on B chair position, and if you look at that, that is my subscap. I am going to show that subscapularis tendon. Okay, so that is You can see that is the tear. That's the tear. Just looking and defining the footprint of the subscapularis. I'll go to the next one. Okay. Now this is a metal anchor I am using. I don't have the nowadays I use the biodegradable anchors. And one good thing is that you can come anteriorly. It's not like your angle has to be correct and the critical angle, nothing. You are coming anteriorly, directly anteriorly. So you got a good leverage of doing that. The chances of error is very less here. Okay, and you can see that, yeah, that is deployed. Now, you can use your own choice of how to take the bite. Okay, you can either take a direct biting technique, or most often I use a bird beak. And sometimes I use this one as well. Okay, you can take a bite and take it out. Okay, this is a bit more longer one. I will edit in between. I'll go ahead in between. See, this is a typical degenerated cuff. You can see that I am cleaning that, and you will be able to see that in a minute. Okay, that's my shaver coming, soft tissue shaver, to define the okay, now you can see that the subscap is torn there. See, initially we couldn't see anything. Now we can see that the subscap is clearly torn. Okay, my probe is coming. Okay, that's my probe. You can see the footprint is well prepared there. Oh, sorry. Should be somewhere there. Now you can see that from the lateral portal, I'm putting my soft tissue grabber and seeing the mobility of my rotating cuff, my subscapularis tendon. Now that is a biodegradable anchor. I am using a peak anchor. This time I am using a bird beak, a straight bird beak, and just taking a bite from that. To repair the subscapularis is easier than you think. It's only the mindset. Okay. What I am doing is from the lateral portal I am pulling on with the soft tissue grabber, I am pulling on the tendon, and then I can easily penetrate the tendon. I'm just finishing. That's my knot pusher coming in. Okay. You can see that my knot pusher coming, and I am going to probe that in a minute. My probe is C. That's a well fixed one. That's a single anchor. Single double loaded anchor. So neglected subscapularis can lead on to anterior instability and the long head of biceps subluxation and the pain from the long head of biceps. And more importantly, it can put more stress on the supraspinatus tendon on the leading edge. So subscapularis where we stand now is diagnosed mainly arthroscopically, 100% diagnosed arthroscopically, and we need to probe the tendon, and if you internally rotate it, you can get a good vision of that. And nowadays we've got a low threshold for fixation. Thank you very much, and I, with the permission of the chair, I am inviting you for the Shoulder Elbow Society annual meeting in Kumaragam, Kerala, 28th, 29th, 30th of this year, and we have a nice workshop from the Leicester proximal humerus fracture course, and this is I will urge you to come with your family. It's a post Diwali weekend, so you can have an extended Diwali, and that is probably the best present you can give for your family. Come, everyone come to the Kumaragam, and you've got a lush green, watery. It's in the middle of backwaters. You will enjoy it. Thank you very much.
Sir, question. There are people who do double row repair for subscap also.
Okay. I mentioned about a previous study, the isolated subscapularis tear. And out of the, in those, we had athletes there and sports people with adventurous sports, okay, mountain climbers and the adventurous photographers, wildlife photographers. They need to keep their camera in this position, and their camera probably 10 kilograms, okay. For 5 minutes, 10 minutes, they have to keep it there. And those are the difficult times. They cannot keep it like that. And those cases, I have used a double row repair. Okay, not that everything I am going to do a single row repair.
Is there any biomechanical difference between single and double row?
Well, what happened is those things, because of the physical need, I didn't take a chance. That's the honest. It's an anecdotal one. It's not a, yeah.
Sir, I could not see the biceps tendon. Did you do a tenodesis of the biceps tendon?
No, you don't have to. If it's a biceps tendon is perfect, don't have to do anything with the biceps. There are two groups, traumatic one and the degenerative. The degenerative one is the one we are worried about biceps and it's associated with the biceps pathology as well. Yeah. Otherwise, it's only subluxation.
Yes,
And
some people like to do biceps tenotomy in the first go because it increases the visualization.
That's what I was telling. It's the mindset. Okay, once you start doing it, it's easy. It's there. It's probably more easier than your supraspinatus. And the isolated subscapularis is a difficult ball game altogether because you will be coming through the two anterior portals. Okay, one below the long head biceps, one above the bicep, because we don't want to jeopardize your supraspinatus. But if it's a part of a massive cuff tear, it's there. Everywhere. The door is open. Okay, you can come from the anterior side, you can come from the lateral side.
Sir,
yeah.
As you mentioned, most of them you showed intra-articular approaches. Will you go any extra-articular to actually repair if it is too retracted? And that's one. And 70-degree scope, sir. Do you use it in your practice?
No, because I didn't have the 70-degree scope, access to 70-degree scope initially. So I am trained for that 30-degree, my 30-degree scope. I don't use any because that's probably I didn't have any access to the 70-degree scope. If you look at the literature, 70-degree scope, and now I don't feel the need for a 70-degree scope. And if you give a 70-degree scope, I don't know what to do with that in this situation because I am used to that.
Laura Lafosse, he uses this extra-articular approach, and people ask him, are you using a 70-degree? Well, I never heard of it.
Okay, thank you, sir.
Thank you, sir.
Thank you very much.
Next is rotator cuff tear, single versus double row. Dr. Chatterjee, sir.
Problem. These people have again problem of mindset, as Dr. Pratap has said. This is not a debate. There is not versus this versus that. This is not a single versus double row repair, but it is a talk on double row repair where I would rather ask people to introspect on the double row. Because now, as we say, that if you don't do a letter J, you almost look down upon, like an outcast. If you don't do a double row, you are looked down upon. So I call this a introspection or a fact check on double row suture methods. Not all that looks white is white. There is more to it. We know that rotator cuff tear is common. There are multiple repair techniques: single row, double row, footprint, transosseous equivalent, suture breeze, bagara bagara. This is the editorial commentary in the Arthroscopy Journal 2019. They said rotator cuff tear remains an imperfect treatment for rotator cuff repair remains an imperfect treatment for rotator cuff tear, with re-tears remaining a common issue, especially with large tears. Hence, a great deal of research went into the repair technique. But the repair technique was mostly focused on different types of fixations, and the number of anchors on that. And especially this was focused on whether 2 rows of anchors or 1 row will provide enough fixation strength. And this is Jan Lowe and Burkhardt in 2003 who first started with this double row thing, and they described a double row technique for cuff repair that re-establishes the normal cuff footprint and increases the contact area for healing, which may potentially improve the clinical results, they said. But we have questions. What is a double row? And is a stronger repair better? What is the healing of cuff in that? How do we know? What is the clinical outcome? Is it better? What about the failures after repair? And of course the cost. As the Americans say, where is the money, honey? First, the different types of double row. This independent double row, as you can see on your left, then this linked double row. But what we basically mean is this transosseous equivalent or the suture bridge double row. That is what we are taking into consideration. Burkhardt has defined that quite well. James Lubovich, in this again 2000, in his arthroscopy journal editorial, he said long time ago that stronger may not be better. There is an increasing recognition that holding the rotator cuff footprint over a bigger area by double row seems to lead to musculotendinous junction failure in cuff repairs. And actually, this Cho has done a good job on these post-repair tears, failures, and he found there are 2 types of failures he described. One is Cho type 1, where the failure is at the repair site, original tear site, and the Cho type 2, where the failure is much more medial to the medial row of the near the musculotendinous junction. And he found that following double row, almost 60% are type 2, and we all know what that means, this musculotendinous junction repair. Then healing. What is a complete healing? What is incomplete? Lack of maturity is seen in MRIs, if there is a persistent gap, whether that is incomplete, whether if there is a poor thickness on the repair tendon, is that incomplete, and how do you assess that? Because in ultrasound, it takes up to 4 to 5 months to actually see any repaired tissue. And if there is, for example, a 20 or 30% healing, like a pasta, at 12 months, is that a healing or a failure? So these are again complicating the outcome, as we say. Of course, the cost factor. The cost of a rotator cuff repair in American literature, that ranges from around 7,000 to 12,000 for a double row. And this have calculated that to obtain cost neutrality, a double row repair should be causing less or fewer revisions for every 17 primary repair in a small tear or every 4 primary repairs in a large tear. So that is again an almost impossible target they have assessed cost-wise. And then clinical outcome. Is there really any difference? That different, this is an meta-analysis of these these repairs done by Ming Chen in 2013. They said the double row repair provides significantly higher rate of intact tendon healing, no doubt about it. However, this benefit did not translate into clinically confirmed functional improvement. Thus, they concluded that double row technique should be used only in carefully selected studies. Same stuff in 2014, another meta-analysis done by Mascarenhas, they said that double row repairs in higher rates of study, structural healing, but the effect of tissue compression and clinical outcome deficit after these has to be delineated before going into that. And this is a third one which say that did not show much difference in the clinical outcomes between the two, which we already knew. However, the medial cuff failure was observed only in suture bridge or the double row group. and one must consider the risk of medial cuff failure and incomplete healing of the repaired cuff before choosing one method above the another. And now coming to the big man, Stephen Burkhardt, in 2019, he said in his level 5 evidence published in Arthroscopy, biomechanical data has convincingly demonstrated that double row repairs are stronger and more durable. Nobody argues that. And the trends in available clinical data continue to suggest that double row optimizes the likelihood, beautiful play of words, optimizes the likelihood of tendon to bone healing. And arguments pertaining to equivalency of single and double row persist because there is not much, regrettably, he said this regrettable, not much pulling of data derived from dissimilar surgical techniques. So gentlemen, after all these long words, what are you, my practice, I say, I will propose this. For small tears, a single row is efficient and inexpensive and has got a high healing rate and good clinical outcome. For large mobile tear, a double row is better because it may provide increased healing row. But for a retracted massive tear, which is not uncommon in our practice, there the tendon can barely be reduced with difficulty. A single row repair is the best, as the study by Yakamado has suggested that it is as good as anything else. And tension-free suture line should take precedence over coverage of the footprint. And the disease, as the diseased curve deteriorates, not only does the muscle retract and stiffens, but also the tendon contracts. And the treating surgeon should be comfortable with severe repair techniques because the technique applied should be based on the tear pattern and tissue quality. And one take-home thought process by again Chalmers in 1919. Does a medial repair as single row, double row? At this point, I believe the single row, triple loaded repair has advantages over double row because does not cut off circulation, does not overtension, avoids repair failure at musculotendinous junction, and quicker to perform, and the cost is less. That is the editorial commentary in the Arthroscopy in 2019. Thank you.
Any questions?
No questions, sir. It's so elaborate and precise that nobody is asking any question.
Thank you, sir.
Next online. Next is irreparable curve, how to deal. Dr. Amaravati, online. Yes, sir.
Yeah, good afternoon, sir.
We know that the type 3 and type 4 are not that great tear to go ahead and repair, but is there a possibility that we can do something different when we end up having these kind of situations? Is also another thought process that we should know of. There is a cuff retraction that comes into play when the cuff is not repairable. Pape has given a nice classification saying that type 1, type 2 and type 3 stages are there when the cuff retracts. It is when type 3 is there that it becomes a boiling point for the surgeon to bring the cuff and put it back onto the GT or put it back closer to the articular surface, or he cannot put it back at all. So these are the lines that he will be thinking of when he is trying to manage these kind of cuff tears. Also, Elman and Gopsman's classified that what a tooth thickness tear looks like and what you should be really expecting when you put your scope inside the shoulder. If you see this picture that I put it on the screen for you, when I see a cuff tear like this, it's better that is we are wanting to lose, but nevertheless when you slowly start releasing the cuff and trying to find out that the biceps is intact, There may be a scenario wherein you can salvage this kind of cuff without doing much. But what if you can't do much and try to give a function to the patient? We need to think of alternative options, which would be in this line that we think of, whether the shoulder is functional or non-functional. If you call it as a non-functional shoulder, the options are basically tendon transfers along with the reverse shoulder. But if you think it is a functional shoulder where the cuff is still not repairable, we can think of doing a partial cuff repair, tissue patches, balloon, SCR and bicep tenotomy. Over the past years, if you look into the literature of irreparable cuff tear or a massive cuff tear, and the tendon transfers, the amount of study and the literature that is available for you to look is more in favor of balloons, because it's a very quick procedure and the patient can get back to function early. Compared to that, if you have to service the tendon transfer, the literature available on that is less, but it needs a lot of expertise and hands-on experience to go ahead and do that, because it is challenging for us to bring back the function by doing a muscle transfer rather than putting a balloon inside the shoulder to recover the function. So to briefly put how the hand can go for a dysfunction, the factors that are generally considered when the cuff is irreparable is whether it is a painful shoulder or a painless shoulder. If it is a painful shoulder, it falls in group 1, and generally would like to put it as a functional shoulder. If it is group 2, wherein there is an isolated loss of a forward elevation of the shoulder, we would like to call it as a pseudo-paralytic shoulder. And if in addition there is an isolated loss of active external rotation, we would like to call it as ILR, and that is group 3. When there is both horizontal and vertical loss of motion, we would like to call it as group 4 and we call it as failure. So these are the 4 groups that we need to keep in mind when we are trying to restore muscle balance in the shoulder. So to understand that, a vertical plane imbalance can be an isolated loss of forward elevation. An isolated loss of external rotation in this fashion could be a horizontal plane defect. If it is both horizontal and vertical, it is called as clear, where there is combined loss of elevation and rotation. What do you think we should be doing for such a lady who has got a massive irreparable cuff tear, but if her function is like this, and is the shoulder being less arthritic? Do we go ahead and do some kind of treatable procedure or some kind of an intervention? I am sure most of the August gathering that are gathered there in the city of joy would just say that yes, I will do a skillful neglect in this patient because she will do very well because she never complains of pain and her function is great. Some situations are there when we can, science does not give entire answers for your problem that we see on your imaging. What if the pain is there? Either it can be because of the pain generator that we all know that is given in our books. It can be either because of the torn biceps, it is a pain generator, or it can be because of hourglass contracture of the biceps. As Pascal Bellon and Gilles Walsh has particularly told us that just doing a bicep tenotomy in these cases will give great relief to the patients and they can have a great function. Also, if you have read the paper by Humeral, greater tuberosity tuberoplasty can also give great relief for these kind of patients to improve their function. What if there is a vertical imbalance of the shoulder as there it is in this case, but she has got a decent amount of external rotation that is there, and there is no active elevation, but a decent amount of external rotation, the tendon transfer that you need to keep in mind is LD. Why I say LD is that latissimus dorsi transfer can be done very well in patients who have got supra and infraspinatus there, but they should have a good subscapularis to augment the repair that you are doing. And if you can see in this picture, the cuff, the supra and the infra are not that great, but nevertheless the subscapula is great in function, and if you choose such a kind of patient for your tendon transfer, then this will be your result, a good elevation and good abduction and external rotation that we can see. Also, if you have read what is the type of LD transfer that we need to do, should we do a transosseous tunnel placement, or we need to do an anterior placement just at the insertion of the supraspinatus or at the insertion of the infraspinatus. We have clearly told in a study along with my boss Jean Canning that if you place your 10 LD onto the infraspinatus attachment, you will get a great forward elevation and external rotation. Also, if age is a criteria, in which age group the tendon transfers will work better, whether less than 55 or around 55 or more than 75. In both age groups, we can see that the tendon transfer works. But if there is some useful function that we can give to patients who are more than 75, LD should be the choice of transfer. Nevertheless, the new kit that is there in the market and everybody is running after it is called as a lower trapezius transfer, popularized by Basham Son. You can see that it can be done in patients who have got supraspinatus and infraspinatus irreparable tear, and the atrophy of the muscle is just grade 2 infiltration. And in all these cases, the subscapulary should be good without any glenoid or arthritis. However, the clinical signs of drop arm sign and arm blower sign should be there in this patient with no pseudo paralysis. Why choose a lower trapezius transfer? Because this is in line with the function of the vector that is there. It is in line with the function of the same vector as the infraspinatus, and especially if the external rotation in abduction is more limited, it is better to do a lower trapezius transfer than the latissimus dorsi transfer, because that is where the more power is needed for you to do abduction and external rotation, and LT transfer is a better choice. You can also do where the horizontal plane muscle imbalance is there, procedure called as episcopy, which is popularized or modified episcopy popularized by Posterior and all. You can combine it various procedures to restore the horizontal muscle imbalance, and that is called as the episcopy procedure, wherein we take the muscle around the humerus and pitch it with the attachment of the pectoral. When there is both horizontal and vertical muscle imbalance, imagine if we try to do only a reverse shoulder arthroplasty, which is the go-to procedure for most surgeons now, because they feel that we can restore the elevation of the patient, and that is a function that everybody would want with pain. But imagine if you do a tendon transfer, if you do a reverse total shoulder arthroplasty without the patient having an external rotation, it will be a very useless procedure, because the patient will not be able to reach to her mouth, not be able to comb, dress up, and all these limitations she will have in spite of the wonderful procedure of the reverse total shoulder arthroplasty. So in that scenario, when there is vertical as well as horizontal muscle imbalance, kindly combine a reverse with a tendon transfer, either a episcopy procedure or a latissimus tendon transfer, so that you can restore the rotations of the patient very well. So in summary, if I had to say, in an irreparable massive cup tear, if I see a functionally balanced shoulder and if the biceps is still present, I would be very happy and keen to preserve it as long as possible and try to repair the cup back, which is probably called as the BioSCR. Or if the biceps is very bad and it's causing pain, I would like to resect it and give some pain relief for the patient. However, if the hand is non-functional and if there is a vertical muscle imbalance, I'd like to do a latissimus dorsi transfer. If not, we would like to go ahead and do a reverse shoulder arthroplasty. The shoulder is arthritic. In case where it is only the horizontal muscle imbalance, episcopy procedure is a good option as described by Posterior in his published literature. And if there is both horizontal and vertical muscle imbalance, we would like to do a reverse total shoulder arthroplasty or a latissimus dorsi transfer along with an episcope, so that we can gain function. And if it is arthritic, we would like to do a reverse with an episcopic procedure. That is how the brief of this irreparable massive cup tear talk will go. Thank you for the opportunity given, and I am open for discussion now. Thank you so much.
Thank you, sir. Any questions from the audience?
For latissimus dorsi transfer, do you do open procedure or arthroscopic procedure?
Great question. begin with, me and my boss, we used to do open procedures, and over a period of time, we graduated from like mini open to open cuff repair. We graduated to doing arthroscopic procedure of lattice muscular transfer. Nevertheless, it is important not how we do exposure of the lattice muscular tendon transfer. It is important where we put the tendon and clinically identify what is the functional limitation of the patient. It is always important that we put this tendon at the level of the infra spinatus to gain maximum advantage of what we want. Suppose you want only forward elevation, you put it at the supraspinatus. You want forward elevation and external rotation, you put it at the attachment of the infra spinatus so that both functions can be restored.
Well, Dr. Amravati, this is Dr. Debashish Chatterjee.
Good morning, sir.
Good morning. Good morning. Good afternoon. My question is, when you are doing a latissimus dorsi transfer, what is the expectation of your patient before the operation, and what is the satisfaction after it? What is the level of satisfaction?
Great, sir. If you have seen the clinical image that we have put, and if you have gone through our paper that we have published, the satisfaction of the patient, both whether they are less than 55 or more than 75, is equally good. And only thing is, we have to sit the patient down and talk to them, because there needs a lot of talking to the patient, and we are trying to train a tendon to do a function which is not
their expectation. What is their expectation before surgery?
The expectation before surgery is to get back to doing the activities of normal living. For example, if you saw that lady wherein somebody has gone ahead and done straight away a reverse broken shoulder, her basic expectation was to reach to her mouth, give you a good handshake, and able to comb. If she is able to do those basic limitation of activities by the tendon transfer that you are giving, she will be definitely satisfied with what you are dishing out to her. But if there is a case that you don't identify those muscle imbalances that she has, which is quite easy on clinical examination, then we will found wanting in what we have to give to our patients.
Okay.
Okay, thank you, sir. There is no more question. Thank you for your wonderful lecture.
Thanks from Kolkata.
Thank you, Devashish. Thank you, Rajiv, and thank you so much. Thank you so much for having me. God bless you.
Next is graph jacket SCR or just biceps, Dr. Ayappan.
To you all. Thanks again to Team Calcutta and Rajiv sir and all the entire team. I'll be speaking on the SCR, superior capsular reconstruction. So thanking our teachers who have taught us to how to do surgery. And before we start off with the SCR, there is some consideration we should have in an irreparable tear. So question is, what is an irreparable tear? Is one by which or in which by regular surgical techniques of mobilization we are not able to bring the cuff back to its footprint and attach it tensionless. So now in irreparable tears, the cuff has certain attributes. There will be significant tendon retraction. In elasticity, the muscle atrophy would be significant, and fatty infiltration also will be quite significant. So if you look at the grades, or how do we quantify each, and how do we know that this particular patient will get an irreparable tear or not? So one is, as Rajkumar sir had discussed, modified Patter's classification. Higher Patter grade would suggest that this is an irreparable tear. Again, a higher fatty infiltration grade shows that it is irreparable. Then a higher Hamada grade would show that there is a significant irreparability. So now we have an irreparable tear. Now question is, what are the options in front of us? So options where, sometime back also we have options where graft jacket or a patch, that is a patch, we patch the deficient cuff. We can do a partial repair and reverse shoulder arthroplasty and muscle transfers. So now, but still it had its own sets of problems and problem in the expectations. So with all this in mind, we started the research more in anatomy. So anatomical research showed that the capsule is a very important structure in the shoulder. The capsule is quite thick, so the measurement would be like 5 millimeter, 10 millimeter is the thickness of the capsule, and it's a very significant contributor to stability of the joint. So Mihata used these principles in the superior capsular reconstruction. So he took a facial lata patch, doubled it. On one side, it fixed it to the glenoid with a single row. On the GT side, fixed it with a double row. So how does this work? So before I go on, okay, there is here also very important thing is not only this fixation of the capsule, but also the fixation of the remnant cuff to this particular capsule or the graft is very important. So this works on the spacer effect. So this is a spacer effect where it's like the balloon what Sir had mentioned. So now this works like a spacer because it actually depresses the head and gets us the correct function. Next, a trampoline effect. It prevents a superior migration. And third, it works by a force coupling effect. So the remnant cuff which is attached to this capsule or the facial lata helps in mobility, helps in the biomechanics of the lift. So now, so Mihata publishes a biomechanical study in 2012, showed excellent results and a great outcome biomechanically. So then the SCR started becoming more and more widespread. People started using in the West, and they started exploring different graft options like a dermal allograft. Then in Korean studies, they came up with biceps SCR, and now we have more and more biomechanical studies financing the SCR. And now we also have short-term and mid-term clinical outcome studies which shows the results of the SCR. So coming to my technique, so I have modified my techniques from what I've learned from Dr. Mihata. So this is one case scenario, it's an irreparable tear. The patient had full range, but definitely pain and weakness. The MR showed a significant irreparability, and this is his full range before surgery, and this is what we did. So here what I've done was, okay, so I've cut the biceps, shifted it anteriorly because the defect was a quite huge defect. So I was not able to bring it, so I've decided to cut the biceps, use that also as an SCR, so that I decreased my requirement for the graft. So I took a graft and the muscle. So this is a quick video on the graft preparation. The patient is always in lateral position. Midline incision is put on the trochanteric area. So and we expose, this is how we expose it, and then it is basically the measurement. Normally I double the graft, so because I need a particular 8 mm thickness, so we have to double it or triple it. So and so the measurement being taken and the preparation. Yeah. So I'll just go on, and this is the final results at 6 months. The patient had excellent results, no pain, full power. So another case scenario which we normally face, a patient comes with a re-tear. So this is a patient who came with a re-tear. At 6 weeks he had a fall, and you can see the anchor has been pulled out. So intraoperative picture showed that there is a significant anchor pulled out. You can see all the anchors, it was a complete mess, and a lot of debridement was done. And again, we did a facial lata, and SCR was done. The patient went on to have good results. It is interesting to note that the recovery is quite delayed. We can see that this is 16 weeks. Please note, carefully note how the patient is moving at 16 weeks. We'll have a little difficulty there. Now we can see his abduction. See, that is the abduction at 16 weeks. But now another 2 weeks later, because the rehab has to be very, very meticulous, and the rehab should be a deltoid based rehab. This is at 18 weeks. So again, great results. So now, as the topic also mentioned, the biceps SCR. So biceps can be used as instead of the facial lata. Especially, I would use it in smaller, tears, retracted but smaller tears. So, and I shift the biceps to wherever I find the deficiencies. Could be anterior, middle, or even the posterior. So this is an excellent graft, quite thick, and an excellent depressor. And the quality of tissue is pretty good. So this is a biceps SCR, or we can also call it reverse bicep stenosis. Gives an excellent coverage and excellent results. The biceps can also be doubled, tripled if you have bigger defects.
Coming to just a few slides on the outcomes. So when we look at the outcome studies with facial lata, excellent outcomes. So lesser retear rates, the function is better, the range is also very good. So when we come to dermal allografts, which were not available in India, so again they show good results, 70% good results with the Arthoflex patches and all that. So again, Burkhardt's 2-year study showed that results are maintained, excellent results. And 1-year study is showing excellent results. So the overall results are good, but certain things to be keep in mind. So whenever using a dermal allograft, we find the thickness is very less. So the minimum requirement is, if you are using it in the dermal allografts, it is recommended more than 3 millimeters. But facial lata, the Mihata study showed that minimum 8 millimeter of graft is required. Thicker the graft, it is better. And there are higher retear rates with the dermal allograft. Coming to biomechanical outcome studies. So biomechanically, now we know we have more information how the SCR works, and it is recommended that whenever we have to do, I'll take a few moments more. So whenever we do an SCR, a side-to-side repair is very important. And if you are doing a facial lata SCR, only a posterior side-to-side is required. But at the same time, if we are using a dermal allograft, because it stretches out more, and anterior as well as posterior side-to-side repair is very important. So graft thickness, this Mihata study showed that 8 millimeter graft is excellent. So we have to double it or triple it to get the adequate thickness. Then shoulder positioning, what position of the shoulder should we put the graft and tension it between 15 to 45 degrees with the patient in lateral position. So our question is, we should do an acromioplasty? Yes, it is recommended to do an acromioplasty. Why? Because the unevenness or the rough surface of the sharp acromion should be tapered off. We should have a smooth underlying surface. Too much acromioplasty is not recommended because it increases. So if the acromion becomes thin out, then there is a proximal migration. So minimal acromioplasty is recommended. So there is something called as SCR plus. So where we do an SCR on the glenoid side, but we also put a patch on the undersurface of the acromion. Again, increase the spacer effect. So also a good technique. Then question would be like, or the main question everybody would ask is, does it heal? Yes, definitely. Even the dermal allografts tend to heal. There is only one case report of this explanted graft which shows tendon-like changes. Facial lata also increases, when you look at the Doppler studies, it shows healing. So if minimally invasive graft has better outcomes. So there are some Chinese studies on the augmentation of facial lata also. So overall, to sum it up, I would say that SCR is a great option, provided we have the anterior and the posterior force couples. If the subscap should be intact or should be a repairable subscap and the posterior force couple, then definitely SCR is a good choice. So I would just sum it up, and again inviting all of you to Manipal Shoulder Conference planned on June 5, and we are also doing a superior capsule reconstruction workshop. So thank you again. Thanking the chair again. Thank you so much.
Thank you, Dr. Ayappan, for this excellent talk. Do we have questions? Yes.
Dr. Nair, very nice talk. So I have two questions. One is, what is the graft site? What are the graft site morbidity that you have you have seen till date, and what are the functional improvement that we get with SCR? Do they have a good supraspinatus, intact supraspinatus like function after the SCR?
Yes. So the answer to the first question, like there have been studies on graft site morbidity. So now the trick is, it was noticed that whenever we take a facial lata patch from the thigh, if we close the facial lata under tension, it is noticed that these patients have higher pain, and they don't improve much. They always complain pain for a long period of time. Now the trick is, that is, when you compare that to, you should not close the facial lata. Just do a subcutaneous and a skin closure. That's it. If you don't try to do it, then there's no pain. The patients are quite comfortable, and they can go for most of my patients. They never complained of, especially for only the first few weeks or a month. After that, they're okay. The second question was the function. Yes. So in all our patients, so the rehab is the key. So instead of a regular rehab, we can't do a rotator cuff rehab. So how the rehab is, first 6 weeks we have to immobilize. After 6 weeks, the rehab starts. And the rehab has to be a deltoid based rehab, like how we do in a reverse shoulder. It is completely very different. So, and the expectation when the patient will have a kind of a normal function would be double of a normal. If it's a rotator cuff 3 months, you expect normalcy. This should take like 4.5, 5 months. Then it is noticed that a patient with complete pseudoparalysis, so they go up to 4 plus. And for example, a patient who don't have pseudoparalysis but got adequate power, then they go to full power. This is what, in my experience, what we have noticed in our patients.
Doctor, there is a question here.
Sir.
Regarding this reverse biceps tendinosis that you have said.
Yes, sir.
But there you don't fix it on the glenoid side, it's only fixed on the humeral side.
Yes, sir.
So it is not exactly an SCR that you are talking about.
Sir, if when we look at the capsule is attached on, normally a capsule is attached on both the glenoid as well as on the GT side. So now we already have a ready-made attachment of the biceps, which is normal on the glenoid. So we use that and put it only on the GT side, sir. So it works very well like a capsule. So it is normally, so if we do, when we do for example, in scenarios where the biceps is completely gone, there's no biceps. So earlier when Mihata, what he used to do was, he used to remove the superior labrum completely, and he used to put the fascia lata on top of it. So that means, that is how the capsule is. Now, what he does is, if the biceps is intact, he leaves alone the biceps. So this is what I do is, I incorporate the biceps, because we can avoid the the glenoid anchors, that's all, sir.
Because I have seen young girl redoing a calf repair, filling up the gap using the biceps tendon exactly like that.
Yes, sir.
And he calls it a calf repair. He doesn't say it's an SCR. That's why I was slightly...
It is called biceps. Now we call it as biceps SCR, reverse stenosis, the bio SCR, different names for that.
Have you ever tried the other one?
Sir?
You do you notice one end of it, when you release the biceps, take a longer biceps out of it, redo it, and attach it on top again.
Yes. Sir, there have been
picture there.
Yes, that is only depends upon, it's a bigger defect. So there have been papers which show that we can double it. That means take the double length and attach to the GT side and then bring it back to the glenoid side. There even tripling is there. That we go there, come back again. Yeah, so you use the grab. The only thing is we have to mobilize till here and then take it. That's it. But it is very, if we don't want to take the facial lata.
It works better if the bicep is healthy. So the primary anchor is already there.
Absolutely. Thank you so much.
Thank you, Dr. Nair.
Thank you.
The next talk is by Dr. Himanshu Gupta, GT Avulsion, Decision Making.
Good afternoon, everyone. I am Dr. Himanshu from Ghaziabad, and I'll be presenting my talk on greater tuberosity avulsion fractures, arthroscopic management. So just a little overview. The GT fractures accounts for almost 19% of all proximal humerus fractures, and they are mainly associated with acute dislocations or maybe because of direct trauma on the lateral shoulder. So as we all have been reading various classifications of NEER, AO, trauma and all, these kind of fractures have been beautifully defined in an article in 2014 into 3 categories based on the morphology, into the avulsion fracture, the split fractures and the depressed fractures. The avulsion fractures involves a small fragment of bone and a fracture line is horizontal. The mechanism is probably the same as the rotator cuff TRS, but here the tendon is avulsed with the bony fragment. It is similar to the ACL avulsion kind of a scenario. And this morphological classification is very helpful in deciding the technical aspects of the surgical management in this kind of situation. So our rationale of surgery is to restore the anatomical alignment of the fracture to avoid any impingement and to restore the rotator cuff function. Our decision making is basically dependent on patient specific and fracture specific factors. Coming on to the patient specific factors, the age, the sex, the comorbidities, physical goals and the expected outcomes are the basics. Apart from that, the fracture specific things which leads mainly for the conservative treatment is like the fractures which are minimally displaced or less than 3 millimeters displaced fractures. Surgical aspect is recommended for the fractures which are displacement of more than 3 millimeters in athletes and overhead workers, and with a displacement of more than 5 millimeters in all active patients. Now we have choices of open procedure and arthroscopic procedures. Open procedures are preferred for comminuted, widely displaced fractures, and arthroscopic procedures are reserved for small bony avulsions, multi-fragments with attachment of supraspinatus tendons on that. Now there is a article which supports the fact that any displacement which is more than 5 millimeter puts almost 16 times increase on the abduction force of the deltoid, and if this goes beyond 1 centimeter, it is almost 27%. So this shows the importance that how important it is to restore the normal anatomy in this kind of situation. So coming on to the case scenario, this is a 56-year-old male who has a more than 3 weeks old injury to his left shoulder. He was being treated conservatively by some orthopedic surgeons, but he was having a constant pain with loss of movement. On clinical examination, the movements were definitely painful and there was a rotator cuff weakness. As we can see on the X-ray, we see a avulsion fracture of the tuberosity, which is supported by the MRI and the CT findings. The important thing is that the fragment size which we sized on CT is almost 25 millimeters in front to back direction and almost 15 millimeters from medial to lateral direction. So in this case, I plan to go ahead with a arthroscopic fixation as the fracture was less than, it was just 3 to 4 weeks old, and I think that the fracture was amenable for the arthroscopic reduction. So coming on to the technique. So I started with a glenohumeral arthroscopy, and this is the biggest advantages in this kind of scenario. We can have a look inside the joint to address other pathologies associated with these kind of lesions. As we can see that at this point, we actually have the opportunity to clean the crater of the tuberosity fragment from the glenohumeral side. It is similar to what we do in ACL avulsion fracture. The first step is to clean the crater, remove every kind of fibrosis, every kind of loose bone from that side. And maybe if the capsule at this point is tight, we can have a little release and we can get a good view of the footprint. So once we are done with this procedure, we move ourselves to the subacromial space, and probably this is one of the most I would say the important and the tiring part of the surgery is to remove the bursa and all other tissue from the subacromial side. So we start from medial to lateral side and we'll try to reach up to the footprint of the tear of the avulsed fragment. So at this point, as I said, it's difficult and we need to do this step very meticulously, because once we start putting the sutures and if there is any hindrance, it will be difficult for us to manage. Then we switch to the posterior lateral portal, which is just adjacent to the fracture crater. We still continued our debridement and we mobilized the fragment completely to bring it to the footprint from where it is avulsed. So once this work is done, the fracture is mobilized, the first posterior anchor is placed on the medial side of the fracture fragment. So in this case, I have used an anchor with a fiber tape loaded over it and a normal non-absorbable suture. The first bite that we take is from posterior side, is usually by the help of a bird beak device. It is easier to manipulate and grab the sutures from posterior anchor. So this is a mattress configuration that I have taken, and the bites have started from posterior to anterior direction. As we see that fiber tape here is something which is newer in my hands. I've started using it for like 5-6 months now, but looks like it's going to give you a better compression at the fracture side. The next thing is we use an anti-grade suture passing device, but with the fiber tape anchors, we need to railroad these tapes. We cannot take the bites directly. The second anchor is placed anteriorly in the medial row, and this anchor needs to be placed slightly at the junction of the crater and the normal bone, as the bone is slightly weak on this side. And the same procedure has been repeated for this anchor. The bites have been taken just adjacent to the fracture site to avoid any cut through from the tendon. So the same procedure has been repeated, and we have taken almost 8 bites through the 2 anchors in the mattress fashion. So we go from posterior to anterior, and as I said earlier, and I'm still emphasizing that meticulous bursectomy, removal of the tissue is necessary. Otherwise, with this procedure, you will keep on struggling to locate your sutures, you will keep on struggling to pass your threads through that. So once it is done, the knot tying is started from the anterior to the posterior direction. The sutures have been gently retrieved and parked into the different portal. We plan to do a double row, so we are not cutting any sutures. Here the advantage of tying the knot is that we get a good compression near the fracture site, as if like we are doing in a primary cuff repair. So once the knot is being tied from anterior to posterior direction, we see that the fracture fragment starts seating into the crater. So here we can see that posteriorly it is not coming 100% into the crater, but I think the amount of residual displacement, whatever is visible, is very much acceptable. So now we plan to go laterally, and we have retrieved one suture from all the anchors and moved almost 1.5 centimeter laterally. So we started from posterior to anterior in the medial row, but in the lateral row we will place the first anchor anteriorly. We have cleaned the soft tissue from the lateral side. The lateral anchor is placed and the sutures are pulled to compress the fracture to its footprint. Here I find out that the fiber tapes gives you a little advantage of giving a better compression of the fracture with the fiber tape anchor. So the first anchor is placed anteriorly and we achieve an adequate tension on the fracture side. The same procedure is repeated on the posterior aspect. Here on the posterior aspect, since we have measured the dimension in the CT beforehand and the posterior side looks slightly comminuted, so here we are little apprehensive in giving an over compression just to avoid any kind of comminution on the fracture side. So this pull is slightly gentle. Again, that pre-drilling for the lateral anchor is done and the procedure of giving the compression is done. We see that the slight, I would say, malreduction on the posterior aspect is there, and in the last, when we check, there is a good strength of the rotator cuff. There's 2 more minutes. So just tying this is, once we finish off the repair, it looks pretty stable, slightly malreduced on the posterior aspect, and when we measured, it is around 3 to 4 millimeter of malreduction in the last when we observe that. So this was the post-op. It's gone. Suddenly, another conference. Oh, lucky enough to promote another conference. So I've left with 2 more slides. I think if we can restart it. Just the post-op X-ray and that's a concluding slide. Should I go on that side? Udhar jane? Okay, next Ajay. Should I conclude my talk here or? Go back and forward. So my screen is working fine. It's not there. The screen is here.
তোমার এতে এসছে প্লাজমা এসছে মেনে আসেনি চলে গেছে হ্যাঁ এবার এসছে
So this is the post-op X-ray. It looks reasonably reduced. So we have certain pearls and pitfalls of this technique. Coming onto the pearls, we can remove the hematoma and soft tissue around the fracture site for accurate reduction. A fiber tape loaded anchor with many sutures gives strong compression of the tuberosity fragment. Place the median anchor just on the edge of the fracture line for an accurate reduction of the posteriorly superiorly displaced tuberosity fragment. Lateral row anchors placed approximately 15 millimeters to the medial row is important to reduce and compress the tuberosity fragment from front to back. Coming on to the pitfalls, the poor visualization is inevitable due to bleeding and displays large tuberosity fragments. Performing bisektomy with a shaver after the anchors are inserted may cause the suture material to cut. Anchor pull-out occurs if the superior anchor is placed on the cancellous bones at the fracture site, especially when using a soft anchors. Inadequate reduction may occur if clean visualization of the fracture site is not obtained. So definitely arthroscopic fixation has an advantage of less soft tissue trauma, blood loss, less morbidities, decreased scar adhesions, and apart from that we can have addressal to the concomitant labral and the cuff pathologies. The disadvantage is more operating time, visibility issues, inadequate reduction and long learning curves. So the take home message is GT avulsion fractures if displaced more than 5 mm needs fixation to preserve cuff functioning. Double row fixation is less invasive, more technical, but a valid fixation method for selected cases. Thank you, Kolkata Arthroscopy Society and Sportsmedcon, for giving me an opportunity to present my talk. Thank you.
Thank you. Any questions?
Thank you.
Okay.
Thank you.
Next is Dr. Pratik Gupta, sir.
Yeah. Good afternoon, friends. At the outset, I'd like to thank Cass and all my friends here in Calcutta for inviting me to this lovely conference. It's always a pleasure coming back to Calcutta and meeting all my friends. So today we'll be looking at cuff tear associated with instability. So thankfully, this entity is less, but we need to be cognizant of cuff tear with instability, especially when we are dealing with patients above age of 40. Under 40, it is less common because the cuff is very strong, and repetitive strain injuries in athlete, sometimes we see cuff tears associated. But age more than 40, it is the deterioration of the structure and the mechanical properties that happen that weaken the cuff and has, as a result, higher incidence of rotator cuff tear. Various reports have shown 30% above 40, and then 57% above 50, and then 60% or 61% above 60. So as the age increases, the incidence increases. Most often it is supraspinatus, which is isolated in 75% of the cases, but a combination of supra, infra, and supra sub is also known in a combined lesions seen. The reason for why this is important is because when we have a cuff tear, we lose a very important concavity compression mechanism, which is important for stability of shoulder. So shoulder with a cuff tear becomes unstable or dislocates very easily, and sometimes small push only causes injury without any extensive trauma to the anterior structures. So how do we pick them up? Anybody presenting with pain after having a dislocation who's been treated non-operatively or not being able to manage having weakness in the shoulder, we should start suspecting a rotator cuff tear. Index dislocation or recurrent instability after 40, we should be very careful not to miss a rotator cuff tear. Examination will show us a weakness and the functional deficit of cuff, and always make a good neurological examination to pick up the terrible triad of the shoulder where there is a brachial plexus involved in infraclavicular, because these are the patients who will take longer and also do not do as well. So what is the investigation of choice? This is the MR arthrogram, or MRI is the standard. You can see both the lesion, the biceps, the Bankart lesion here, the labral tear, and also the rotator cuff. And MR arthrogram will give you even better picture. This is a 60-year-old lady who presented to us. She's a swimmer and a swimming instructor who had instability and pain. We will be seeing her video in a little while. So once we have looked at thinking in terms of rotator cuff, now the management principles for under 40 and above 40 are quite different. When we are dealing with patient under 40, we are looking at more prevention of recurrence of dislocation, while above 40, it is more so with the cuff tear, the associated problems with cuff tear like functional deficit, pain, disabling degenerative changes. So what do we do with the treatment? Usual treatment for any dislocation is reduction and then putting them in a sling and reviewing after 7 to 10 days. If the pain is managed well, they are assigned to physio. But if at that point you realize that patient still has pain 10 to 14 days down the line and there is weakness in the shoulder, then MR, if already not been done, is warranted. Even those who have been put for physio, they should be reviewed in 3 weeks to see if they're progressing well. If there is any weakness, then again one should have a high suspicion of rotator cuff. It is important because if you pick up the rotator cuff tear early repair has a better results. Delaying the repair undermines the outcome. So once we have the rotator cuff tear with instability or anterior dislocation, how do we manage? The tide is tilted towards the operative side because non-operative treatment gives 50% or less result, and more satisfactory results are by surgical repair. And if you look at the various studies, under 40 there is no question repairing both rotator cuff as well as Bankart lesion gives the best result. When we are dealing with 40 to 60, when the incidence increases, here also the results are better if we do both the capsulo-ligament complex tear anteriorly or rotator cuff, both done together. Only when we see a patient of above 60 and especially who's low demand, then one can think of doing only a rotator cuff repair where you still get good results. And when we are dealing with above 70, where we presume that there was a preceding lesion in rotator cuff, and in such cases generally the repair is not as feasible, then one can consider the treatment of conservative tendon transfer. But rotator cuff reverse shoulder is more an option which is being opted for and has shown better results. So this is the same patient who is a 60-year-old lady who presented to us with this pain and inability to manage with the after having a fall. So for some reason this video is starting to give me some trouble. So we can see that there is a Bankart lesion here and rotator cuff tear as well. And the arthrogram had shown there was a big tear. So here we went on and did the Bankart repair, as you can see here. When we started doing the rotator cuff, we thought it was a small lesion, but then we realized that once we debrided it, it was significant lesion, which was repaired using the anchor to the footprint. And she rehabbed well back to her swimming coaching classes that she takes. This is another patient who is a polo player. He is 48. He had a fall from a horse, sustained the injury. He was given a sling, did not manage well. Pain was there and inability to lift his shoulder. And you see there is a big rotator cuff tear. Also there is a retraction there. And once we see the Bankart area, the labrum, it is quite heavily affected. This gentleman had a big anterior lesion, as you can see here, quite a violent force falling from a horse, sustaining this. And he came to us, I think, 4 to 6 weeks down the line. And when we did the arthroscopy, we found it was almost like a panlabral region. So a panlabral repair with 7 anchors was performed, following which rotator cuff repair was undertaken. And he was able to return back to horse riding, though polo became a little problem for him, but he was happy he was able to ride his horse at least. And the last, a different kind of a case where this was a gentleman who presented to us with recurrent dislocation of shoulder at the age of 66, and he had 12 years ago a fall and sustained a dislocation, and then since then many dislocations were there. MRI showed Bankart as well as rotator cuff lesion. Here you can see this big Bankart lesion, and his cuff was torn, but the joint was well preserved, so we did a Bankart repair here. And then since there was a cuff tear was quite large and there were degenerative changes, we went ahead with biceps tenotomy, as we see here. And then the rotator cuff was addressed. As you can see here, there is a large tear on its merit, just as usually we do for any of a cuff tear repair. And he thankfully stabilized and had no further dislocation since. So it was very nicely, the treatment for rotator cuff tear with Bankart was very nicely summarized by Perslin in his study, where he said the aim is to have a very stable repair of both the lesions and then follow it by aggressive rehab in order to get the maximum outcome and to put back the patient to their own physical activity. So in conclusion, whenever we have a patient of an anterior instability or anterior dislocation, especially after 40 years of age, one should have in mind and have high suspicion of rotator cuff injury possibility, as we want to pick them up early, because the studies have shown, and so have the has borne out, that if you repair them early, they tend to have a better repair, better results, because the elasticity of the cuff is better. Conservative treatment seems to give suboptimal results. Repairing both the lesions, both rotator cuff as well as the capsular lesion with aggressive rehab makes the mainstay. Only for those people who are above 60, low demand, here we can get away with doing only cuff repair. And a neurological examination should always be taken to pick up the terrible triad. Thanks.
Thank you, Dr. Gupta. Any questions? No. If we don't have any questions, thank you, sir, for this excellent talk.
Thank you.
The next speaker is Dr. Senthil Villan. He'll be speaking on arthroscopic transosseous implantless cuff repair.
Good afternoon, everybody. I'm Dr. Senthil Villan, and first of all, I thank all the team and especially Dr. Rajiv Brahman for providing this opportunity to talk on. So I think it's not the talk loaded. This.
এটা দাও দিয়েছে দাও দেখো এসছে 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 এটা এসছে
Sure. Yeah. So again, thank you for inviting me for delivering this talk. So my talk is on arthroscopic implantless and transosseous cuff repair. How do we achieve that? And a lot of times in multiple conferences we hear about single row repair, double row repair, transosseous equivalent. But actually the need of the hour is how do we actually achieve a good quality repair? But cost is most often the forgotten factor, which probably is the most important factor when we actually come to actually treating most of our patients. So to disclose, we have received funds from NHHID, which is actually a national health hub for innovative device development, which is a part of Department of Science and Technology, India, for development, prototype, testing, and also for commercializing the device and instrumentation. So most often, in the non-corporate sector, we come across the patients who are the only breadwinners who can present with such a kind of disabling cuff tears, and we offer them, cuff repair with suture anchors presently. But, cost is a significant factor. So if we go back, as I said, this is the transosseous repair system, which is presently certified and also approved. So we know that the rotator cuff repairs have a significant social and economic impact, and presently the suture anchors that we use are gradually moving on, as we know, from metal, PEEK, also to a vented anchor. So when we actually talk about a vented anchor, we know that we are talking about more biology, because we want more amount of the stem cells that come from the proximal humerus to actually allow for more biological repair. That's why we are moving towards biology. So we need a better biology rather than actually moving to a better anchor. So it's time that we went back to the basics, and we know that transosseous has been the gold standard against which the anchors were actually compared against. So how do we get about it? We got to a team of engineers, we tied up with the NHHID, and then we went about trying to actually create a cost-effective but a reusable system. So to actually reduce the cost, the system should be autoclavable, and so that it does not have any recurring cost every time when we do a rotator cuff repair. That was the first priority in which we actually wanted to do the rotator cuff repairs. And then it should be easy enough, it should be reliable, and every time it should actually be accurate. So after a number of mechanical analysis, cadaveric testing, and we had actually come upon a screw lock mechanism for actually a the rotator cuff repair system. So why do we have to do the transorseous? Obviously, it's got multiple advantages. We know that obviously no implant, better biology, because there is no disturbance of the blood supply. Revision becomes a much easier scenario, and obviously it's cost effective. And it is nothing new. We are not reinventing the wheel, but a number of disposable systems are available in the US and in Italy, and where the transosseous rotator cuff is done, and it has been shown that the structural integrity is equivalent to that of a suture-based, anchor-based repair, and also the biomechanically the tendon-bone interface is also as good, or in fact it is better compared to that of a single row repair. So, and the long-term clinical results have also been shown that the transosseous repair is equivalent to that of a cuff repair. So the other systems that have been in the market are the arthrotunneler, Tensoros, but unfortunately these are not available in India, and so we need to create a commercially available system, but it is widely usable and also it should be reusable. So the initial prototypes we actually set out were, very big, and it was cumbersome, it couldn't be used, and then we, honed in on the, we needed both a medial and a lateral tunnels. So, and we, in fact, it is using the same principle of multiple other systems, but it's just that it is a reusable system. So the instrumentation is very simple, where we make vertical tunnels and also the horizontal tunnels, but this has got a very interesting suture lock mechanism which is loaded onto the tip of the horizontal jig, which locks onto the jig, and then it actually, detaches once it actually locks onto the jig in an accurate fashion. So the steps, I'll just go through it. The standard vertical pilot hole is done up to the laser mark, and then the transosseous jig is actually inserted from a lateral portal, but the lateral portal is actually a much lower lateral portal because you want to insert the jig, because I'll explain to you why we actually made it much larger, the vertical part. And then the horizontal drill hole is made, which actually meets the tip of the jig. And once the tip of the jig is met, you insert the locking screw mechanism along with the shuttling sutures. And then once you actually locks, then the screw is actually disengaged along with the horizontal handle, and then it takes off the sutures from the top, and this results in this bone tunnels which are interconnected and leaves the suture. And then it is a standard mechanism of cuff repair, and any type of configuration is possible. Most often, this is the question that we asked. When you use bone tunnels, how many bone tunnels can you do? Will the bone give way? I mean, we know from CT-based studies that actually, the thickness of the proximal humerus is much, it gets thicker as we go down, and we have to come to a level where about around 20 mm it is actually good. But as we go more lower down, we cannot, you are limited by the axillary nerve. So that's why actually we made the horizontal part of the jig about 22 mm so that it captures maximum volume of the bone so that it doesn't cut out. So we recently have published the article, on the technique on arthroscopy techniques. So we'll just go through the video technique briefly. I do them in lateral positions. So this is standard shoulder arthroscopy is done, and the cuff repairability is assessed, and we actually load the tray in the back table, and it is prepared. And this is the standard pilot hole which is done onto the standard medial footprint area and up to that of the laser mark. And once that is done, you can see that the lateral portal is quite low, and then the transosseous jig is inserted. It is in the initial times it would be a little bit difficult, but once we get used to it, then it is much easier. And then you find the pilot hole and then insert it, and once you actually insert it, it is actually has a snug fit to it. And once it is in position, then the lateral drill hole is done up to that predefined mark, so it meets exactly at the point of the tip of the jig. And this is the arthroscopic video which is showing from the lateral portal wire. And then this is the suture lock mechanism which actually goes from the lateral horizontal portal where you actually have drilled through the jig, and then it actually locks onto the tip. And this video is actually showing that the top part where the screw is engaged onto the tip of the jig, and it actually takes the suture shuttle. So now we are left with actually a suture shuttle from the horizontal to the vertical part, and now you can actually load up to 3 fiber wire sutures, and then this can be used for a standard repair by means of using any suture passer. So up to 3 tunnels can be made, because the size of the drill hole that we make, or the part of the jig, is actually about 4 mm, but usually 2 tunnels are usually enough. So any type of configuration are possible, and usually the knots again are placed quite laterally, so it leaves you with not much of impediment. I'll just take 2 more minutes, please. So the rehab protocol is similar to that of any standard rotator cuff repair. We've done about 53 patients so far, and the results after 2 years have been encouraging, and the mean operating time also has significantly reduced, and it is on par with any standard cuff repair. And we've been able to make a lot of difference to. We've trained quite a few of the surgeons, and this is especially in the government sector in South Tamil Nadu, where we've actually been able to train a number of arthroscopy surgeons to actually achieve the results. We've had the fair share of complications in the initial part. Some of the limitations are that when you have an associated subscapularis tear, you may have to use the anchor-based repair along with this. And we've had one patient who had very osteoporotic bone. We had to actually convert and use a much bigger anchor. So now we are in the process of actually commercializing and licensing it, but with a lot of guidelines, because it is actually in relation with the Department of Science and Technology, and in revision scenarios, and also transosseous equivalent repair, we are planning to conduct studies. In the phase 2, where we actually have now moved on to actually knowing the clinical effectiveness of the product, we've actually achieved more funding, and also we've tied up with the newly opened cadaver lab in Chennai, Stanley Medical College. So where about 50 arthroscopy surgeons will be given a day of training hands-on, and then the instrumentation set would be provided to them, so that this can be used for their patients. So in conclusion, it's an arthroscopic transosseous system, implantless, obviously cost effective, and it is comparable to that of any anchor-based system. Thank you.
Thank you, Doctor, for this very innovative new concept which you have brought in. Since we are running short of time, we won't have any more questions. We move on to the next session now. I'd like to call upon Dr. Kanchan Bhattacharya and Dr. Amit Joshi to chair the next session, please.
First session, I think the first talk is by Arnav Kormakar, tendinitis around shoulder.
Yeah, good afternoon. Yeah. So my talk is on tendinitis around shoulder. So I think most of my part has been already covered by others, because the management part is already hugely discussed. So still I'll try to make things interesting, because there are a few things to look upon on the diagnostic part, on the imaging part. देरी হবে না, এটা স্টার্ট হবে। Okay. So regarding the tendinitis, if you broadly classify what are the possible tendons, first things comes to your mind is the rotator cuff tendon. So, and biceps tendon. So, we can broadly divide that most of this 80% to 90% is rotator cuff tendinitis and a part of it is biceps tendinitis. But both these are usually concomitant things. So, you can divide the rotator cuff tendinitis into subacromial impingement syndrome, because that is the more commonest reason of being the tendinosis in the rotator cuff, and another big thing is the calcific tendinitis. So, what is important about the rotator cuff tendinitis or a subacromial impingement syndrome? It is the most common disorder of the shoulder, to be very astonishing, accounting almost more than 50% of the comprising of shoulder pain. And Need has first actually explained the term impingement syndrome in way back 1972, and he has described different stages of developing of this subacromial impingement. In the stage 1, that happens to be edema and the hemorrhage in the tendon, and it is usually seen in younger patients and the lesions were reversible. Whereas stage 2, that develops into fibrosis in the tendon, and that causes a chronic inflammation, usually a little bit older age group, and that causes recurrent causes of shoulder pain with activity, specifically the overhead activity. And stage 3 develops into bony spurs, and that bony spurs can lead to a rupture of the tendon. The disability progresses, and it is mostly seen in a older age group of patients. So this is a picture. You can well see the position of the subacromial bursa. It is very crucial structure that can prevent the friction of the rotator cuff tendon with the lower edge or under edge of the acromion. But what happens in the abduction? This bursa is compressed and the rotator cuff actually getting friction with the subacromial space with the undersurface of the acromion. So if there is any deformity or any spar or any arthritis in the AC joint or the subacromial space, that can lead to chronic tendinitis. So secondary impingement, there is a concept of primary and secondary impingement. It is usually associated with repetitive overhead activity because of their job, and if there is an instability scenario also present, that can also lead to impingement syndrome. So that is called a secondary impingement in the presence of an instability scenario. And we all know that the supraspinatus tendon, it's the most common tendon which is actually getting involved in the impingement syndrome. And there is a critical zone of avascular area at the base of insertion of the supraspinatus that is actually causing the pain. And Job has classified the stages of subacromial impingement in athletes. So stage 1, there is pure impingement, no instability. And stage 2, primary instability with capsular or labral injury with secondary impingement, which can cause internal impingement or subacromial impingement. Stage 3, primary instability because of generalized ligament laxity with secondary impingement. And stage 4, pure instability and no impingement. But one big thing you need to exclude before taking a conclusion in the impingement syndrome, that some of these patients are actually having a scapular dyskinesia. So late activation of the lower trapezius and the serratus anterior and an early recruitment of the upper trapezius fibers lead to a narrowing of the subacromial space during shoulder abduction. That could be a possible reason. A review of the literature of these topics confirm that these patients with shoulder impingement have a decreased upward scapular rotation, a decreased posterior tilt, and a decreased external rotation due to an imbalance in the periscapular muscles. So before jumping into conclusion or before going for management plan, you need to exclude this problem. How we are going to diagnose this? There are various clinical tests, and the diagnosis is absolutely very clinically can be done, and obviously can be established with proper radiograph. So I'm not going to discuss all the detail. But there are few important things you need to see in an X-ray. Subacromial sclerosis or spars, especially in hooked acromion, anomalies of the acromion, sclerosis of the greater tuberosity and undersurface of the acromion, reduced subacromial space with a proximal migration of the humeral head if associated with a torn or dysfunctional rotator cuff. It can be seen in X-ray. So there is a Biglani classification grading of acromion deformities. In type 1, acromion is flat in shape. Type 2, it is more curved acromion which lies parallel to the humeral head. Type 3, the edge of the acromion is hooked, which is very high chance for getting impingement. Ultrasonography is a very good way of investigation, and sometimes it can help in management when we are planning for a local injection. There is a Milgram's ultrasound classification that actually understands the thickness of the bursa and that whether any associated cup tear is present or not. This is a very important thing, though it may look clumsy, but I like to take your attention. This is a very good paper, you can read this one, Bigliani et al. And Kita et al. They describe all the possible things we need to look in a radiograph. First of all, we need to understand the acromion slope. So how this anterior part of the acromion and posterior part of the acromion is differentiated in between the angle. Then we have to understand the acromion tilt, that is the angle that has been calculated with the position of the coracoid and on the acromion. Then we need to understand the acromion index, that is the final one. And finally, we need to understand the angle between the glenoid cavity and the acromion. So all these things actually, there is a correlation between the impingement syndrome and these radiographic features. Regarding the management, there is most of these cases can be managed by physiotherapy and exercises. Some has role in laser therapy also, and local injections are also very popular in this type of scenario. Regarding surgical management, yes, historically open subacromial decompression has been described, or acromioplasty has been described by Neer, but it is nowadays not done because most of the surgeries are done arthroscopically. So regarding arthroscopic decompression or subacromial decompression, I like to say two different techniques are described in the literature. So in one type of technique, there is a cutting block technique. So you can put your scope from the lateral portal and you can put your resector from the posterior portal, so that you can understand to create a normal slope in the acromion connecting to the posterior to the anterior part. This is one form of technique, and another form of technique is described way back in 1995, that you put the scope in a normal posterior looking portal and you put your resector from the lateral portal and you resect the undersurface of the acromion. This is what we do commonly because we are combining the procedures with either rotator cuff repair or any other procedures. So regarding calcific tendinitis, it is the carbonate hydroxyapatite deposits that usually located in the supraspinatus tendon. Women aged between 30 to 60 are most common and frequently affected. The reasons behind are described in the literature are tendon hypoxia, genetics, or an endocrine disorder. Sometimes high uric acid level may also cause this calcific tendinitis. So radiography, yes, for calcific tendinitis you need to look in the X-ray properly. You need to understand the size of the deposit, and according to the size of the deposit, Bosworth has classified in 3 categories: small, medium, and large. Large is more than 1.5 centimeter. Gartner classified the calcific deposits according to their radiological appearance, whether it is sharp, dense contour, whether it is poorly defined or dense or sharp, or whether it is poorly defined or transparent. Because if it is poorly defined or transparent, it's very difficult to be located in the surgery. Surgery is standard is removable, arthroscopic removal once it is symptomatic and creating problem. But one important trick is that you just do the diagnostic scopy before removing it completely. You try to locate it with either 2 of your needles or 2 of your K-wires. Then you try to debride that area locally, and always keep your cuff repair set with your hand, because it may be, it seems that cuff is intact, okay, but once you debride that area, you may see that cuff is torn. So if it is torn, you need to repair the cuff also. And finally, the biceps tendinitis, I think we have already discussed about this. Most of the times it is not an isolated disease, it is most of the time it is related with the rotator cuff tendinitis. Sometimes it is related with arthritis, whether instability scenario also. So we can MRI jolly decide, diagnosed, can diagnose in the scopy also, and surgical management, we can either repair or debride it, or we may tenodesis or tenotomy depending on the scenario or associated disease. I think it has been widely discussed already, so I'll stop here. Thank you.
Thank you, Dr. Karmakar. Any questions here? So I think you've described everything very well. Thank you very much.
Thank you, sir.
May I call Dr. Biplab Dolui to speak on stiff shoulder, current concepts.
Good afternoon and thank you, Chairman Sir. Member of upper limb committee, Isakos, tried to make a consensus on stiff shoulder. They published a monogram titled Shoulder Stiffness, Current Concept and Concern. Most of my presentation is from that publication only. Isakos favors the term frozen shoulder over adhesive capsulitis as because there is no intra-articular adhesion involving articular surfaces. They also divided shoulder stiffness into two groups, primary idiopathic stiff shoulder, that is classical frozen shoulder, and into secondary stiffness depending upon whether there is any underlying disease process or not. Pathology is nowadays well understood. It starts as an inflammation involving synovium and capsule. As time progresses, fibrosis appears, particularly anterior inferior capsule and various ligaments. With more passage of time, both inflammation and fibrosis subsides. Clinically, it's mostly a clinical diagnosis. There should be both active and passive range of movement restriction. At last movement should be tried is the external rotation by keeping the arm by the side of the chest. You can hear or feel the crackling noise of breaking the adhesion. At the end, you need to repeat all the movement once again to check whether terminal range has been achieved or not. But nowadays, the preferred technique is arthroscopic capsular release. It is advisable in resistant cases where there is failure of multimodality of treatment. You can do controlled release. You can identify the thick structure and release it. This is a 65-year male patient, diabetic. He was resistant to all modality of treatment. We entered into the joint through posterior portal, started releasing the rotatory interval using a radiofrequency probe, including coracohumeral ligament. Take care of subscap. Once rotatory interval has been released, then you need to release the middle glenohumeral ligament and anterior inferior capsule. Proceed up to posterior inferior corner. We usually do not release the inferior capsule because of close proximity of axillary nerve. We break it by doing manipulation at the end. So in conclusion, you should try conservative treatment in most of the cases. It would be successful even up to 90% of cases. Conservative treatment gives good result. Before contemplating any intervention, you should try at least 6 to 9 months of conservative treatment. If you are considering any intervention, manipulation and arthroscopic release are equivocal, but ACR is nowadays preferred technique than the manipulation because of fear of complication. Thank you.
Thank you, Biplab. Are there any question to? Yes, please.
Arthroscopic release is reserved for the resistant cases. When all the conservative treatment failed, we do it and immediately you can get full range of motion, nearly full range.
So the results are good, even
results are
long-term
good,
results
yeah.
So, Biplab, my question is, how do you decide it's time either, how do you decide you manipulate or you take for surgery?
Manipulation, immediately after anesthesia, we try for manipulation first. If we see that it's resistant, we won't be able to achieve at least a satisfactory range of motion, then we go for arthroscopic release.
I observed that you give an injection without ultrasound, but for hydrotherapy you need an ultrasound. Now it's been proven that you can hit the area either way. So why do you need that? Because it's 20 cc?
Yes, sir.
Why do you need an ultrasound for hydrotherapy and you don't need it for injection?
No, I just wanted to show that it is also another technique. You can take USG guided. Otherwise, those who do regular arthroscopy, it's not a big deal. They can do it very easily.
Yeah, they've gone a full circle now, going from injecting all the time to saying that it is not required.
Thank you, Biplab. That was an excellent talk. May I request Dr. Arvind to Okay, so we have done with the session. Thank you very much for keeping in a very short and sweet session. May I request to continue the next session? Thank you very much.
So next session is master technique in knee, and the chairperson for this session is Dr. Ritik Ganguly and Dr. Jaya Prasad Pidda.
So first talk is the master of this technique and our teacher Dr. Kanchan Bhattacharya sir. He will be talking about PCL.
Good afternoon, everybody. So, I'll run it quickly through how I do my PCL reconstruction most of the times. We've seen this being done. Ananda Mandal has shown his way of doing it. Roshan Wade has shown his as well. And it's not very different. So, I do a transtibial arthroscopic PCL most of the times. Use a high anterior portal. Keep both the portals very close to the center. The first thing we do is do a complete knee roundup. Having trouble with the video? Video?
ভিডিওটা এ করনি তখন হ্যাঁ ওখানে চলছে এইচডিএমআই আছে নাকি
All right, as they're preparing it, so I make my portal close to the center, high lateral portal and a medial portal also pretty close to the patellar tendon. I use gravity assisted saline. Very rarely do I use a pump or any additional. Been right to the left. So while I'm going through my trials and tribulations, let me extend the bad news that Indian women have lost in the last ball. So they are not going to the semi-finals, no. So I think we let this pass. Let somebody else present theirs. There's no point wasting so much time. We are running late anyway. Video is not running. It was running when I went out there. এখানেও চলছে না তোমার Is it? Okay, then we will have to do it without the, you'll have to just listen to the voiceover. So we do, this is the first one, we do a complete knee roundup. We look at all the structures, clean up the soft tissues so that we see it better. The ligamentum mucosum is frequently present, and so we take that out as well. And then do not forget to look at both the menisci and both the corners. The thing that sticks out is you see that the ACL does not look as normal as it normally should, and the ACL looks floppy and kind of more horizontal. The menisci is all right, a little bit opening on the medial side, but very important to look at the posterolateral side and see if there is any drive through. The next thing we do is so this is the next part. Here we clean up the stump, femoral stump of the PCL and see how close it is to the articular surface and make a mark with the RF so that we know where we come back for the femoral portal later. We put in the femoral guide pin there, go along the medial wall, clean up whatever is needed of the PCL. Here, as opposed to ACL reconstruction, we have to clean it fairly assiduously so that we can see the back and see what we are doing, and also make sure that we do not damage the ACL. So stay close to the wall, go right back, see the back of the knee, and when you go to the posterior compartment, the next thing you do is try and then when you reach the posterior compartment, the next thing you do is identify the posteromedial portal with a spinal needle. Once you have the posteromedial portal, you enlarge it, and then and I use a clear cannula so that we don't lose it. And this is the most important, the intricate part of the PCL transtibial. You clean up the back of the tibia. Make sure that you go distal to the posterior posterior edge of the medial meniscus and go beyond that. You see some shiny fibers. If you can put your scope way high and way back, and that's at the back of the posterior part of the medial meniscus. And as the slope goes down, as it's described as the champagne flute, you try and aim for that area which is about 10 to 12 millimeter away from the horizontal. You have to make sure that you're going beyond the horizontal so that you do not damage any part of the medial meniscus, because that way you'd be doing a lot of disservice to the patient. You can use RF, but be very careful when you use it. And actually you have to come both from the front and from the PM portal to make sure that you clear that part very, very nicely. And this is a pretty stressful part as long as you've not seen it. No matter what guide you use, you'll have difficulty in seeing it from the front. If you have any difficulty, you can put the scope in the posterior portal and view from the back too. I avoid doing this because I seem to get a little bit of disorientation when I keep switching my scope back and forth. I did it many years ago, but I don't do it now. The other thing which we all had done at some point of time, and at some point of time we gave it up, is using a C-arm while doing this. So we use the guide, and then the drill hole is made. And once the drill hole is made, we clear it very nice. You can see the tip of the drill hole there. Make sure that you clear it so well that you do not miss it when you ream it. The other important thing that I always follow about reaming the tibia in case of PCL is never to use a tibial reamer. I use an Acorn reamer because this is less aggressive than the solid reamer that we normally use for the tibia. This Acorn reamer goes slowly. You can control it a little better too. Let's say it's a little less efficient reamer than the solid reamer. So at all the time, you have to view the tip of the guide pin with the protection, whatever protection you're using. I use one of the devices or sometimes a curved curette to protect it. Once the tunnel is made, in this case I do remember it's a 9mm tunnel, but the tunnel is made, lead sutures are passed through the tunnel. That is going to help us in pull the graft in. So this is the back end of the bead pin going in. It's good to use a colored suture. You can use the white ones, but a green one is a little more easily visible while you're dealing with everything that's going on there. And especially if you're working in 3 different centers where you may not have the same staff working for you. So once you retrieve it through the PM portal, I find it easier to deliver it through the AM or AL portal and leave it there, because I'm soon going to need that for passing my graft through this. So here I'm retrieving it through the AM portal. The next thing to do is to make the femoral tunnel. Now this is the 9mm graft, so I use a 9mm reamer. So I use a 9mm reamer, and that's the 9mm reamer you can see as the guide. It's at the edge of the articular surface, and I've already centered the mark with the cautery before. I pass it from a low enterolateral portal. If I can view it properly from the normal AL portal, then I'll keep both of them on the same side. But in this case, I have moved the scope to the AM portal, and I made a low enterolateral portal and gone in with my guide pin through the 9mm graft. Once the guide pin is gone, you make the tunnel with the 9mm. About 30 should be all right, because this will certainly be anything between 38 and 40 in most cases. And the more curved you get, slightly bigger you get. So you've got a 30mm or you can even up to 25, because the minimum graft that you would want inside that tunnel would be about 15mm. And I use an endo button to fix it up. You follow this up with a 4.5mm guide pin and then measure it out. So now you have the guide pin. So both the tunnels are ready. The next thing you do is to do the final part, put the graft in. So we have 2 separate colored sutures, one for the femoral tunnel, one for the tibial tunnel. At this point of time, I bring my scope to the AM portal, deliver the white sutures which is coming out from the femoral tunnel out to the AL portal, take the graft, which in this case was 4-fold peroneus, 9mm wide and about 85 or 90mm long. So, and this is the graft passage now. So I pass in the through the femoral tunnel first, with the rest of the graft outside the joint. Once the mark I see, which is that 30mm, reaches the edge, I flip the endo button and tighten the femoral end. Now the femoral end is fixed. Now here you have a little bit of bunching, because part of it, the graft is inside and you have to deliver it into the joint. Now the green thread that was meant for the tibial tunnel was lying in the AM portal. I bring it now to the AL portal, take the sutures in, take the sutures of the tibial end that's remaining through those leads, through those pull sutures, and pull it out through the tibial tunnel. I maneuver it and help the graft to reach inside, because it's bunched, it becomes a little tough in here. You may have to widen out the aperture also, but once it goes in, you need some real orthopedic skill. You need strength. You need a strong guy to pull it down. And if by mistake you're doing a double bundle, my God, it's really hard bringing it down, really hard bringing it down. So I've seen a lot of American surgeons spend hours on it and never giving it up. Ian must have seen it too. They will not give it up. The strength part, they will not give it up. I always give it to my younger guys to do it now, but this is still quite difficult. And all the time, you have to maneuver the thread and see that the direction is right. And one other thing, since we're switching portals, also make sure that you suddenly do not go around the ACL. You do not want to trap the ACL in the PCL as it's going down. And once the graft goes through and you pull it out through the tibial tunnel, and once you apply the certain amount of tension to it and you find that the step off is gone off, you'll also notice that the ACL, which is lying horizontal, has now become taut and pretty vertical. And that tells you that you're almost done. This is a small piece of osteoarticular cartilage which has to be taken out. So once the graft is in place, and this is the graft that is in place now. Graft is never too long to come out unless it's use a double fold and up to about 105 or 10 millimeter. Some of it stays inside. So I use an interference screw. I do not really go towards the back, the aperture at the back. I just go in so that it's a level with the graft that's there. And I always add an additional suture post for PCL, and for all my revision ACLs, there's always a secondary fixation required. And X-ray, and this is, I'll show you an X-ray at the end, and that was the end of the picture. We would, even up to here, it's permissible. If you get your tunnel from up to here, it's permissible. This was pretty dramatic, quite low, but even up to here, it's permissible. If you go here, it's not a very good job. And as you see this, this is the point where if you go from here, you would still skim a little bit of the medial meniscus, but distal to that, you will not. And this is the additional fixation that I have. And this is a picture, well, this is an immediate post-op, so not a kneeling thing, but it does not, the step-off seems to be pretty much all right. It is, I want to think it's all right. I have seen the patient post-operatively twice. This is about 3 or 4 months down the line. So he's doing pretty much all right. There is a TBL step-off, and it's still not ripe enough to find out how much sag he has. But this is the way it is. Thank you very much.
Thank you, sir. Question, please.
So there's one question from here.
Yes.
Rohit. So, how far down should we go for making the tibial tunnel? And is it easy to visualize from the anterior portal? Because I saw most of your visualization was from the anteromedial portal.
Yes.
You don't go to the posteromedial portal?
I very rarely go. I used to do earlier. Like I said, I find difficulty in orientating it, going back and forth. I'm not very comfortable. Now, 2 things. One is you can see very well provided you do it fairly frequently. With PCL, fairly frequently means if you're doing 2 in a month, is fairly frequent. Yes. Okay. Big time surgeons, and this is what I found in the COVID times, big time single surgeons, their average PCL in a year is 20 to 30. So if you're doing 2 in a month, you're in the higher range. So if you do long enough, with a 30-degree scope, you can see fairly well. If you're comfortable with a 70-degree scope, you can see even better.
Yeah.
If you're comfortable with 70-degree scope, you can see that part even better. Not a very good idea to switch between 30 and 70 degree. Again, orientation problem comes
that
there.
is a problem.
One other thing I found out that not using the PM portal helps me in one way. When I use the PM portal, I become a little more cavalier. I always end up putting my tunnel a little lower down because I can see it from there very nicely. And then when I try and retrieve it, I find I'm in trouble. And this turn, getting the graft into it, becomes a little more hard that way. And to answer your question, I think regardless of whatever guide you have, 12 to 14 millimeter is enough.
Is enough. And another question, sir, there's a talk about killer curve in these.
Now you notice, if you start from lower down, you have a fairly vertical tunnel. So that way you negate it a little bit, but you cannot take it off the table entirely.
Thank you.
Thank you.
Thank you, sir, for nice presentation. Next speaker is Dr. Ranjit Panigrai. So he will talk about all inside ACLR with internal bracing and LET.
Yeah, good afternoon all. My topic is all inside ACL with internal bracing along with LET. So coming to the case profile directly, it's a 30-year male with a history of injury 1 month back, presented with complaint of pain and instability. And on examination, he was found to have hyperlaxity with Beaton score 7, positive Latchman, grade 3 pivot shift test, no mediolateral instability, no malalignment, and on MRI, he was found to have ACL tear with some of the AM bundle remnant intact. So this was the MRI of the patient, and these are the clinical findings. So the patient is hyperlax. You can see the genu recurvatum, how much of hyperextension he is having. The Lachman test and the pivot shift test, both are positive. Pivot is grade 3 pivot shift. So we went on with a all inside ACL reconstruction augmented with internal brace and then LET. So this was the diagnostic scopy. So here we can find the ACL, which is completely torn. So you can see it's completely torn from humeral side, except some fibers of the AM bundle are intact, only few fibers. So then we went ahead with marking the femoral tunnel and then the tibial tunnel. And the semi-T only graft was taken, graft link was created. The ethibond, the fiber wire was applied on both sides to have the mark, and then it was measured. The length was 6.5 centimeter and the diameter was 7.5 millimeter. So it was augmented with a fiber tape as internal brace. The both ends of the fiber tape was passed through the proximal button, and then it was crossed in the tendon substance, and then it was passed in the distal button. Nowadays, the preloaded fiber tapes are also coming with the tight ropes. So once the graft construct is done, then the ACL all inside femoral jig is kept at the intended point, and with the flip cutter, the drill was done. Inside the knee, it was flipped, and the retro socket was created. Usually 15 to 20 millimeter of the retro socket is enough on the femoral side. So once the retro socket is created, then it is again taken back, unflipped inside the tunnel, inside the joint, and the flip cutter was taken out. Now the debris were cleared with saver, and you can see the tunnel inside tunnel. Now with beath pin, the leading suture was passed. It was retrieved anteriorly with suture retriever and was parked there. And then deflecting this little remnant on the tibial side, the tibial footprint jig was placed on the tibial footprint, and with the tibial side jig, again with the appropriate size flip cutter, the tibial drilling was done. Once the flip cutter was inside the joint, again in the similar way, the jig was taken out. The flip cutter was unflipped, and the retro socket on the tibial side was created. So one should be very careful that the creation of the retro socket is started after this flip cutter touches the bone, and then you can take the appropriate measurement on the marker outside. Usually 30 millimeter is enough on the tibial side. So once it is done, then again the beath pin with the suture was passed. After this flip cutter is taken inside the knee joint and unflipped and taken out. So once the beath pin and the suture was passed, then through the passport cannula on the anteromedial portal, this suture was retrieved, followed by retrieval of the femoral side leading suture. So once it is done, then the marking on the tightrope grappling construct was done. and it was pulled inside the joint up to the marking, or you can directly see through the tunnel. So once appropriate area is approached, then it was cinched to pull the tendon inside the femoral tunnel. So once the tunnel is inside the femoral tunnel, once the tendon is inside the femoral tunnel, then the tibial side tightrope and the internal brace was loaded on the leading suture. At this time, with the help of a probe, the remnant was a little bit deflected for smooth passage of all these constructs. So once it is pulled inside the tibial tunnel, then gradual cinching on the tibial side again done to pull it inside the tibial tunnel. Then finally, the graft was fixed on the tibial side with further cinching after cyclic loading at 10 to 15 degree of flexion, and then the internal brace was fixed in full extension, or rather with little hyperextension, so as to create a differential tension. Now we will go ahead with the creation of this LET. So incision was given along the line of the lateral epicondyle and Gaudi's tubercle, and the IT band was exposed. A 1 centimeter strip was taken in the middle of the IT band with the help of 11 number blade initially, and then it was extended proximally, and a measurement procedure was taken to extend proximally, and always check the width should be at least 1 centimeter. So once it is released proximally, then it was released distally to gain a length of at least 8 to 10 centimeter. Then a number 2 fiber wire was taken, and weave stitches in Coracoid manner was applied to the end of this IT band strip, and it was measured. Then the LCL was identified, and underneath the LCL one suture is passed, and the femoral tunnel is created just behind and above the lateral epicondyle in a proximal and anterior direction. Then over the leading suture, this IT band strip was passed underneath the LCL, and then it was reloaded on the femoral side, and over a guide wire it was passed into the femoral tunnel. And at this point you further cinch the ACL tunnel, and then fix the ITB strip on the femoral side at 70 degree knee flexion with neutral rotation. So this is the final picture, and inside the knee you can see the anterolateral opening has reduced significantly. And this is the stability clinically, no pivot shift test, and the Latchman is negative. Thanks again for the opportunity to CAS and IS for this wonderful experience.
Thank you.
Thanks, sir. Thank you for your excellent presentation. What measure you have taken to prevent tunnel collision while dealing both the tunnel for ACL and LET?
LET, that is a major challenge when you are doing combined ACL and LET. The two things you should be very sure about, because when I am taking out the ACL leading sutures, so I retrieve through the incision what I have given through the IT band after taking the IT band strip, so that you can see at what point the femoral tunnel is coming. Number two, you can take your scope inside when you are doing this femoral tunnel, so that there is no coalition of these two tunnels, and you keep it proximal and anterior. So these are the three measures you can take to avoid the tunnel coalition when you are going with a ACL and LET in combination.
I can add one point here. while we are doing such kind of procedure, we pass the guide wire through the ACL tibial tunnel, femoral tunnel, and then see under the vision with the scope, and then pass this guide wire for the LET on the femur.
Yes.
Okay. Thank you.
Can I just ask a couple? I think first part has already been taken by Dr. Gurdev. So, have you tried drilling the ITB femoral tunnel with the scope inside the joint?
Yes.
And the graft of the ACL not yet in place?
Yes. In certain situations, I do first the femoral tunnel and the tibial tunnel, and without passing any of your graft, you harvest the ITB and do the femoral tunnel and see it through the scope, and then you complete the ACL and then ITB femoral tunnel fixation. But if you are careful enough while seeing all those three measures, it's rarely required to do so.
So
the thing is how is your tunnel direction, that is more important. So if you are sure of your tunnel direction, by proper placement of your direction when you are drilling a femoral tunnel, there is a very less chance of coalition. But in short knees, when you are confused, small lateral condyle, then what you are telling is a very valid option to go with that.
Or use something else apart from an interference screw?
Yes, or else you can go with the femoral fixation outside in technique, so that you can very well avoid this kind of tunnel coalition. But it's very rarely required. I think most of the times, if you are properly maintaining and the good size lateral condyle, then tunnel coalition is very minimal. The complication arises when the lateral condyle is very small, then you have to take all these measures properly. Unless otherwise you are sure of your you are not coalescing to this tunnel.
Which are the cases you are picking up for doing LEAT?
For LET. The major cases which I am picking up is if the person is a very high demand athlete and less than 25 years and wants to do this pivoting sporting activities, and he is having a grade 3 pivot shift, then definitely for sure to protect our graft, I am going for this LET. In hyperlax individuals, I am going for LET, and most importantly in all the revision situations, to protect our graft and to decrease this pivoting activity, because we do not want to take any chance, so we should go for this LET procedure.
So essentially hyperlax and high demand.
Hyperlax and high demand and revision.
So,
thank you.
Thank you. So we,
Thank you very much.
for the time constant, we have to move first. Oh. Our next speaker is Dr. Dipesh Patel. He will be talking about popliteal sling reconstruction.
Thank you, chairpersons, my seniors and my colleague. Today I am going to present a topic named popliteal sling reconstruction, when to do and how. So to begin with the anatomy, as we all know that a posterolateral corner is a very complex area of the knee which is composed of a large number of structures, among which a popliteus tendon or a popliteus musculotendinous complex is one of the important structures that maintains the rotational as well as the posterolateral subluxation of the knee joint. If we see the attachment, popliteus tendon is attached on the posterolateral surface of the tibia just above the soleal line, and in a femur it is attached just at the dorsolateral aspect of the femur. If you see the function of the popliteus tendon, it mainly prevents it helps in rotation, medial rotation of the tibia on the femur when femur is fixed, especially while sitting, and it also helps in the external rotation of the femur on the tibia when tibia is fixed while we stand. It also prevents the unlocking, it helps in the unlocking of the knee, that is while bending, as well as prevents the forward subluxation of the femur during the clutching. When we go through the incidence, isolated posterolateral corner injury is very rare, which is usually less than 25%, and it is always, it has a high incidence with a multi-ligament injury that is commonly associated with ischial or a PCL injury. And if it is untreated, it may lead to a varus or an rotational instability. It may be associated with peroneal nerve injury, that incidence is around 13 to 30%, and it is repaired within 3 weeks, and for reconstruction we go for more than 3 weeks, so that the knee gets silent and swelling subsides. If we see the indication, we have to always check for ACL and PCL injury. We have to look for the gait, that is varus thirst, as well as the nerve injury, and varus stress test, along with the reverse pivot shift test, and most important is the dial test, that is in the 30 degree. If it is positive, it is a posterolateral corner involvement, and if it is positive in a 90 degree, it is a posterolateral corner as well as the PCL injury involvement. If you see a normal MRI, it can easily, and here we can see the popliteus tendon. So the best test for a doubtful PCL is, we have to always go for a MRI as well as the clinical test like posterior drawer and the stress X-ray. In X-ray, in a lateral view, we can see the grade subluxation of the tibia, that may be a grade 1, 2 and 3 depending upon the degree of subluxation, that 5 mm, 5 to 10 and more than 10 mm. This is the way we do a dial test, that is for a posterolateral corner, which is a rotatory component. So dial test signifies the rotational rotatory component of posterolateral corner as well as the entire posterolateral. So if you go through the classification given by Fenelli, for type A, where there is a more than 10 degree of external rotation of the tibia, which shows the damaged structures are usually the popliteus as well as the popliteal fibular ligament. So while doing the varus stress test, if we do a varus stress X-ray, here we can see a joint line, opening of the joint line. Can we say that it is here the lateral collateral ligament is involved? So in that condition, if we compare with the opposite side, we can see that it is almost equal. So for a lateral collateral injury, it must be more than 4 mm of the increment on the affected side according to the Laprade. While for posterolateral corner, it should be up to 2.7. So if the varus stress test is less or negative, though LCL will not be involved, here only popliteus will be involved. So in that condition, we will go for PCL reconstruction as well as the popliteal sling. So the indication for the popliteal reconstruction will be a grade 3 PCL with a dial test positive. Regarding the technique, we will go. This is a we can make a tunnel through. Just this is a Gerdy's tubercle and this is the tibial tuberosity. We have to always go through in between them so that the tunnel should pass just above the fibula at the posterior attachment of its popliteus, which we can see posteriorly at this level. So regarding the portals, we always use a high and a low anterolateral as well as the posterior medial and posterolateral portal, and is the transseptal portal. So once we go inside the joint, we can see a good floppy ACL sign. Then after debriding the popliteomeniscal fibers, we can easily see the torn popliteus. Here it is. I will skip the major portions as it's a video for a PCL reconstruction. And then we will then through the viewing from the posterior medial portal, we will make a tunnel for a popliteal link, putting ACL jig from anterolateral passing through the posterolateral portal, and we will make a tunnel of 4.5 mm drill bit, and we will pass the thread through the posterolateral corner, and then after that we will put a scope through the higher anterolateral portal to see the insertion of the popliteus at the femoral side. Then we will make a tunnel, give a transeptal portal, and through that we will make a tunnel from dorsolateral to the medial for the femoral tunnel, and we will pass the graft through it. This is the way. Here it is moving. Now we can pass. So the technical problems that can occur is the common peroneal nerve injury, which is usually making during the posterolateral portals. And to prevent this vascular injury, we have, if we go through from the lateral, that is through the Gordy's tubercle, there is a chance of a popliteal artery injury. So we have to always be slight medial, aiming towards the lateral portion, so that we can prevent the injury. So to conclude, there are few subsets of PCL injury where we can escape, which can escape the LCL injury, and anatomical PLC, that is the dial test and the varus instability. If these two are present, then we have to go for anatomical PLC reconstruction, and PLC and popliteus through the arthroscopy provides a less morbidity. Thank you.
Any questions? So that we can, thank you, Dipesh. So we can move into the next lecture, the medial meniscus all inside repair by Dr. Ashok Silvaraj. Yes, please.
Good afternoon. At the outset, I'd like to thank Dr. Raju Raman for inviting, and the Kolkata Arthroscopy Society for inviting me for this conference. My talk is on all inside meniscal repair. It is important to repair the meniscus. Gone are the days when we used to do meniscectomies. Now, with the advent of all the new technologies what we have, especially in all inside repair instrumentations, we get good robust repairs, and which will go on to heal very well, and we get good outcomes. Each instrumentation provided by the companies have their own advantages and disadvantages. We choose the which works for us and stick to that. What are the technique we use? All inside, inside out, or outside in technique. The principles of meniscal repair remain the same, which is being, we should use as many sutures to achieve stable anatomical repair, and you should have at least 5 mm distance between each suture. Vertical orientations to sutures from the meniscus to the capsule has an increased failure strength, but in certain places we can also use horizontal or oblique sutures, and it is important to have a combined stacked superior and inferior sutures to achieve a balanced repair. As you can see in this picture, which gives adequate compression, leads to optimal outcome. So I'll start with slide is not working.
ডিসপ্লে সেটিংটা কোথায় আছে ডুয়েল করতে হবে ডিসপ্লে সেটিং ডিসপ্লে সেটিং নারায়ণ ডিসপ্লে সেটিংটা ডুয়েল করতে হবে তবে আসবে সেটিংস আছে সেটিংস তবে ভিডিওটা নেবে নাহলে আসবে না ডিসপ্লে সেটিং এটা ডুয়েল করতে হবে কিন্তু নিচ্ছে না এমনি প্রেজেন্টেশনগুলো চললো এখানে দেখাচ্ছে মনিটরে ডুয়েলে না এবার আসবে এবার আসবে এবার ভিডিওটা চালিয়ে অফ থাকলে আসে অফ থাকলে আসে
Sorry for that. I'll start off with the usual vertical tear of the posterior horn of the medial meniscus. We prefer to do an all-inside repair for all posterior horn or posterior horn body junction repairs. We can either use a vertical mattress suture or an horizontal mattress stitch based on the width of the repair. Once you put the superior suture, you can see the meniscus lifts off. So it is important for us to reduce or balance the repair. So you have to always put an suture in the undersurface. You can either use a all-inside device, but if it is in the body, you can also go ahead and do a inside-out sutures. But since it is in the posterior horn, we used a all-inside reverse curved all-inside device. So once you apply suture and you reduce it, at compression, you can see that the meniscus is compressed, you get adequate balance. So once this happens, there is no synovial leak inside, and we get good compression. The repair goes on to heal. So next case would be the posterior horn of a radial tear. It's a radial tear of the posterior horn of the lateral meniscal tear, with also has a vertical component to that. These are complex tears to repair because it's in the place where it's just anterior to the popliteal artery. So once you do a diagnostic arthroscopy and plan for a repair, you do remove any loose flaps which impede the repair, then you have to plan for your repair. So ideally in a lateral meniscal tear, you pass the all-inside sutures from the anteromedial portal. But in this case, when it is at the posterior horn, you will not be able to get the adequate angle as it's shown in this picture. So in this case, you have to go through the anterolateral portal, then there is a risk of popliteal artery injury. In those cases, what we do is, the literatures are shown that when you plan this, keep the knee flexed beyond 90 degrees, and also keep the stopper at 16 or less than 16 mm, you can reduce the risk of neurovascular injury. Once you plan that, you make sure that you place the all-inside device carefully, not over-penetrating. Once you have done that, before tightening the suture, we have to reduce the meniscus. That is more important. Otherwise, there will be an overlap. You reduce the meniscus before you tighten the sutures finally, and you can see that you can get good reduction as you get in a fracture. So once you have applied a suture above, it is also pertinent for us to repair the undersurface here as well to get a good compression. So you apply the similar all-inside device in the inferior aspect, also reduce it, and you get good compression. Another advantage of all-inside repair is you can get very nice compression at the tear site, any pattern of the tear. So once you compress it, you can see that the tear is reduced comfortably, and also in the end you always check for the check for the strength of the repair by suction method. Moving on to the ramp lesions. Ramp lesions are difficult lesions to treat for even seasoned surgeons. You have to do a posteromedial portal, you have to have instrumentation for that, makes it very difficult. But ramp lesions can very well be repaired by all-inside method. So these are the types of ramp lesions. When you do a diagnostic arthroscopy and you see underneath and pull and see if it is mobile, that means there is a tear. Once you know that there is tear, you have to repair the meniscotibial ligament to the meniscus. So you put a reverse curve to the first to the meniscus, undersurface of the meniscus, and then into the posteromedial capsule along with the meniscotibial ligament. Once you apply that and give compression, you can see that the meniscus gets reduced to the posteromedial capsule. It also, if you feel you're not happy with the repair, you can always add a similar suture on the superior aspect as well. You can visualize this application through the into the posteromedial aspect, and once you compress, you get a good adequate repair. So you can visualize, and you can see that the meniscus ramp lesions nicely reduced and repaired. It's important to apply the compression force in full extension of the knee. So another similar case where there was a type 5 tear, where there was a white zone tear as well, which was debrided, following which the tear, which was chronic, was freshened and was repaired in a similar manner by 2 all-inside sutures. You can see that we get good compression with an all-inside repair itself for ramp lesions. Moving on to my last case. So any complex tears what we have, once you do the excision of the white zone tears, you end up with a horizontal tear like this. So the normal convention is to remove the loose flap, which are superior or inferior one, which almost amounts to a subtotal meniscectomy. But we can always go and freshen this meniscus leaves, and you can repair them with vertical mattress sutures. The advantage of the all inside is, like I said before, we can control the compression what we get. As you can see, when you tighten that, you can get nice compression between the 2 leaflets, and we can apply as many sutures as we want. So as you come towards the body, you can switch out an inside out suture method. So at least 2 to 3 sutures are applied to get adequate compression for us, so that once you freshen it and get an adequate repair, they go on to heal very well, so that we retain as much as meniscus as possible. So in conclusion, we should all remember the R factor. Resist attempt to remove. So we should always try to conserve the meniscus, repair the meniscus whenever possible, and whichever possible method you do. Most of the cases I do is a hybrid technique, where you repair all inside for the posterior horn, followed by inside out or outside in technique. And you have to always achieve a robust repair. So we always neglect to put sutures in the undersurface, which is very important, and following which the rehabilitation is very important to get good optimal outcome. Thank you.
So it is any question?
Nice talk, Ashok. So for ramp lesion, do you routinely go for, in diagnostic round, you routinely go over the posteromedial portal and see whether the ramp lesion is there or not?
Like I showed in this video. Like I showed in this video, once you do a probing, when you probe the undersurface, you can see that the mobility of the meniscus is slightly more. So once you get a mobility of the meniscus slightly more, then you should alert that you should look for a ramp lesion. Invariably, in any chronic ACL tears, I always go into the posteromedial aspect and see if there is a tear. If I feel by probe it's there, but I'm not able to see there, then I make a posteromedial portal to probe it further. But most of the time, we can always see that.
And when do you decide whether you will repair this ramp or you will treat it conservatively?
If I see the ramp, I try to repair it, sir. Because your ACL healing and overall knee stability depends upon the ramp lesion. So there is a nice paper by Soneri Quartet who has shown that people who have not underwent ramp lesion repair have high failure of ACL. So for the knee stability, the ramp lesion or the posteromedial capsular stability is very important.
So next speaker, thank you. Next speaker, Dr. Gurudev. PLC injuries. Yes, nice topic.
So good afternoon, everybody. Before my talk, we have already observed the ACL, PCL, and now come to the posterolateral corner injury, which is very much important. Initially, once upon a time, it is known as a darkest side of the knee because of its poor understanding of its structure, biomechanics, and its treatment option. Usually, post-PLC injury isolated only in the 28 to 30% of the cases. Rest of the cases, it is associated with ACL or PCL or multi-ligament knee injury. Independently, if it leaves it as such, it very difficult to heal, and it may jeopardize the healing potential of the reconstructed ACL or PCL, and there is ultimately graft failure and tibiofemoral arthrosis development. So, the patient is lying supine on the operating table, make the point over the girdle tubercle fibular head and the lateral femoral condyle, make the girdle hockey stick incision over the lateral aspect of the thigh, extending from the IT band proximally and distally between the girdle tubercle and the fibular head, and develop the vascularized flap, posterior vascularized flap, then isolate the common peroneal nerve, and hold it with a Penrose, then develop the then develop isolate the common peroneal nerve, then hold it with a Penrose drain, then make the finger decision over the back of the fibular head, then pass the guide wire from anterolateral to posteromedial direction, then drill it according to the size of the graft, then pass the loop wire as a suture shuttle, then make the pass the guide wire over the tibia lateral and distal to the girdle tubercle, and the exit of the guide wire behind the knee joint is 1 centimeter proximal and medial to the exit point of the fibula. Then identify the IT band, then pass the guide wire for the fibular collateral, then pass the another guide wire parallel to the first guide wire, which is 18.5 millimeter anterior from the FCL, then drill it according to the size of the graft, approximately 20 to 25 millimeter in depth, then fix the graft over the femoral condyle with the interferential screw, then pass this FCL underneath the IT band, and then from the anterolateral to posteromedial direction, and then retrieve the popliteus through the popliteus hiatus and underneath this FCL, then finally ultimately retrieve both the FCL and the popliteus through the tibial tunnel, put the guide wire, give the proper tensioning over the graft and fix with the interferential screw. Then the wound is closed over the Romback drain and closed in layers, and put the hinge knee brace and follow the usual protocol of the rehabilitation for PLC. Thank you.
Nice demonstration. So one question is, do you fix the fibular tunnel with screw?
Initially I try to fix it, but nowadays we are not getting 6 mm screw, so we are not fixing this.
Yes.
Any tips for exploring the common peroneal nerve?
initially for the beginner it little bit difficult, but nowadays it is not very difficult. You have to identify the long head of the biceps. It is the common peroneal nerve is directly located posterior and medial to the biceps femoris tendon. Long head of biceps.
One question. How do you, what are your tips and tricks to put a tibial tunnel? So how do you identify, and what are the tips and tricks to avoid any vascular injury?
No, we have first dissect the posterior aspect of the knee joint with the finger between the soleus and the lateral head of the gastrocnemius, and to see the musculotendinous junction of the popliteus. Our entry point of the guide wire is medial to the Gerdy tubercle, and the exit point of the guide wire is 1 centimeter proximal and 1 centimeter medial to the exit point of for the FCL through the pubular head. And then we pass the guide wire in this direction and then drill it according to the size of the graft. It's very easy once you identify the structure.
You can put a small spoon underneath and
yes,
protect the posterior.
Put the finger.
Put the finger.
Yes.
Put the finger, but when you are reaming, that will be a little difficult. It will hurt you. And
yes.
And your assistant should be known about the other complications. So sometimes if you are drilling.
Yeah. Thank you.
Okay. So next lecture by Dr. Rohit Lal. The peroneus longus graft harvesting video technique.
Another question, Doctor. Gurdev Kumar. One question. You are fixing at 30 degrees of flexion or 60 degrees? So popliteus need to be fixed in different, and LCL has to be need to fix in a different position or degrees. So
we fix it in 60 degrees.
60 degrees.
Yes.
Okay.
So, good evening, everyone, and thank you for giving me an opportunity to speak in this august presence. So, my presentation today is peroneus longus graft technique. So, a properties of a good graft is it should be reproducible. There should be no graft site morbidity. There should be a good tensile strength of the graft. It should be easily harvested and should have a good biological incorporation. So peroneus longus grafts still they are not done as primary ACLs, but it can be considered as a primary ACL in non-athletes, in obese patients, and of course in multi-ligament injuries as well as ACL, PCL injuries. It's a very promising graft. There is no complications. There are no complications, easy to harvest. So this is my first video. So coming to the technique of peroneus longus harvest, we should always see the tip of lateral malleolus and 2 finger breadths proximal to and 1 finger breadth behind the lateral malleolus, mark a point. And it is very important to identify the 2 tendons. So the two tendons here which you will get are peroneus longus and peroneus brevis. Now that's the first tendon which you encounter, and this is the peroneus longus. It has a long tendinous structure. There are no muscle fibers attached to it. So this is and it is very easy to identify. Whereas in peroneus brevis, there will be muscular fibers attached to it. Yeah. So that's the peroneus longus tendon, which can be easily identified. That's the first tendon which you encounter here. Now that's another video. So that's how we try to put a very minimal incision, so that very near to this tendon is the sural nerve. So the idea is, if you are very close to the lateral malleolus, you may damage the sural nerve. So it is very important to be proximal, about 3 centimeters to 4 centimeters proximal to the peroneus longus. The distance between peroneus longus tendon and the sural nerve is highest, and there are very less chances of you to get the sural nerve entangled or damaged with your tendon stripper. So this is how we do. We take a few bites so that we don't lose the peroneus longus tendon. And once we secure it so that we don't lose it, and earlier literature used to tell us that we should suture the distal stump of peroneus longus back to peroneus brevis, but recent literatures, they are not very supportive of it. So I just leave the distal stump as it is and harvest the peroneus longus graft, and then I pass an ethibond loop. So it's a very easy graft. A lot of times in obese patients also I use this graft for my primary ACL who are non-athletes, as well as for multi-ligaments, ACL, PCL, when I have to do both together. I'm using this. And the other thing, and the other important point in the technique is your tendon stripper should not go up to the fibular head. It should be at least 4 centimeters. So I'm keeping my hand there. I'm keeping my hand there so that I know where my tendon stripper is actually knocking off the tendon. So this is the graft which you get, a very nice graft. So the advantage, and there are a lot of papers which are supportive of PLT graft because it does not cause secondary injury to the knee and its adjacent structure. The anatomy of the knee is not disturbed because of this graft. So that is another picture. And you can see you get a graft of about 26 centimeters, and almost if you double it, you get it about 8 mm thickness with 12 to 13 centimeter of graft. So these are the two important points in the technique. So this is the small incision with which we are able to take the tendon. So I'm very careful. I usually ask the patients to demonstrate their strength in the ankle and after the surgery. So that's another patient of mine who underwent an ACL reconstruction. There's no pivot. Anterior draw is good. So another patient who underwent a primary ACL. Actually, I practice in Jharkhand, and I go to a remote place to do my ACL surgeries also. So a lot of times non-athletes patients because it's an easier graft, I do my primary ACLs also in a few patients. So there's absolutely no morbidity. What I wanted to say, even if you go for an ACL primary ACL reconstruction with a peroneus longus graft, there's no morbidity as such in these patients. So another patient with underwent ACL reconstruction, good ankle movements and able to squat. The same patient. So another patient. So I reviewed a bit of literature also. So this is one paper which was from one of the European journals. So they concluded that peroneus longus tendon is a promising graft in ACL reconstruction. It is considered the first option graft in ACL and it demonstrated absence of significant post-operative morbidity regarding biomechanical inconveniency to the ankle donor site. Nevertheless, further research comparing the grafts is important. So this is the diagram which shows how close the sural nerve is, and if you damage the sural nerve, there's sometimes an atrophic scar at the graft site. So it's a promising graft. Again, taken from one of the papers, AOFA's Heinz foot score. It was not 100, but it was 98 plus minus 3, and which are considered to be excellent results following the graft. So it's potentially a good graft for revision, multi-ligament, obese patients, and maybe you can do it for non-athletes and for primary ACL. Thank you.
Are there any long-term complications with the peroneus harvesting? Amit Joshi sir, you can also involve in this. Any long-term ankle instability or anything is there with the peroneus longus?
You see, we've been using it for three plus years, peroneus longus, especially in female. It is not my primary graft in male, especially in female, low demand female. Around 70 patient odd in follow-up, and their ankle foot scores are good. There is no flattening of the foot. The eversion power regains after about 6-7 months. And there are paper coming up which says that like hamstring which regenerates after the harvest, the peroneus also has potential to regenerate, so they tend to regenerate.
Thank you.
Is it safe to take in the dancers?
You see, literature theoretically saying you are absolutely right. Literature also do not suggest, especially the ballet dancer, those dancers who require eversion and the inversion foot. Theoretically, but practically what is coming is it's not only the peroneus which is responsible for eversion of the foot. There are so many other, you are preserving the peroneus brevis. There are so many other that will be recruited once you take out the peroneus. So in due course of time, probably yes. But I agree, it should not be the first choice at this moment. The literature not enough to say that for this group of patient also you can use a peroneus. But I think over a period of time, the threshold to harvest the peroneus has gone down. More and more people are using it. Thank you, Jaya.
I completely agree. Just one point to add on. I think what I do when I take peroneus is the distal part of the peroneus longus. I tenodece to the peroneus brevis. I don't know what is that is one thing that is emphasized in the papers.
Yeah, that's actually we were doing that, but Samantha sir is here. Samantha sir told me not to do it. Okay, thank you.
Thank you.
Just actually what happens if you tenodece to the peroneus brevis, it forms a bump. And if you know that there is a retinaculum down there, so when you evert, usually when you evert, it tends to go down and impinge into the retinaculum, and this causes pain to the patient and loss of eversion. So now literature are there which says that you do not need to tie it to the peroneus brevis. But there are a lot of people who are doing that with good result as well.
In pediatric cases, sir, if they are taking peroneus longus, they will tie the distal part to the...
True, I understand, yeah.
And another thing is fascia closure is very important. Under the just our skin incision, the muscle is there. So if you are not closing properly, it will bulge out. They will get a lot of pain.
Especially in the very thin patients, we make a small slit in the brevis and we put the peroneus longus into that and take stitches with just Vicryl so that there's no formation of bump. And as you said, I think, sir, closure is very important, otherwise it leads to pain.
Closure, meticulous closure.
And we also say that the synovium has to be kept intact, and studies have shown regeneration of the longus if the synovium is kept intact before you harvest the tendon.
Yes.
Yes, thank you. Thank you, Dr. Rohit. So our next speaker is Dr. Vivek. He'll be talking about pediatric patellar dislocation.
Hello and namaste. I am Dr. Vivek Basukala. I come from Nepal. I work at AKB Center for Arthroscopy, Sports Injury and Regenerative Medicine in the premises of B&B Hospital. Today I will be talking about pediatric patellar dislocation. So at the very outset, let me thank Saarc. The banners outside were very interesting. Chance made us friends, then chance made us fellows, and country made us neighbors. So it is exactly true. Actually, we all Saarc people are brother from another mother, and the Kolkata Arthroscopy Society has played a good role in getting all these brothers together. Thank you so much. So let us start. Patellar tracking, as we all know, starts with 30 degree of knee flexion. At 30 degree of knee flexion, patella goes and sits in the trochlear sulcus. And from there onwards, patella is tracked, patella is guided by the trochlea. So well-formed trochlea along with the well-formed patella is a key for good patellar tracking. This is the way where patella will track. So when the patella dislocates, there are multiple causes why it dislocates. The causes may be extrinsic, like rotatory instability of femur or tibia. There may be a genu valgum causes, which also causes patellar dislocation. The cause may be at the feet. There may be plain foot or placed planus deformity, which may lead to the patellar dislocation. There may be intrinsic causes like patella alta, grossly dysplastic trochlea, again under trochlear dysplasia, the non-functioning MPFL, and tight lateral structures along with the non-functioning MPFL. So intrinsic, it is usually the interplay or good mixture of these extrinsic and intrinsic factors that will lead to the patellar dislocation. So why patellar dislocation is so serious in pediatric population, and why we need to reduce them, and why the good tracking is essential. This is because just as a mold of a sculpture, what happens is this particular trochlea of the femur, it is molded with the good well-formed patella or well-tracked patella. If patella is tracking, just like in DDS, if patella is tracking well, the trochlea will develop well. Otherwise, trochlea will be not develop well, and that is called trochlear dysplasia. This has been proven with the literature, because the patellar instability, cases of patellar instability, the anatomical radiographic study was done, and almost about 96% of cases had some form of trochlear dysplasia. So I think this is the this guides us that the patellar dislocation has to be managed as soon as possible. So let us classify patellar instability in children and adolescents: acute, recurrent, habitual, and dislocated. Acute is the first time dislocation, and this can be with osteochondral defect or without osteochondral defect. Recurrent means subluxation or dislocation. Habitual is very interesting thing. Every time patient flexes or extends, the patella dislocates. Dislocated means patella is dislocated, but it is reducible or irreducible. So these two particular instances we will be discussing here because they are common one. Acute dislocation means first time dislocation is usually traumatic. Patient has twisting injury. What happens is the MPFL is torn and the patella is pulled by lateral structures. There will be abrupt push over this particular structure, and there may be the osteochondral fracture. So if in the first time dislocated there is osteochondral fracture, these are cases for surgical intervention. Otherwise, first time dislocators can be managed conservative. Then let us discuss about habitual dislocation. Habitual dislocation can be in flexion, and usually these people have the scarred lateral structures. Tight lateral structures are Saarc. In extension, it is a worrisome condition. Patella alta and trochlear dysplasia are the condition which will lead to habitual dislocation in extension. So I present you a case, habitual dislocation of patella in pediatric population in flexion. What we do, we have been trying many techniques, but what we currently do is a la carte approach 4-in-1 procedure, and this is what we do. This is the animation of what we do. The tight lateral structures, lateral structures is elongated, only the superficial layer is cut, then the deep layer is cut at the level of medial epicondyle at the femoral attachment. Then it is lengthened, and the redundant elongated medial structures is taken over the patella and it is fixed. Then this is another technique which we will add, and this is Rugolvid procedure where the vector is arranged. So this is the animation, and this is the clinical demonstration of the same technique. This is the clinical picture of the patient. Every time we flex, the patella is dislocated as shown here, and as we try to relocate it, it is very difficult, which shows that the lateral structures are very, very tight. So this is the surface marking. The patella is grossly dislocated laterally as we flex. Central midline incision is given, subcutaneous plane is made, and now I'm extremely sorry, this is lateral lengthening. The superficial layer, the lateral layer is cut in 2 equal parts. As we divide the lateral structure into superficial and deep part, we will get some sense that patella is relocating. So that is a good thing. So as we go on, we make this into 2 particular layer. Deep layer is cut and the lengthening is done, and then the Rugolvid procedure is done. The patellar tendon is cut into half, the lateral half is taken underneath the medial half, and it is sutured over the periosteum over there. The medial side is transected completely as shown in the figure. The trochlea is always dysplastic, some dysplasia is always there. Then Rugolvid procedure is completed, it is sutured with periosteum, and we deal the whole of the medial structures which had been released is sutured with the superficial layer of the lateral retinaculum. So tube quadricepsplasty is done along with. So finally what we do is, this is the process being done. The patella is very much stable now. Now the lateral lengthening is completed. The deep layer of the medial half and superficial layer of lateral half is sutured. This much of length is gained with the lateral lengthening, and the final step is addition of MPFL. Superficial quartz is harvested. Superficial quartz, the new second layer is made. The tendon is passed through this tunnel. The adductor magnus tendon is exposed as shown here, and it is sutured over adductor magnus tendon, sutured around the adductor magnus tendon, and the incision is closed. So this is how we close it. So this is the post-op stability. You can see the difference. The patella was dislocated every time the knee was flexed, and this is the stability. Thank you so much. I welcome you all in second Saarc Sportsmedcon. It will be in Pokhara, the Shangri-La, and it is full of some adventure sports as well. I welcome you all to Nepal. Thank you so much.
Okay, thank you. Thank you so much. Next speaker, Abhijit. Please start.
This is fine.
Good afternoon, everyone. Many times than when we harvest semitendinosus and gracilis graft for ACL and PCL reconstruction, we face this scenario. We, after preparing the graft, we find that the graft thickness is around 7 mm, so which is very insufficient. at this situation, we start thinking whether we should plan a graft which is more customizable and more predictable. So here lies the solution, which is superficial quadriceps graft. So superficial quadriceps graft is a versatile graft for ACL or PCL reconstruction. It has 3 layers. The superficial most layer is formed by the rectus femoris. The medial layer is formed by the vastus medialis and vastus lateralis in its distal 6 centimeter, and the deepest layer is formed by the vastus intermedius. Here in this clinical picture, we can see that vastus medialis is pretty muscular and vastus lateralis is a bit tendinous. So when we harvest the superficial quadriceps graft, we take the graft from the lateral half of the tendon. So what are the advantages of quadriceps tendon graft? Number 1, the superior graft quality. It has been seen that it has 20% higher collagen content and higher fibril interstitial ratio and higher fibroblast density compared to the same size of the BPTB graft. Here is the paper which is published in Arthroscopy Journal in 2016, which says that compared to the patellar tendon, 10 mm quadriceps graft strip has higher cross-sectional area, higher ultimate load to failure, and higher stiffness. There are other advantages of superficial quadriceps graft. These are: there is decreased chance of injury to the neurovascular structures, there is no flexion weakness at all, there is very minimal or no anterior knee pain, and customization of the graft size is possible. There is reduced incidence of arthrofibrosis, and there is better patellar mobility. Conventionally, quadriceps graft has been harvested with a open technique, which produces a ugly scar and also delays the rehabilitation process. Here we demonstrate a new technique which is very simple and innovative of harvesting superficial quadriceps graft, which does not require any specialized instrument. So the L mark denotes the vastus lateralis and the M denotes vastus medialis. Here a 2.5 centimeter vertical skin marking is put at the junction of the lateral 1/3 and medial 2/3 of the upper pole of patella. Now the skin incision is made over the above marking. After dissecting the subcutaneous fat, then with the help of a number 11 surgical blade, we incise the peritoneum. Then we, with the help of a Mayow's dissecting scissor, we dissect the peritoneum. We take 8 mm of the graft width, which is measured with the help of a 8-inch right angle artery forceps, which is roughly 8 mm, or we can use a scale also for this. The first incision is made over the midline with the help of a number 11 blade, and the second incision is made 8 mm lateral to the first one. The depth of the graft is decided with a 6-inch right angle artery forceps, the tip of which is roughly 5 mm. Here we can see the 8 mm of the width of the graft is taken. Now the distal end of the graft is detached from the patella, upper pole of the patella, sharply with the help of a knife. The distal end is looped. Now we secure the distal end with whip stitch with the help of orthocord. 2 to 3 centimeter of the superficial tendon is elevated from the deep one with the help of a scissor. Here we can clearly see a fatty layer in between the superficial and deep layer, which confirms that we are at the right plane. Now, a closed tendon stripper is introduced. And we push the closed tendon stripper. While pushing the tendon stripper, we should keep the knee at 30 degree of flexion so that quadriceps tendon get relaxed. And this long graft is harvested. Here we can see we have harvested more than 30 centimeter of the graft. Now the donor side defect is repaired with 20 Vicryl. The peritoneum is repaired. You can see the wound size is 2.5 centimeter. By doubling the graft, a 9 mm thickness graft is prepared. Here are 3 clinical pictures which is taken from the cadavers. We have harvested superficial quadriceps graft in cadaver. The first picture is of the soft tissue tunnel. Then we opened up the soft tissue tunnel to see whether there is any damage to the deep part of the quadriceps tendon, and it has been seen that there is no damage to the deep tendon and only superficial part of the graft is harvested. There is nothing in the world without drawbacks, so it has also some disadvantages. If the thickness of the quadriceps tendon 3 centimeter above the upper pole of the patella in mid-sagittal MR is less than 7 mm, then it's not preferred to take quadriceps tendon graft. And this procedure is better to avoid if already BPTB graft has been harvested from the same limb. Thank you.
Excellent presentation, Dr. Abhijit. So, any question? I think there should not be any question.
What is the usual length you get on this?
Sir, it's around 30 centimeter.
And mainly you use this for PCL, ACL, or you can use for both ACL or PCL? Both?
Sir, for both we can use.
Okay. But for ACL, if you do it a quadruple graft, threefold?
Threefold.
Okay, then threefold makes sense.
Okay. Yeah, please.
Just
Thank you.
one last question.
Yeah,
Very interesting.
sure. Yes.
So between the superficial and deep layers, you always manage to find that fat layer, and you are always confident that you are not going through the deep, right?
Yes, sir. Yes, sir.
Any tips for that to make sure that it doesn't go wrong?
Sir, while we dissect, when we first detach the distal segment and elevate it, then we check whether the fatty layer is there or not. If fatty layer is not there, then we go further deep. So once we get that fatty layer, then we take the whip stitch and proceed further.
And approximately how much depth you have to go to get the fatty layer?
Sir, approximately 5 mm.
So the graft is effectively 5 mm thick and 8 mm wide.
Yes, sir. The width part of the graft is customizable. We can take 8 mm or 10 mm. This part we can customize, but.
So this is my position. Now coming directly to the visual presentation, my case was 25-year-old person with mid-substance ACL tear. So after doing the initial roundup, we go into the intracoronal notch area and see that the ACL is completely torn, and so we start debribing this with the help of saver. And after initial debridement, we probe to see if some fibers of the intercostal ligament is attached to the femoral attachment. Here we can see that there are only few fibers, so we remove the remaining part of the intercostal ligament from the femoral side. Here I want to say something. I usually use the, I think you have seen, I am not using the saver. I usually use the punch to remove the posterior part initially, and after that I use the saver. This is usually helpful to prevent injury to the posterior cruciate ligament, which is lying. This is the posterior cruciate ligament. I think you can see the posterior cruciate ligament nicely. I am using the accessory anterior portal to do the ACL reconstruction. The site of the portal is around 2 cm medial to the medial border of the patellar tendon and just above the middle meniscus. It should be able to reach the femoral attachment site. Normally for identifying the site for femoral attachment, I use the zig, but in this case the anterior and posterior border of the femoral footprint was clearly visible, so I used a owl to create the impression. Okay. Then we use the bead pin. Then we are using a bead pin. Initial part I hammer it. Then I will place the limb in 130 degree of flexion and introduce the bead pin. Once this is done, then I will drill the femoral tunnel with 4.5 mm drill bit. This is the 4.5 mm drill bit. Intermittently we should clear the joints so that we can clearly see the amount of drilling that we have done. Throughout the procedure we should remember that the position of the limb should be around 130 degree of flexion. Now we can see that around 20 mm of drilling has been done. Now 25 mm drilling has been done. Gradually continue the drilling till we will feel there is sudden loss of resistance, which indicates that the lateral cortex of the femur has been drilled. After this we measure the depth of the tunnel, and after that depending on the size of the graft we drill the femoral tunnel. Here we use the flower tip drill bit so as to prevent injury to the posterior cruciate ligament. This is the posterior cruciate ligament. You can see just posterior to the drill bit. So the drilling is continued. The position of the limb is again 130 degree of flexion. We intermittently clean the joint to see how much of drilling has been done. We can see that around 18 mm of drilling has been done till now. We will continue drilling till around 20 mm of the tunnel is achieved. Then we remove the drill and introduce the looped fiber wire with the help of the bead pin. We can see the tunnel inside tunnel, and the lateral cortex is intact. After this we will drill the tibial tunnel. In this case we can see that the femoral tibial footprint is clearly seen, so there is no problem identifying a spot. But in chronic cases where the femoral footprint is, the anterior horn of the lateral meniscus acts as a guide. The zig should be placed just posterior to the anterior horn of the lateral meniscus. Then we drill the guide wire. We can see it's coming. Yeah, it's coming here. At this point, the position of the limb is 90 degree of flexion. No hyperflexion is necessary. As the guide wire was not clearly visible, we drill it inside. I think you can see the guide wire. It's in the center of the footprint. While drilling the tibial tunnel, we should remember that we should hold the guide wires with the help of I usually use a coccus forceps, but curette can also be used for this purpose. The position of the limb again is 90 degree of flexion, no hyperflexion is needed. After drilling the tibial tunnel, we retrieve the looped thread from the tibial tunnel. Now coming to the last part, delivery of the graft inside the joint. I usually use an adjustable loop. So this video shows the loop is going in. Now the button is going in. Is going in. The button is going in. There are two markings that are very important while using the adjustable loop. This is the first marking that you can see. This is equal to the length of the femoral tunnel, and the next marking will be 15 millimeter from it. So we pull it further. So I think you can see the second marking going into the joint. Then we pull it ACL graft, and you can see that the second marking is coming inside the joint. Okay, this indicates that the loop has flipped in the femoral side. So after this, we will shorten the loop. I think you can see the graft is coming inside. This is the graft. I usually mark the length of the tunnel with the help of a vicryl. So this is 20 mm. Some amount of shortening will be needed. So it's going in. Yeah, that's 20 mm inside the femoral tunnel. After this, we fix the tibial tunnel with interference screw, and after that, the last part we see for notching. You can see on complete extension there was no notching. Thank you. Thank you very much.
Okay, any question? So there is one question. So if you debride all the ACL stumps both in femoral and tibial side, or keep some, so what is
actually we keep some, but this was for demonstration purpose, so I remove some more amount for only demonstration purpose. Yeah.
Yes. There should be some for healing, better healing.
Yeah.
Okay, thank you.
Now last session of this conference, the master technique, shoulder technique. I would like to invite Dr. Ayappan. Dr. Pratap Kumar is not there. Then Dr. Sanjay Kumar to chair this session, please.
We'll start the session calling in Dr. Purna Chandra for pan label repair in shoulder instability.
Good afternoon. I thank Rajiv sir and all the organizers for giving me this opportunity. I work at Yashoda Hospitals, Hyderabad. My special interest is in hip arthroscopy and shoulder arthroscopy. So I have nothing to disclose regarding this talk. I'll be presenting on pan-labral repairs or the pan-labral disease of the shoulder. So various papers say that the overall incidence of pan-labral tears is around 2.4%. How does it occur? Normally, the entire labrum does not tear in a single instance. Most of the times it is secondary to anterior dislocation. 65% of these lead to panlabral tears if neglected and if there are multiple dislocations. And 20% is secondary to posterior dislocation, the rest 15% being idiopathic. So when do we suspect a panlabral tear? There is no gold standard test or a single sign or exam that we can easily diagnose with. We should have a suspicion in mind if the patient has history of multiple dislocations, significant shoulder pain in between two traumatic dislocations in a case of recurrent dislocation patients. As you all know, most of the time the pain subsides after an episode of dislocation, but if the patient continues to complain of pain in between these episodes, a panlabral tear should be suspected. On examination, most of the provocative tests for labrum are positive. Also, we should have a high suspicion if we are dealing with an extremely active patient. MRI alone does not always detect the panlabral lesions. Of course, MRI arthrogram would be a very, very useful adjunctive, but we do not get it very usually. So what we need to do is, it is always better to always suspect that there would be a panlabral lesion in a recurrent dislocation patient, and we should be ready for the same. So I do this in lateral position, standard 3 portals, the posterolateral, anterosuperior and anteroinferior. I mobilize we usually use the opposite shoulder, opposite joint approach in this case, and first identify the extent of the tear, liberate the tear all around, and then go ahead with repair. Sequence of repair: first I always place the posterior-inferior anchor. I always use percutaneous placement of anchors for me to give a better angle, and take bites through the inferior labrum, then inferior to superior repair of the posterior labrum, followed by inferior to superior repair of the anterior labrum and capsular shift if required, and lastly the superior labrum if present. So how do I do this? So this is the right shoulder. I use the 3-point traction system from one of the companies. I follow Stephen Snyder's diagnostic principles. This is viewing from the posterior portal. You can see anterior and the posterior labral tear here. This is the bare area. This is the PIGHL. This is the intact rotator cuff by the biceps. Then the rotator interval. Then after this, I establish the portals. First the antero-inferior portal through the rotator interval. Especially in cases of these, when I suspect a panlabral lesions, I tend to use these semi-flexible cannulas, which are called as dry dock cannulas from ConMed, because these helps me with more maneuverability in the shoulder than the stiff cannulas, followed by the antero superior portal. This is a clear cannula that I use. This is my primary viewing portal later, where I shift my scope here, and this is the establishment of the posterior portal. I always confirm the position of the posterior portal before I insert the cannula in. Then this is me viewing from the antero superior portal, giving me a bird's eye view. Then I get my liberator from the antero inferior portal and release the posterior labrum first, and then the antero inferior labrum. And after I release this, I should be able to pass my liberator all the way, or the shaver all the way from the anterior, inferior to the posterior. That's when I am very satisfied with my liberation. This is me freshening the edges of the glenoid for the subsequent repair. And then I sometimes use electrocautery in chronic patients just for me to see the muscle down. As I said, I always use percutaneous placement of anchors for me to give better angle. I use multiple percutaneous holes for the same. I tend to use all suture anchors. This is the 1.8 Q-fix anchor. And then shuttle. This is the usual steps. Shuttling the suture to the front. So as I said, the opposite shoulder approach. This is the left shoulder I am using, sorry, this is the right shoulder. I am using the left curved device here. So this is my first anchor and the first bite. Then I decide on subsequent, it is important for me to decide on subsequent placement of anchors for equal spacing and to have a good robust repair. This is a straight crescent shaped device. So it's always good to have different suture passing devices in your armamentarium, because to have a good repair, it's always, we struggle with fixed devices. I have left, right and straight curved crescents always. This is my second anchor. And now, as I said, I finished the posterior. Now this is the antero-inferior anchor going in at around 630-ish position. I always use the grasper from my posterior portal to lift off the labrum, and so that I get a real robust bite, including the capsulolabral complex. So this is just a subsequent anchor. So this is the last anchor going in. So I have used 2 anchors posteriorly and 3 anchors in the anteriorly. So you can see the bird's eye view, nicely balanced shoulder. This is how I do my panlabral repairs. Rehab for this, normally I keep the patient in a shoulder abduction brace in neutral rotation for 4 to 6 weeks. Only the pendulums are started for the first 2 weeks. And scapular plane abduction is allowed from 2 to 6 weeks. Normally I only start active assisted from 6 weeks and gradually increase to get full ROM till 3 months time. Once the patient gets full ROM, only then my patient goes on to strengthening, that is at around 12 weeks time. Normally patients return to unrestricted activities in 6 to 9 months. However, for bowlers or throwers, it is better to avoid till 12 months of time. Thank you.
Great talk. Just one question. Like you said, it is you're doing a panlabral, and in panlabral you could be having an anterior-based instability or a posterior-based instability. So when you're doing it, how do you decide which to tension more? Is there a difference in tensioning anteriorly and posteriorly, or you do a regular tensioning all around?
No, the way I look at with its anterior placed instability is when I do this thing in lateral position. If the shoulder seems, if the head seems balanced off the anterior edge of the glenoid, then that is where I tend to tension the antero-inferior first. And most of the posteriors, I don't think there is actual subluxation of the shoulder, but this is what I look at when I put my scope into the antero-superior portal. I see if the shoulder is balanced or not, and if it is falling off anteriorly, then I tend to balance the AIGHL first.
Absolutely, that's a great technique to do. Yeah. Any questions? No. Thank you so much.
Thanks.
The next would be Jay Prasad, sir. Sorry. So sorry. Amit Joshi, sir. Arthroscopic bank repair.
I would love to sit back and listen to all the great talks. Thank you very much, Team Kolkata. And then probably we are coming to the last session of a very great 2 days. So the responsibility for me is to talk about a very simple procedure which is known as the Bankart procedure. So we all know that labrum is a primary stabilizer, and then it has various functions. So the importance of labrum need not to be elaborated. What happens in the anterior dislocation is there is a tear of the labrum, which we know as a Bankart lesion. If you go to literature that say that the Bankart lesion, in most of the time they are limited between 2 o'clock to 6 o'clock. So the focus of our attack for repair should be between this 2 o'clock to 6 o'clock position. So Bankart repair seems very simple if you know that we are just stitching back the the labrum, but it becomes a little bit complicated and understandable when you understand that it is not only just a repair of the tear, but it has to have a component of capsular shift. And usually what we do is we shift the 6 o'clock capsule, the IGHL, to the 5 o'clock. That is the basic principle of doing a Bankart repair. How we do it? So you put into the 5 o'clock anchor into the 5 o'clock position, then you take a bite at 6 o'clock, so anchor at 5 and bite at 6. So this brings your 6 o'clock position to the 5 o'clock position by doing a capsular shift as well. So how normally we all do is we put our lasso from the antero-inferior portal by putting your scope either in the posterior or antero-superior. By doing this, attacking at the 6 o'clock position is little difficult. So either you need to put a retraction suture or you put a grabber into the labrum so that you pull and you go down. What I do personally is I do a reverse attack on the 6 o'clock. So I put my scope into the anterosuperior and go from the back side. So if you go from the, insert your lasso from the posterior side, attacking at the 6 o'clock become very, very easy and become very simple. That is the technique I commonly use. I'll briefly go into the 4-minute video of a Bankart repair. You can see that this is, I think, 7-time dislocation of a 20-year-old gentleman. Most of the time I find that attrition injury of the labral lip. So this is the standard procedure. You elevate, which is one of the most critical step of a Bankart repair. Adequate elevation for a capsular shift is a must. What I usually do is I take a acutely curved and I extend the tear about half or 1 degree. So if it is up to 5.5, then I extend and make it up to 6.5. In this case, you see that the tear was up to 5, so I've extended it up to the 6 o'clock. So of late, this is my favorite technique. What I found that most of the time there is an attrition injury of the cartilage. So there is no point keeping this cartilage, and we all know that soft tissue doesn't heal to the cartilage. So what I do is I denude the cartilage. I take my ring curate so that I make this cartilage, make the face of the labrum bleeding. Second is to attack onto the wall of the labrum, wall of the glenoid. The standard procedure, I use various instruments to do that. Make sure that the wall also should be bleeding. Then what I do, my scope is in anterosuperior, and then I put a cannula, and then through that anteroinferior portal I put the first anchor. This is usually a double loaded nowadays. So see, this is the outside video. My scope is in anterosuperior. All the sutures are anteroinferior, and my lasso is going from the posterior. If you see that, attacking the 6 o'clock is such an easy job if you come from posterior. If you have to attack the same position from the anteroinferior, it becomes very, very difficult. Make sure that you do not take a deep bite because there is a axillary nerve. And you can see that anchor is at 5 and my first bite is at 6 o'clock, so that this shifts the whole capsule. Next thing is for an inferior one, we all know that the inferior one is the main culprit. I take a horizontal mattress on the inferior part. So my first bite was at, what happened to the video? Please. So by the time the video plays, my first bite is at 6 o'clock. 6 o'clock, and second bite is at 5.5 o'clock. So, okay, stop and then we'll come back again. Quit and we'll come back again, okay?
माउसটা ইয়ে হয়ে গেছে মাউসটা হ্যাং হয়ে গেছে এক মিনিট মাউসটা হ্যাং হয়ে গেছে
রিস্টার্ট রিস্টার্ট কি বলা Okay, so the basic difference of that I use to use a normal technique is I take a bite at first bite at 6 o'clock and the second horizontal mattress at 5 o'clock. So what it does actually is it gives a bursting effect. It gives a bursting effect into the inferior capsule, which is very, very important for the capsular shift and decreasing the volume of the axillary pouch. So so what I have done is I have taken first bite and second bite, and this is the horizontal matras. If you see how beautifully this pulls the 6 o'clock tissue into the 5 o'clock position, and it forms a very nice, bump, which is very, very important. So just to cut short, rest of the steps are as usual. Sometime I use a single loaded, sometime I use a double loaded. I'll not go into the details of this process. This is probably the final suture I have been applying, and once the final suture is applied, you can see that beautifully centralized head of the humerus, and then see the the bump that has been created by pulling the 6 o'clock into the 5 o'clock position. So this creates a very good bumper in the risk zone of recurrence of dislocation. So to summarize and conclude my presentation, a meticulous glenoid valve preparation is very, very important. Denuding the cartilage is very important so that you can shift have a more capsular shift. Having a bite at 6 o'clock and bringing it to 5 o'clock is a capsular shift. Plication with the matras suture, especially the most inferior one, is the key process in my technique. And then this creates a very good bump, and there are studies which is saying that size of the bump is very, correlate with the recurrence rate. Thank you very much. Thank you.
So, it's very nice talk, sir, and your animations are very good, very, very, very explicit, very nice. So, one question was, like, when is do you do any inferior plication? Is there any indication when is yours that now you've taken from 6 o'clock you have passed on? Do you take, and the bite is mostly coming from the 5:30, I saw that lasso coming in. Do you do inferior plication?
Yeah, my inferior plication at this moment, I'm doing putting a matras suture. If you put a matras suture, which is about, have a 1 centimeter gap, and when you tie it, this gap also closes. So kind of a purse-string effect comes into the inferior capsule. So purse-string effect and bringing it into the face by denuding some 3 to 4 millimeter of cartilage is the key step of my surgery.
Sir, another thing was, like, some surgeons would be doing from till 3 o'clock or till 2 o'clock. Do you take, what is your maximum upper limit of taking the sutures? Where do you stop? In some cases with maybe more hyperlaxity, do you go all the way up?
Yeah, my regular limitation is the the border of the subscap. So I limit my fixation or anchor placement right up to the subscap. But it depends. If you have a robust labrum, and the labrum tear is going right up to the base of the biceps, then I repair right up to there. So creating a bump up to 3, and if there is a labral tear, probably repairing the labral tear right up is the way.
Sure, sir. Great technique, sir. Any questions?
Thank you very much.
Yeah. Next would be Dr. Jayaprasad, Upalnataji.
So good evening everyone. First I would like to thank Dr. Rajiv Raman, Sunit Hazra for inviting me, and I would like to thank IAS and Saarc and CAS. So I am going to talk on opal lateral procedure. So this is, I think, third time repetition. So this surgery is pre-operative decision. This surgery is a pre-operative decision. You need to go through all clinical examination and X-rays, basic X-rays, and CT MRI is mandatory before going for your decision. So you need to sit with a CT and MRI with your radiologist and decide whether it is off-track, on-track lesion or any other injuries associated with injuries, because the recurrent dislocation, there will be a slap and rotator cuff tears will be there. Even though it is a partial tears, you need to address, and this is a pre-operative decision to go for your open lateral J or ortholateral J. So the simple steps, use of part of deltopectoral approach. Normally I take a small incision from the coracoid 1 centimeter above the coracoid towards the axilla, not the more oblique one, and so you can work towards the glenoid side. So identify the cephalic vein and the deltopectoral area you have to identify. Just it is half minutes approach. You need to identify the coracoid. Just to put your finger slide down so that you can have entire opening of the deltopectoral area. And then you need to find out the CL ligament. This is very useful for suturing. And then work down under the acromion. Take out the pec minor. And next step is the identifying the required length. You need to identify the tip of the coracoid with your K-wire or needle, because sometimes you may not estimate the tip where you are going to have, because you need to have at least 2 or 2.5 centimeter. Bigger one, you need to have a 2.5 centimeter. A smaller one, you need to go for 2 centimeter. That is very important. And protecting your the brachial flexus at the same time musculocutaneous nerve underneath this one. It is very near to the coracoid, coracobrachialis, around 2 to 5 centimeter down here. So when you are dissecting, it's very careful to take care of this entire neurovascular structures. And then you can use osteotome or the oscillating saw. So initially I used to do osteotome. Now you are going to oscillating saw. So first you can cauterize superior part and indent, and then use oscillating saw to take out the coracoid. Then once you did that one, this is a very important step. 2 important steps. One is preparation of the glenoid, another one is a preparation of the coracoid. You need to take out the fat under surface under this area, and then inferior part has to be made the bleeding surface, and it should be flat to abut on the glenoid. Then go for the this is a very important the instrument. So with this you can hold, you have to identify really if it is a central, anterior, posteriorly, mediolaterally. So before putting your KYs and drilling. So this is important thing till the end of your drilling and making holes. So once you have done that one, these offset guides are available. This is also very important thing. So need to put your offset guide inside, and you check the offset. How much is the offset? You need to have a 6 mm offset from the glenoid. So that you need to have here. Once you check, you know that how much is the offset. Really, it is 6 mm is medial. You are going to have this one on the glenoid, or you are going to have a lateral abutting on the outside on the lateral side. So then the next step is splitting the subscapularis, superior 2/3 and inferior 1/3. Put your gauze piece or bump under the subscapularis and find out the capsule. This is very important. This Gilpis retractor is very useful here. Once you split from the lateral to medial, so 1.5 centimeter you can cut with a cautery, and then you can release the artery blunt dissection. Then you put the Gilpis retractor and open the capsule. I open the capsule longitudinally because this is very useful to mobilize your lower capsule when you are suturing later. So you can put an anchor, you can mobilize towards east and north when you are closing the. So when you are going for the vertical incision, then it is very difficult to close towards the glenoid side. So this is another important step. So you need to have a flat to make entire fibrous tissue or malunited bone and other things, and it should be here, we have seen here. So this is making a lower, almost 1/4 of the glenoid, making it as flat to contour with our coracoid. Then so once you have done that one, and this is offset guide, you see that where your pilot holes are going. So it should be very parallel to your glenoid and medial. So I normally put this screws 1 centimeter in the coracoid, so not to have wobbling effect inside. So it gives a very useful before putting inside the glenoid. Once that is done, so once I put the graft inside after drilling on the glenoid, then this is the plate. So 5 years back I used to use these plates, and putting these plates and taking onto medial side on the bone is very important, because the projected metal will abrade the humeral head. So that is very important thing, and then you take the this metal plate towards the glenoid side, and then so both the screws, so you need to tighten simultaneously. So if you see here, it's little medialized bone and with the labrum, with the glenoid. So you can add with the anchors, and this is the closure, partial closure of the subscapularis, and so these are the post-op ROM. He had a bilateral lateral J procedure. He lifted heavy weights, and he had glenoid fracture both sides. He came after 1.5 years, and with multiple dislocations. So I did both sides lateral J, single sitting. These are the another patient post-op X-rays. So these two instrumentations are very important. One is a Gelpis retractor. You need to buy this Gelpis retractor with a blunt one. So when you are putting in the capsular area, should not penetrate the capsule and get the neurovascular structures to get damaged. So another one is the Fukuda retractor. This is another important. Even you are going for the knee replacement surgeries, you can have a bigger one. But here a smaller Fukuda retractor, and with a blunt one, you have to see here it should be blunt, and not to get damaged counterpart, other part of the posterior part of your glenoid. So this one is biotech screw. Nowadays I am using this screw, this flat end. So this is very useful to compress on the graft. So these are the post-op. So sling for 4 weeks, and begin passive and gentle active assisted ROM flexion for after 1 week, and active ROM after 5 weeks. Thank you so much.
Great talk, sir. The visualization was very good. The retractor placement, because your field was very clear. Not many people, it's very difficult to get that.
Yes.
But very meticulous. It was very, very nicely done.
So that two instruments are very important, because when you tell your assistant to retract capsule, he will tear out an entire thing, and even subscapularis also. So once you put a retractor with your assistant, both two assistants, you can't go in.
How frequently you are doing the surgery? How frequently?
Almost 1 in 2 months.
1 in 2 months.
Yeah.
Have you fractured any time, anyway, the coracoid?
Yeah, until 2019 I didn't fracture. Single case. I went this Kerala conference. So one of my senior, he's telling I had a complication, other thing. I didn't have any complication. I told. The next week I got a fracture, just a split, and luckily inferior screw was holding, and I put an anchor and hold with this inferior part of that the bone and the tendon junction. I put a 2 or 3 anchors and hold it.
Nice, nice.
So that is a one patient I got split of the coracoid. Thank you.
Okay, any question from the floor?
Next is by
Thank you.
Dr. Bibodinath, AC joint reconstruction.
Roshan Shah is here. Roshan Shah. Next.
ठीक है. So, respected dear sir, respected faculties, and my dear delegates, I am Bibhuti from Nepal, and it's again my pleasure to be here. I was as a student here for last 1 year, so I'm thankful to few of my teachers of life who are very precious to me and who taught me all about this arthroscopy and sports thing. So I couldn't start before thanking them all. And so talking about the AC joint, so AC joint is a diarthrodial link which is established by several ligaments: the coracoacromial ligament, the acromioclavicular ligament, and the coracoclavicular ligament. That includes the trapezoid and the conoid ligaments. So Rockwood in 1989 he came up with a classification, and till date we all are following it, that it has all the 6 gradings of dislocation. Grade 1, that includes only the AC joint ligament sprain. Grade 2, the tear of AC ligament. Grade 3, AC and CC ligaments both are torn and the displacement is less than 100%. Grade 4, in which the clavicle is displaced posterior to the acromion. Grade 5, the displacement more than 300%, and grade 6 is a rare in which the clavicle is underneath the coronoid. So looking at the management, there is no doubt that grade 1 and grade 2 are managed conservatively. For grade 3, there are still 2 schools of thought, few advocates for conservative management and other for the surgery. And grade 4, 5 and 6, no doubt, we recommend surgery. So looking at the grade 3, still there are few meta-analysis, they say that conservative management is still better. But when we look at the conservatively managed cases, still 20 to 40% of the patients who are managed conservatively had problems and unsatisfactory results like pain, decreased range of motion, paresthesia, and loss of strength. So these days, even for type 3 dislocations, the rate of surgeries are increasing, and especially if the patient is young adult and physically active. So there are many modalities in which the surgical management comes, or if with TBW, hook plate, the Bosworth screw fixation, and the modified Femister technique. These are few into practice, but when you look at all of these, they are non-anatomical. They don't provide the full anatomical stability. So with new techniques emerging up, new studies have come, and they say that new biomedical studies have demonstrated that anatomical AC joint reconstruction is far more effective even for the persistent instability cases. So people are more and more moving towards the anatomical reconstruction of the AC joint. So there are, even for the anatomical reconstruction, the newer techniques, they are coming up, and people have started even using the allografts or the synthetic ligaments in place of the regular ligaments that we harvest from the body. So for surgical management, the techniques like you can do it arthroscopically or you do it open. The grafts lies the autograft. the allograft and the synthetic, you can use fiber tapes and the tight ropes. So I present a case here in which we do anatomic ligament sparing technique. So for that, what we need is a tight rope. I usually use Arthrex tight rope and a dog bone button, the ABS button that is provided by Arthrex. And we need a C-arm. So the C-arm, the main thing of the C-arm is the position of the C-arm should be inclined so that it focuses the coracoid in a manner that it comes over a point. So that will give you a proper picture when you drill it. The position, yes, the beach chair position is the best one. So I will show you a little bit of demo what we do first. So if this is a grade 3 dislocation, then what, if it is a grade 3 dislocation, then so you can see we drill the clavicle with a 4 millimeter drill bit. We go to the coracoid, we drill it again. Then after drilling that, we pass a hook suture, and then we pass a tight rope and try to tighten it. We cinch it to fix the joint. This is how it's done. So another demo we will see how we pass those tight ropes and the dog bone button to fix it. How we pass the tight ropes and the dog bone button to fix it. So you can see after drilling the coracoid, we take it from inside and then we fix the dog bone bottom below. Then we flip the flip it the button above, and then we cinch it and tight it, and it comes in the position as we saw in the previous one. So what are the surgical steps? We prepare the patient, we put a skin incision, we do the soft tissue clearance, then we split the deltoid. This is the approach in which we split the deltoid. We mark the coracoid, and right from the coracoid we start dissecting or splitting the deltoid. And while exposing it, we have to keep into consideration that we don't get medial to the coracoid, because the brachial plexus and other structures lie medial to the coracoid. So, and then we drill with a 4 millimeter reamer and we pass the tight rope through the coracoid and stabilize with dog bone button. So this is a small video. So you see, this is our case type 3, and so the incision, if we talk about the incision should, we mark the coracoid, and after marking the coracoid, our incision should be perpendicular to the clavicle and to the coracoid, so in the line, and then we give the incision. And after giving the incision, so you see, then we split the deltoid, and then we find the structures, then we try to find our coracoid. So once you get our coracoid, then we find the coracoid, we get our clavicle, and after that we drill it with a 4 millimeter drill bit. Then we pass again the same tight rope, we pass it from the below as we saw in the demo, and then we flip it over the clavicle, and then we cinch it, and then we fix the clavicle. So this is the final picture of a beautiful reduction that we have achieved. And then finally, after doing this, you can do the repair of the acromioclavicular ligament, whatever is left there, because with the same incision you can approach over there. So I would advise a sling for 3 weeks following this, and pendulum exercise would be started in the very first week, and abduction and RM exercises from the 2nd week follow on. So we get a very good rehabilitation following this. And thank you for your patience for aiding us. This is our small department at our hospital. Thank you so much.
Yeah, Vibhuti, it is a great talk. One few questions will, like, do you find difficulty in reduction? Because what I saw, like, under CM visualization, and you are drilling an unreduced AC joint. So it would it be better, like sometimes we find it difficult in the last minute to reduce it. Is it a good idea to reduce it first and then
No sir, what I actually do is, I first drill the coracoid, because we have already exposed the coracoid. So once I drill the coracoid, I'm very comfortable because I can handle the medial structures, and then I can drill the coracoid. After drilling the coracoid, then I reduce the clavicle, but I don't put any provisional fixation like KOR or anything. And just after, in the same line I drill the clavicle, but with the same 4 millimeter drill bit. Right. And then I pass the loop suture and then fix the dog bone from below and pull it up, and then from the above hole I pull it up. So that doesn't make any problem, sir.
Nice, excellent technique.
Thank you.
No
Thank
questions.
You so much.
And then next talk would be Dr. Gaurav. Subscap repair.
Good evening, last session of the day, and thank you so much to the organizers. So, my dignitaries on the dais as well as in the audience. So, Dr. Pratap actually spoke very nicely about the subscap repair, and he showed a beautiful video, and my technique is not very different from that. So, then I had a discussion with Soumyadeep if I should bring in something slightly different. So I thought, okay, remplissage has not been covered in the entire couple of days. So I'll show you a video of remplissage. I won't bore you much with the theoretical aspects. We'll quickly skim through. So soft tissue and bony components we all know. And the bony component of shoulder instability is the flavor of the day. So that's what is being talked about repeatedly, and we see more and more Latarjes addressing the bony components. Now, the bony component of instability is two things. One is the glenoid bone loss, for which I think we have found an answer in terms of an ICBG or a Latarje or putting bone in there. But the other bony component of instability also needs to be addressed, and this talk is more about that, about the Hill-Sachs lesion. And it all boils down to being able to address, to reduce your failures, and that is where the entire glenoid track concept comes into play. The on track, off track is very much similar to what was earlier engaging, non-engaging, right? I'll try to take you through. Itoi came up with this concept in 2007. Essentially, the area of the glenoid where the head moves as you go from neutral to aber position, that is the glenoid track, in simple words. Okay, now comes mathematical calculations. So what is non-engaging is on track, and what is engaging is off track, right? Many people confuse about track and dimensions and so on and so forth. We'll come to that, we'll try to simplify it. So what's engaging is off track, and you need to address something here, and what's non-engaging is on track, okay? So yeah, Eiji Itoi and Steve Burkhardt have done a lot of work on this. The idea is, if it's engaging, you need to stop the engagement, right? So if it is off track, you need to bring it on track. How? So these are the slides. I'll just summarize them very quickly. You see, this is the attachment of your rotator cuff, okay? And this is the medial most end of your Hill-Sachs. If you draw a line from this attachment of the cuff to the medial most end of the Hill-Sachs, that is called HSI, Hill-Sachs interval, right? That's one calculation you need to do. You need to find out the dia, the best fit dia of the glenoid, and take 83% out of it. Why this capital D minus D is because you are accounting for the attritional bone loss. Account for the attritional bone loss, take 83% of it and compare it to the HSI, Hill-Sachs interval. If the HSI is more, right, then you are in trouble. I hope this bit is clear. If the distance from the insertion of the cuff to the medial most end of the Hill-Sachs lesion, that distance is more than 83% of the best fit dia, you are in trouble. That's off track. You need to do something. Okay. Otherwise, this concept, people find it very difficult to understand. I've made it simple so that it just goes like a breeze. What do you need to do? You need to do something about it. So that is where remplissage comes into play. you need to fill the Hill-Sachs defect with something, and that something is essentially posterior capsular infraspinatus tendon. You need to fill it with something so that it doesn't go and engage, so that it doesn't ruin your Bankart's repair. Now this figure has been changing, right? I don't know whether we should be looking at 25, we should be looking at 20, 15, or this morning I learned it's now gone to 13.5. I don't know. I don't have an answer to this. But there is something called critical bone loss, and that determines whether you're going to put bone or not. So whatever figure you believe in, more than that is critical bone loss, below that is subcritical bone loss. So in a situation with subcritical bone loss and an off track or an engaging Hill-Sachs, you need to do a soft tissue repair with a remplissage. And this is a very simple, straightforward thing to do. So you go in with a posterior portal, right? And then I put in an accessory posterior portal to denude this area. Nowadays, I have slightly changed. This is a 3-year-old video. Nowadays, I have slightly changed it. So I start viewing from the anterosuperior and use my standard posterior portal to do this job. But if you want to do this one, the accessory posterior portal, fair enough, it works very well. So you denude everything, make it raw. And then I used to switch the portal at that time. Once I had made it raw, I would switch the portal. Nowadays, as I said, I started switching first and then using the posterior portal. Once everything is denuded, you put in an anchor. In big size Hill-Sachs, I have sometimes put in 2 anchors, but I'm a bit worried as to, there's a very narrow bridge of bone left between 2 anchors. So you put in your anchor, withdraw your cannula slightly, take it back, and then come in with these penetrating graspers or the bird beaks, whatever you wish to call them. And I put in 2 full mattress stitches. Sometimes you can leave one of the threads right there and take 3 bites, if that has gone through a decent chunk of soft tissue. Otherwise, you take 4 stitches. I usually try to start from the top and then gradually move down and separate the 2 so that you have got a wide footprint of the capsule and infraspinatus filling into the defect, right? Once I shuttle my sutures, then I go on and do my regular Bankart's repair. I'll forward it. There's no point in, This has been dealt with by Dr. Joshi very beautifully. So, yeah, I'm not going to. Forget all this. Once this is done, your 3 Bankart stitches or 4 stitches or 5 stitches are done. Then you pull onto your, these threads, and the entire posterior capsule and infraspinatus will get sucked into this defect. Then comes the last part where you have to tie, and that tying is pretty much, you see it's got stuck the moment you pull it, and that tying has to be done blind. This was the 4 portal technique that I used at that time. The tying has to be done blind, so you have to be very mindful of not mixing your sutures and playing up with the knots. Sliding knots sometimes have got stuck, so I have now come to non-sliding knots for these, right? And unlike what people believe, I have had pace bowlers of cricket go back and have full external rotation, go back to pace bowling, despite having had a Bankart's repair plus a remplissage. So restriction of external rotation in a remplissage is more of a hype thing rather than a reality. It happens maybe 5-7 degrees, that's all right. They can still keep their bowling action. Okay. So this chap is a policeman, the previous guy was into cricket. So people with high level of activity have been able to go ahead with it. So this is just a bit of a summary. Bony and soft tissue components, and the bony component needs to be addressed. That's it. Thank you. This is another chap who's on to some high level. Gym instructor.
Very great,
Thank you.
nice technique, Dr. Gaurav. And I think it's quite very well explained. I don't think anything else to be added on to it. Nice technique. So but I believe in the Sugaya school of thought of fixing, just because of what you said right now, because no external rotation deficits. So I belong to the school of thought where fix all remplaçages. But this is a great technique what you follow. Yeah. Thank you so much.
Thank you.
And last speaker would be Dr. Rosen Shah, arthroscopic slab repair.
Good evening, everyone, and I want to thank Kolkata Arthroscopic and Sports Society for inviting me and giving a chance to speak on this forum. So I will be presenting an arthroscopic slab repair. We all know slab is a superior labral anterior posterior tear, and slab lesion is basically rare. Snyder had found only 6% of his cases had slab tear, and among them only 50% needed surgical treatment. And the patient will present with difficulty in overhead activity. He will be having pain in overhead activity, and on physical examination, active compression test and anterior slide test will be positive, and for further investigating, X-ray will be normal, and this can be even diagnosed by some special ultrasonologist and the investigation of choice is magnetic resonance arthrography, and if many times it may be incidental finding, and at that time surgery is not indicated. Slab lesion can be classified into 7 types. Type 1 is basically degenerative type, which is among 11% of the cases, and in this there will be fraying of the biceps tendon, but there will be intact anchorage of the biceps in the labrum, and the treatment we need will be arthroscopic debridement, and type 2 is the most common, and in type 2 maybe type 2A, B and C. In type 2A there will be anterior detachment of the superior labral lesion, and type B there will be posterior, and type C there will be combined anterior posterior detachment with the anchorage of biceps will be intact, and the treatment of choice in these cases will be reattachment of the biceps and stabilization of the torn superior labral anterior posterior lesion. Type 3 is bucket handles superior labral tear with intact biceps in the labrum, and the treatment recommended is arthroscopy debridement. Type 4 is a bucket handle tear of the superior labrum, and the tear will extend into the biceps tendon, and the treatment indicated is repair or tenodesis of tendon based on the quality of the biceps tendon and other symptoms. And type 5 is the superior labral tear plus slap lesion plus labral tear, and in this stabilization of both labrum and slap lesion should be done, while type 6 has a flap tear in the superior part, so debridement will be the treatment of choice, and finally type 7 is a tear of slap tear extending into the capsule, and repair and stabilization is needed in these type of cases. Congenital variations are also common, so we should not be confused with the sublabral hole such as seen here, and the cord-like middle glenohumeral ligament, which is also called Bufford complex. This can be mistaken. So, and we have to also consider discoid labrum in the diagnosis of slap lesion. So, the goal of the slap repair will be pain relief and full range of motion, return to prior activity, and the goal of the labral repair are stability. So, slap lesion treatment should be avoided repair should be avoided in elderlies who is more than 40 years of age, where there is sublabral holes, tight shoulders and adhesive capsulitis. And tenodesis is preferred when there is rotator cuff pathology and revision surgeries and older athletes. For repairing superior labral lesion, we may give two portal technique, and many times we may need 3 portals. For type 2 slap repair, 2 portals may be sufficient many times. For other lesions, for the repair of the posterior slap, we have to make another port of Wilmington. From port of Wilmington, we can approach posterior superior injuries, and we have to make an additional antero-superolateral portal for superior capsular labral work, which we can see here in the schematic diagram. And anchor placement should be just off the face, and we have to use short and smallest anchor if possible, and knot should be away from the joint. Age more than 40, and alcohol, tobacco use and heavy lifting at works are poor prognostic factor for healing of the slap lesion. Here is a shoulder arthroscopy, first diagnostic, showing rotator interval and the superior labral tear, which have been repaired by the multiple suture anchors. We can see here the superior labral tear, which is type 2, and the glenoid rim is debrided. After debridement of the glenoid labrum, suture anchor has been placed. We can see how nicely the slap tear is repaired here. So my post-op rehabilitation program will be 2 weeks rest in the arm pouch sling, and we'll start shoulder pendulum exercises, and gradually will allow him to return in his daily routine activity of the life. So for concluding, superior labral anterior posterior tears are rare, and we have to use short small anchors if possible, and knot should be off the face, and we have to avoid the repair in the older stiff shoulder and rotator cuff tears, and never operate on the basis of MRI finding only. Thank you.
Great talk. I just want one question was, like we have the anterior limb, that is anterior to the biceps root and posterior to biceps root, if it's a type 2. And do you actually repair the entire thing anterior to posterior, or only posterior, or only anterior? Is there any reasoning behind it? Do you think that there could be external tightness if we tighten it too much?
Yeah. So for better stability, we should repair both from both anterior to the biceps tendon and posterior.
There is actually it's a gray area because it's a difference in school of thought, because there is the Western school believes that it's because of the peel back effect we should do only posterior, but Sugaya school of thought things should be only anterior. And if it is a overhead, for example, it's like a acrobatic person, a gymnast, then you should do both anterior and posterior. So there's a difference in school of thought. So I mentioned.
Thank you.
Thank you so much.
as like everything, every good thing comes to an end. So is this is conference. As I remember that our conference we started in the one of the hotels where we are having our CAS meeting. Our seniors were there, and there we thought that we need to do a conference as the COVID is gradually going down. PowerPoint. So as it was going down, it was gradually we thought about that, then we planned, and then we sat together. Nahi, PowerPoint. So I think till the last moment I can see them. Our Nepal faculties are there. They're there from the day one, and they are still there in the valedictory session as well. Yellow. So would like to thank all the delegates. I think without the delegates, no conference can be successful. So I would like to start by thanking all our delegates. They were there, and they were very supportive and interactive as well. So we really enjoyed their accompaniment. And I think this is on the 24th night when the Raju came, and we actually this was the day before the live surgery. On the 24th night when we were still planning for how the live surgery will be going, and then we had on 24th on 25th actually we at Rajikar Hospital we had 10 live surgeries. Out of them probably 1 or 2 was cancelled. The rest went very nicely, and everybody demonstrated all the live surgeries very nicely. And this is how the Rajikar conferences started on the day of live surgery, and everybody very nicely demonstrated their live surgery, and all the delegates enjoyed till the very evening, and which actually ended till late 7 p.m. or 8 p.m. I think. And then I would like to thank all our mentors of the CAS who actually not only supports us throughout the day, they also give us company in the evening as well. So as you can see, their supports and blessings are always there. I would like to thank the entire CAS team, not only my seniors, my juniors, and everybody. Somodeep, Rajiv, Moinak, everybody. Sanjada is always there with us, and I don't need to mention our seniors' name. I think they are always there, our mentors. Okay. So I think the next big thing is probably our international faculties. I would like to really thank all our Nepal team. They really came here and stayed from the day one to the last time. So I would really like to thank everybody like Amit Joshi, Sudeep Vaidya sir, Ishwar Pradhan sir, Dr. Naveen Karn, Chandra Bahadur Mishra, Dr. Roshan Klavar, everybody. I think we really enjoyed your company. We're looking forward to have you here again and again. All the other Saarc companies were also there. So from Afghanistan, Imal Badak joined online. From I think Bangladesh, Parvez Hassan sir were there here, and they were online. The Aminul Haq Pathan was also there. Amur had joined online. We had the learning from the V. Swarna Kumar from Sri Lanka as well, and the Santiram Dhakal from the Bhutan gave a very nice talk yesterday. We really enjoyed those talks as well. And all our Indian faculties were there. They came in a large number. Appan is probably still here. I think we really enjoyed all the companies of all the international faculties. Sachin Tapaswi, IPS sir, everybody. I think Gurudev Kumar, the Sundar Rajan sir, everybody were here. So they came in large number, and we had a very good learnings from them as well. So everybody was enjoying in the evening as well. Subra sir was also there. Pratik Kumar sir and Pratap Kumar sir and Pratik Gupta sir were also there. Tirth, everybody, and Rajiv is also there. Rajiv is probably omnipresent. And the delegates were also a very good number on day 1 and day 2. So we really enjoyed their company as well. So I would like to thank them also. So, but I think as we all know, that we need to thank the venue partner as well. CII gave us the hall, and they supported us with everything. All the supporting staffs were very nice and cordial. And we all know that without the company's support, it's impossible for any conference to happen. So I would like to really thankful to all the Depuy, Mytech, Striker, Conmed, MJ, Smith and Nephew, and I mean Telefrag Group and everybody. A big thank. Without their support, I think it's impossible to hold this sort of meeting. And I would like to thank the Bonista as well. So they are already still there. So I think lastly I would like to also thank the Rajkumar and his team, Kolkata audiovisual team. They were their flawless things were there from the start to the end. So I would like to thank Rajkumar da. And I would like to end with thanking our conference partner Rueda. I think probably for the last 3 or 4 months, I think we used to go to their office without probably sometimes without intimating them that we are coming for the meeting, and they were always there supporting us. Thank you, Rueda team. Thanks everybody for this conference. I learned a lot, and I hope all the delegates learned quite a few things as well. Thank you.